Very happy to see everyone over here. Full house, I think. So, my name is Deepa. I'm from India Medtronic, and just wanted to introduce the team here. We have quite a few people from Medtronic. There's Satish Nair, country sales manager. There's Jasmeet from the team, Minakshi as well, Amit Dubey and Minesh too. So, from all of us from Medtronic, very warm welcome to everybody sitting over here. We're very proud and happy to welcome you all to Repair Conclave 2024. This was started last year as an initiative, and I think we're very happy to do the second installment as well this time. And looking forward to 2 full days of a lot of learning and with our esteemed faculty as well. So thank you so much for being here, taking out the time as well. And now over to Dr. Jayakumar. If you'd like to probably welcome everybody and then we can start off. Thank you so much.
Good morning, everybody. A hearty welcome to Kottayam, this government medical college, which is situated actually in one of the rural areas of Kerala. Means if you look at Kerala, you cannot say rural area, but it's a single stretch. Yeah. So I'm happy to have all of you here. Especially we have eminent faculties, Dr. Praveen, Dr. N. Barasu, Dr. Amit Chandra, Dr. Lalit Kambur, Dr. Priya. And I think we have very senior as well as middle cadre surgeons from all over India. And I thank Medtronic for organizing such a wonderful event, bringing all the people together so that we will have good interactions and mutual learning. So that this valve repair is something now which we discuss every time, but it is always a continuous process. So it's like every time, every valve, like when we were doing general surgery, our professor used to say, every thyroid is different, every hernia is different. The same way, each and every case is different, and every day we are learning something or other. And of course, these mutual interactions is what makes our surgical fraternity go forward. And there was one of my professors in neurosurgery, Professor Iqbal. He used to take a lot of classes on history of surgery. There is basically, the olden days where such things were not there. People used to travel a lot, observe people, isn't it? That's what we have learned in surgery. And then they sail in the sea, and that time only they will discuss, interact, have new ideas. So the same way, the modern era is bringing us together more frequently in a better way. So definitely this interactions and learnings is going to help us going a lot forward. And I welcome all of you to this academic event, and especially our senior faculties, senior colleagues and dear friends, and the Medtronic team who is organizing it. Just introduction to our institution. This is 2,300 bedded government tertiary care hospitals with almost all specialties and super specialties. And the cardiology block is a separate one. It is also part of the institution. And we are doing almost more than 2,000 cases a year. And it includes the entire spectrum. It's a government sector, you get all the spectrum, like coronaries, valves, congenitals, and aneurysms is a big load on us, and including all the complex aneurysms. And then, say, thoracic work, we are also doing everything, including VADs and major airway resections. And then, say, if you look at, say, 11 o'clock in the night, our residents will be doing a lot of AV fistulas also, because there is one good learning for them to know for the vascular anastomosis part of it. And trauma also we are taking care. But mostly the general surgery side, we help them out. So this is something like the entire spectrum of cardiovascular and thoracic surgery that as a government medical college we are doing. And we have 3 faculties right now, myself, Dr. Nidish and Dr. Vinita, and they are busy with the theatre and organizing the techno college. And we take 4 residents per year, almost always full. So that is in brief about our department. So, and we did say 8 heart transplants also so far, and we are ready for the next thing is lung transplant. We are just getting tuned for that. And we are also always helped by our colleagues from Kerala, because Praveen is always there with us, and then Dr. Jose Chako and Barasu and all these friends, they really help us and guide us in many ways. So I'm happy that all of them are there. So, so we look forward for a fruitful discussions. Today we have planned 4 or 5 cases, depending on how it goes. So thank you and welcome once again. We'll start off. Dr. Ambarish, please.
Good morning, everybody, and welcome here. Believe me, to me, it's a dream come true. It's been a long time I've been planning to watch Dr. Jayakumar operate, and this is the first time I'm getting an opportunity to come here and see what's actually happening. Tomorrow, actually, I'm planning to, with Sir's permission, I'm planning to get into the theatre and see the setup. He's been doing a wonderful job here, and the work he does in this setup is amazing. The numbers he told us is amazing in a public setup. And we will have this very, very informal, nothing formal. The presentations will be filling in the gap in between, and I request all the delegates here to be open for discussions and come up with whatever questions you have. And we want to take this mitral valve repair program to the next level. More and more surgeons should be doing mitral valve repair. And in a country like India, where we have a lot of young population who need valve surgeries, and replacing them with a mechanical valve and sending them away to the community is not a solution. We need to, these people to have a long life, productive life, and the only way to do this is to try and repair most of these valves and keep them off anticoagulation, which is going to help them in long term. And we will gradually get on. Praveen, shall we start with the TE talk or TE talk? Because TE is very, very important when you start a mitral valve repair program. We'll have the anesthetist from Dr. Jayakumar's team to talk on the TE. And then maybe after that, basic assessment of valves. So we have a lot of senior people also here. Let's introduce ourselves, sir. Lalit Kapoor, sir. Shall we just introduce ourselves, everybody? No, everybody knows you, just a formal to start off, sir. Yeah.
Hi. Good morning, everybody. I'm Dr. Kapoor, Lalit Kapoor, and I'm working at Calcutta. I'm the cardiac surgeon at Rabindranath Tagore, NH, Narayana Hridayalaya in Calcutta. We're doing a lot of work there, more than 2,000 cases a year, as you rightly said, and a lot of valve work as well. So, interest in many areas, and I'm happy to be here to help with some information if there is. Thank you.
I'm Dr. Vaibhav Shah. I'm working in Sion Hospital as a lecturer, associate professor. And we are doing routine cases, valve, coronary, and pediatric cases.
I'm Dr. Chaitanya Raut, Associate Professor in Sion Hospital, Mumbai.
I'm Praveen Verma, Professor and Head of the Department of Cardiac Surgery, Amrita Hospital.
Myself, Dr. Tushara, cardiac anesthetist. I'm working at Amrita Hospital.
I'm Dr. Jayakumar, Professor and Head here in the department.
Dr. Anbarisu, I work at Medway Heart Institute, and we do about 500, 600 cases a year, and a significant amount of our valve work is valve repair. Thank you.
Good morning, I'm Priyank. But I head the department at Sal Hospital in Ahmedabad. Just like Dr. Anwar, so I do about 500 to 600 surgeries a year. And yeah, I mean, in Gujarat we have a lot of scheme work, PMJY and stuff. So we get a lot of patients from rural for the repair, particularly at the centers where we do UN Mehta's. There are a few centers we do it.
Hi, I am Dr. Amit Chandra from Vedanta, Medicity, Gurgaon. We are doing about 4,000 cases overall every year, of which a significant amount of work is valve repairs, aortic surgeries, sometimes transplants, and everything else is being done. It's a pleasure to be here, and I thank organizers for calling me here.
Good morning. My name is Dr. Nitin Gundre. I am a consultant cardiac surgeon working in multiple hospitals in Mumbai.
Good morning, everybody. I am Dr. Rajkumar Yadav from SMS Medical College Hospital, Jaipur. Our is a very old hospital from 1947. It is like Dr. Jayakumar told that they are catering every kind of case. Similarly, in our hospital also, right from coronary transplant to the AV fistula, chest trauma, and even the vascular, peripheral vascular diseases are also being taken care of. And the main work in the open heart is still the valve work, and mitral valve is the most common. We are all versed with the replacement techniques, but this repair work is still. Last time Dr. Chandra came to our Jaipur and he performed some of valve operation. We are also doing, but the results are not that promising. Thank you.
Hello, I am Dr. Sunil Dikshit, professor in SMS College, along with the sir, the same. Sir has told.
I am Dr. Ashar Nayagam from NIMS Medicity, Trivandrum.
Dr. Sivashankaran, an assistant professor from Government Medical College, government setup in Chennai.
Good morning, myself Dr. Shweta Deshpande. I am additional professor at Nayar Hospital, Government Medical College in Mumbai.
I am Dr. Jashwant, senior consultant, Miyot Hospital, Chennai.
Good morning, faculty, colleagues and seniors. I am Dr. Ajay Pandey. I am a consultant working in Jagjeevan Ram Railway Hospital in Mumbai.
Hello, I am Dr. Nilesh Wadke, consultant, Seven Hills Hospital, Mumbai.
Good morning, everyone. I am Dr. Saravana Krishna Raja, associate professor from Chennai Government Hospital in King Institute, doing predominant works in cardiac and thoracic.
Good morning. I am Dr. Praveen Jayakumar, working in Medway Heart Institute, Chennai.
I am Dr. Jaswin, working in Triple Hospital, Chennai.
Good morning, I am Dr. Soumya. I am working in Triple M Hospital, Chennai.
Good morning, I am Dr. Azhar from Kolkata. I work with Dr. Lalit Kapoor, sir.
Good morning, I am Dr. Ram Krishna Dev, additional professor, Nizam's Institute of Medical Sciences, Hyderabad.
I am Dr. Gopal, sir, associate professor, cardiothoracic surgery, Nizam's.
I am Dr. Kaladar from Nizam's, Hyderabad.
Good morning, I am Dr. Rajesh. I am Amrita Hospital, Kochi.
Morning, everyone. I am Dr. Praveen, assistant professor in CT surgery from Nizam's, Hyderabad.
Good morning, I am Dr. Praveen Dohale, cardiac anesthetist working in Mumbai.
Good morning, everyone. I am Dr. Vikram, consultant cardiac surgeon from Narayana Hrudayalaya, Shivamogga. I have started my independent practice just 7 months back, almost completing 100 cases now. So very happy to be at this platform. Thank you.
Good morning, everyone. I am Dr. Nishit Udupi, consultant cardiothoracic surgeon, Andhra Pradesh, Kurnool. We are doing almost 350 to 400 cases per year.
Good morning, everybody. I am Dr. Rakesh Sharma from SOA University, Bhubaneswar. I am consultant cardiac surgeon and I am working in a medical college setup.
Hello, good morning everyone. I am Dr. Swapnil Fuladi. I work in Anand, Gujarat. I am doing mainly adult cardiac work there. Thank you.
Good morning all. I am Dr. Parth Bharat Solanki. I am a consultant cardiovascular thoracic surgeon in Vadodara. I am an associate professor and head of department Parul Sivasram Hospital. As well as I am associated with multiple corporate hospitals in Vadodara. We do around 350-400 cases overall. And I have done almost around 150 plus MICS surgeries and about more than 100 mid-caps. But my experience with mitral repair is quite less. Thank you.
Good morning. I'm Dr. Yashankar Marla from Mangalore. I'm in a medical college attached corporate side. We do around 400 cases, 450 cases. We do valve repairs, but I wanted to do learn something more than what we do regularly. We do some repair, which I think we wanted to take it to the next level. Thank you.
Good morning. I am Dr. Tejasvi Marla. I am a consultant cardiac surgeon in Apollo Hospital, Chennai.
Good morning, I am Dr. Kunal. I was a product of this department only, second batch. Dr. Jayakumar is a father figure to me. And I am working presently as Assistant Director, Indira Gandhi Institute of Cardiology in Patna. I was ex-assistant professor in AIIMS Patna and also associated with a few private corporate and trust hospitals.
I am Dr. Kumar Aditya, Assistant Director, Indira Gandhi Institute of Cardiology, Patna. We both are working at the same place.
Dr. Neeraj Sharma from Santokba Durlabji Hospital, Jaipur. We routinely doing adult cardiac, congenital, vascular, thoracic, all type of cases, including minimal invasive surgery and repair also. Last year we started our mitral valve repair program after Dr. Amit Chandra done a CME at our center, and we are doing routinely around 10 to 12 cases per year. Thank you.
Good morning, everyone. I'm Dr. Amita Yadav, working as a cardiac consultant, National Heart Institute, Delhi. We are doing routinely adult and pediatric, but yes, we want to work on repairs also. So definitely this is going to help us a lot. Thank you.
So thank you all, and thank you for coming over. I think the next session, Dr. Praveen and Anparasu will moderate, and Dr. Manjusha is our cardiac anesthesiologist. We have a team of 4, Dr. Manjusha, and then Dr. Thomas is there. He is my classmate also for the MBBS, and he's a cardiac anesthesiologist. Then 2 more are there. So I think we'll start off. Please.
Good morning, respected faculty and dear delegates. Welcome to Kottayam, and hope this workshop will be add to your knowledge on mitral valve repairs. So what I felt is that like from our previous workshop, the preoperative assessment and intraoperative assessment will get a detailed, we'll get a lot of time to spend during the workshop. So post-repair assessment is one area we should be focusing on, because finally when you go back you will be more confident about doing repairs. But finally, what is a good repair? That is very important. So as per our current guidelines, a mitral valve repair should have a less than 95% reoperation rate, and you should have a less than 1% mortality. So we should be doing a good job in the first place. So I will be just talking about intraoperative TE for post-repair assessment. So because we will be having further talks on the topic during the live case as well as during our session. Just always, it's like whenever you start for a mitral valve repair, you have to pay homage to Carpentier and his golden rules. So finally, we have to correct the leaflet dysfunction. We have to have an adequate surface area for leaflet coaptation, and you have to restore the physiological annular geometry. So those are the goals for a mitral valve repair. So when you're going about it, just because the first step has to be right if everything has to go well. So you have to be systematic about it. So when you're doing the goal of the whole intraoperative assessment, whether it is on echo and whether it is on surgical assessment, I feel both are complementary to each other. So you have to understand the mechanism of mitral regurgitation using an imaging as well as the valve analysis. So we have to decide on what is the appropriate repair technique based on what is the culprit lesion. And assessment of repair quality we have to do with pressurized saline testing, that's done on the surgical side, and when we come off we will do it on echocardiography. So the difference between the two is that saline testing it's a non-physiological state, heart is arrested, flaccid. So echocardiography is always, we are doing it on in a real-time dynamic assessment. So it is all, our intraoperative TE is always a time-limited assessment, because we don't have time for a very detailed examination, but it has to be focused on specific points. And one thing we have to remember is always that it is a very dynamic assessment. So the periods which you're assessing when you're immediately coming off bypass is one state. When you've come off bypass, ideally you should be assessing the mitral valve finally 15 to 20 minutes after you have come off bypass, once your hemodynamics is stable. That is very important. And ideally you should be doing it before chest closure also. So this is just to familiarize everybody with the mid-esophageal TE views. So we have the 5-chamber, 4-chamber, 2-chamber, and the long axis views. But the views which I will prefer will be the 120 degree, that is aortic valve long axis view, and the commissural view, because those are the more reliable cuts which you get. The 4-chamber view and 2-chamber view may be extending to a lot of other planes. So this is the Okay. So this is a mid-esophageal 4-chamber view which we have got at 0 degrees, but at some point you can see that a small portion of the aortic valve is also coming. Usually this view is going to be A2 and P2, and in this case you can straight away see that there is a prolapse of the posterior segment. The leaflet which is close to the aortic valve is always the anterior leaflet. It's easy to remember it that way. So once you advance to 60 degrees, you have the commissural view. So in the commissural view, we can always try to read the image from the right side of the screen to the left side. So you can see that close to the appendage, you will have the P1. Next to that, you can see the P2 and A2, and the most towards the right, left side of the screen will be P3. And this is a classic cobra head sign where you can see the P2 is prolapsing behind the A2. So then we are coming to the two-chamber mid-esophageal two-chamber view. So as you can see in this view, it's not a perfect orthogonal cutting plane. So you'll be seeing a portion of P3, you'll be seeing a portion of P2, and the anterior leaflet you'll be seeing some part of A1 and A2. You can always rotate the probe and decide which view you're seeing. So this is a aortic valve long axis view. In this view, whichever segment you're seeing, if you're seeing the aortic valve, it is definitely A2, and you can see the P2. And even without measuring, we can see that the P2 is a little long, and there is a flail segment also. So advantage of 3D views is that it gives us, it's corresponding to the surgeon's view. So other than those images which I showed you, it's easy to communicate. What I felt is that even if you're a newcomer to echo, it's easy to identify these views. So here you can easily see that there is a P2 flail. Sometimes if the atrial view is not clear, I've always preferred to have a ventricular view, because here you can see the line of coaptation very well. So once we have decided, okay, this patient is having a P2 prolapse, so we have to decide what are the predictors for a failed mitral valve. More than a failed repair, probably what is going to be a difficult repair. So suppose you're having an organic MR, if you have a severe central jet, if the annulus is dilated more than 50 millimeters, if the lesion is in 3 or more segments, again that means you may have to employ multiple techniques. When compared to the posterior leaflet, lesions of the anterior leaflet may be a little more difficult. Mitral annular calcium is something which you should definitely be looking for, because it might be difficult, it may cause problems. Another important thing which should be stressed on is inadequate leaflet tissue. If the leaflet tissue is less, then it's a relatively difficult repair. Opposite dysfunction means that you have, sometimes it might not be just one pathology. There may be a prolapse in one segment and there may be restriction in another segment. So when you have a dual lesion, it again becomes a little difficult. So today's talk is mostly on organic, but I will just add a few words on functional MR. So functional MR, as we know, is because the leaflet is normal, but it is because of the LV asymmetry which is causing the functional MR. In those cases, when the valve is pulled too much into the LV, you may not be able to bring it up. So tenting area more than 2.5, posterolateral angle more than 45. If the LV is very dilated and that symmetry is distorted, so that causes a widening of the interpapillary distance. End diastolic dimensions more than 65, end systolic more than 51. So we have the sphericity index. So as the heart becomes more globular, it might be a little more difficult to get a good repair. So the bottom line is again a good sustainable repair. So coming to our patient, so this was some of the measurements we take. You can see that when I'm highlighting, the posterior leaflet is quite long. PML length more than 16 is a marker for, so we are worried about one complication. So we can see that the PML length is 23. When we are measuring the septum, it's a little sigmoid, and just close to the aortic valve, the septal distance in diastole is 17 millimeters. So what's the problem? So we have these measurements are very important for predicting a very important postoperative complication. So that is SAM. So we can see that we have to measure the ratio of the heights of the anterior to the posterior leaflet. Anything which brings a coaptation anteriorly can predispose the patient to SAM. So in this patient, we have a ALPL ratio of 0.8. So in spite of having a relatively okay C-sub distance of around 2.5. So what are the echo predictors of SAM, which we have to remember? If the posterior leaflet is very tall, more than 15, ALPL height is less 1.3 or less. If the C-sep distance is less than 25 millimeters, if the basal interventricular septum is hypertrophied, which may be, especially in older patients who are hypertensive, we have to be very careful with this. And if there is any displacement of the papillary muscles, that mostly happens in HOCM and other conditions. And another important caveat is when you have a small hyperkinetic left ventricle, this can happen in patients with severe AS. Coming for AVR also, we had 1 or 2 cases who developed SAM posteriorly, postoperatively. So, in this patient, so what we did is that we put a 30 mm Edwards CE physio ring was done, a triangular resection of P2 was done, and a caudal shortening was also done. Because there was a large segment of prolapse, some medial commissural plication was done. But post-repair, this is the image you're seeing. So this is a textbook appearance of SAM. We can see that during systole, part of the coaptation is anterior, and the AML is pulled into the LVOT so that you can see a flow turbulence in the LVOT. So you can see that this is the marker is not coming. Okay. So we can see that there is, you can see that during systole that there is flow turbulence in the LVOT, and this is a textbook appearance of a SAM when you take an LVOT VTA. You can see that it is a dagger-shaped gradient with a late systolic peaking. Maximum velocity is 56. So when you see this, so how do you assess? So post-repair SAM, the first thing you have to do is that if there is, you have to give volume. Volume expansion is important. If there is any inotrope going on, you have to stop it. And goals are you have to have a heart rate around 90, mean PP should be around 80 to 90. If you're not achieving it with these two measures, the second step will be to add a beta blocker, or you can increase afterload by adding a vasopressor. In spite of all these measures, if the peak gradient is still more than 50 and you're having significant mitral regurgitation, you have to think about whether should you go back and revise. So some of the techniques which will help is edge-to-edge repair. You can shorten the height of the posterior leaflet, do a sliding plasty, or put a bigger ring. So for our patient, this is the post-bypass image. You can see that the leaflet is, AML is now well away from the LVOT. PML height has been reduced, and we can see that there is no turbulence in the LVOT. And when you see the LVOT velocity has come down to 3. So the thing is, one issues which can be sorted out in the OT, it is best to sort it out in the OT. Otherwise, you will be keeping on, it will always be behind you. And it's easier to sort it now than to go back to the ICU, escalate supports, give a lot of volume and weight. So another important assessment for the valve is we have to make sure that there is no stenosis. So the criteria is your mitral valve area has to be more than 1.8 centimeter square. The mean gradient has to be less than 6. It's variable. Some people, ideally 5, some people say 6, but more than 7 definitely has a less, patients have a less poor quality of life, and more than that, they'll be prone to atrial fibrillation also. So 3D views of the mitral valve are very useful because I found it's very useful for communicating. So rather than looking for multiple views, at least in one go, you can say whether all segments are okay, whether there is any residual MR or not, or if there is any paravalvular leak, this view is good to communicate exactly where the leak is. So the second major issue which can have is unfavorable circumflex anatomy, so that there is a RWMA and circumflex injury. So this happens usually if there is a repeat mitral valve surgery. Especially important is posterior mitral annular calcium, or if there is a very extensive posterior leaflet destruction. And for other patients, you have to, ideally we can measure the distance of the circumflex to the mitral annulus. If that is less than 3 millimeters, those patients are at high risk for having an injury to the circumflex. So angiographic criteria is usually in patients, it happens in patients who have a left dominant or a co-dominant coronary system, or if the circumflex course is anomalous. Another issue is sometimes if the patient's coronaries are very large, when you're taking a suture, sometimes it can cause distortion of the coronary course and cause aliasing. So this is one of the papers which analyzed the circumflex artery in relation to the mitral valve using CT. And they found that the most high-risk zone was close to P1 and that lateral commissure, that is zone 1. So in those places where the patients in the zone 1, if the circumflex is less than 3 millimeters, they are at a very high risk for developing a circumflex injury post-op. If it is more than 5 millimeters, it's usually a safe zone. So how can echo help you? So there are multiple measures where you can do. 3D is definitely useful. So you can take the circumflex, you can see it in the en-face view as well as in the short axis view, and you can measure. So parallax errors are avoided in 3D. This is one of the seminal articles on echo identification of iatrogenic injury, because the important caveat is if you have a circumflex injury, the time from circumflex injury happening and the timing of intervention will determine how much of the LV you will be able to save. So you can see that I'll be showing you that image in our cases also, how the left main is coming and branching into the circumflex and the LAD. Quantification of severe MR is it's easier because you have to see the valve morphology, color flow, in the OT again, once again we are in a time limited place and there are hemodynamic changes. So I don't know how much of the quantitative measurements will happen. And one thing you have to remember about echo is that echo, the numbers just don't follow the numbers, because echo is based on a lot of, depends on the hemodynamics, it depends on the physics, it depends on what's happening at that time. So if you have a doubt regarding severity, don't rely on one number, take multiple measurements and take multiple types of measurements and multiple measures of the same thing. So vena contracta is which is repeatable and easier to do. If the vena contracta width is more than 7, definitely there is a severe MR. Or pulmonary vein systolic flow reversal. Those are the things which we commonly do. In case there is a doubt, what I personally prefer is to do a 3D vena contracta area, which has less geometric assumptions. So the next, I've added this slide because it is severe MR we'll be able to see easily, but most of the time the confusion comes when you have a less than severe MR jet, mild to moderate. So when should you go back for that, or should you just accept it? So mild MR is always if the vena contracta width is less than 0.3. If there is a doubt, you can take the vena contracta area. You have to see the location of the jet, and you have to correlate it with where is the jet and why is that jet happening. That is more important than quantification per se. And always it depends on the patient's condition. Is it worth going back, and will you be able to correct it or not? So this is an excellent article from Amrita by the late Dr. Reshmi Lisa. So we had, so they have a systematic approach to mitral regurgitation after mitral valve repair. So the first step is to ascertain whether is the MR significant. Very trivial MR jets on TE usually they won't even be seen on the post-operative transthoracic images mostly when we follow up these patients. So if the MR is a little more significant, you have to decide on, so what is the next step? So next you have to think about, since it's a repair, so how is the leaflet motion? If the leaflet motion is normal, you have to think, wow, what is the cause of the jet? If there is a residual cleft or a perforation, it is best to go back and revise it, because that is not going to go back. If it is due to because of suppose it is a coaptation length issue, then you have to think about whether then it depends on the patient. Should you accept, if it's a small jet, should you be accepting it? Should you go back and revise? Or if you have to, or you have to think of a mitral valve replacement in this patient. Suppose leaflet motion is abnormal and you have a residual prolapse, it is always better to go back and revise. However, if it is because of tethering, this usually happens in type functional MR. So again, you have to think, will the patient be tolerating a second bypass run? Are you going to make a big difference for that moderate jet? So again, when we talk about mitral leaflet motion, echocardiography is like a language, so we have to be speaking the same terms. So billowing is when the body of the leaflet is above the annular plane, but the leaflet tips are below. If the leaflet tip is above the annular plane, we call it a leaflet prolapse. So but the tip will be facing towards the ventricular apex. If there is a flail, that means it's usually because of a caudal rupture. The leaflet tip is above into the LA and the tip is facing into the LA. So that's when we say there is a flail segment. So again, this is from that same article. You have a post-repair decision pathway, because the most common question which everybody gets is a repair enough? So it is always better to go for a systematic approach. You have to ensure that there is no MR. You have to have an adequate coaptation length. So coaptation length, there are multiple articles having multiple cutoffs, but the definite consensus is if your coaptation length is less than 5 millimeters, your repair is not going to last. Ideally, you need it between 6 to 8 millimeters. So is more the merrier if you ask. If it's an excessive coaptation length, sometimes the AML tip will be close to the LVOT, and again you may be prone for SAM. Peak mitral gradient, mean gradient should be ideally less than 5 or 6. Sometimes if you are examining gradients, you have to take it in the context of hemodynamics. If the patient is having a high cardiac output state, if the patient is vasodilated, if the heart rate is high, again, sometimes your gradients may be falsely high. You should check for SAM. SAM has to be either a nil or it has to be mild. The cutoff is, if the peak gradient is less than 50 and there is trivial MR, you can accept. Systolic function is very important. You have to rule out RWMAs or any unanticipated worsening of LV function, because some patients with MR always, as we know, the ejection fraction is always, it's an overestimation of ventricular function. So once a repair is done and that MR is cut off, that's when the LV's, the true nature comes out. So if all the 4 criteria are met, yes, it's a very good repair. If any of the issues are there, if there is a residual MR, we have to follow our previous chart. If the gradients are more persistently high after correcting hemodynamics, maybe you have to think of re-repair, especially if the mean gradient is more than 7. Next is for SAM. If the LVOT gradient is less than 50 and it's less than mild MR, we can accept it. If it is more than 50 and you are definitely seeing a SAM in the table, probably you should be thinking whether you should revise or whether you can, other measures are starting amiodarone, but that's mostly in the post-op. Assessment of ventricular function, definitely wall motion abnormality, LV dysfunction and circumflex. So if there is a circumflex injury, again, the best space to detect circumflex injury is in the OR so that we can correct it as early as possible. Sometimes it may be okay, and when you're closing the chest and comes into the ICU, you may have a late presentation. That happens when there is no total occlusion, but there's a partial occlusion. Some flow is there and some is not there. If possible, you have to, if you can shift to the cath lab and have a definitive diagnosis. Some cases you may not get time for that, and maybe we should just go back. So this is just to summarize. Intraoperative echo, it's always good to have in the pre-bypass and post-bypass, discuss the imaging as a team, that is from the echocardiographer's part as well as from the surgical part, because we have to, in common, we have to understand what is the pathology, what are we going to do. Only then we will understand what happened to the valve after repair, because once you have repaired the valve, once again, it's a new valve, so it may have new lesions. What is the impact of new findings on a surgical plan? So always be focused, and then you can move to the comprehensive examination. So even if, like, conversion is a very difficult topic in the OT, but conversations about it should not be difficult. Thank you.
Thank you. Thank you, Dr. Manjusha. It's an excellent presentation. Anybody who wants to start a mitral valve repair program should make sure that their anesthetist are well versed with TE. And by the time the anesthetist gives you an idea, and by the time you scrub it and start get into the case, you have a fair idea of what is to be done. In fact, our anesthetist has gone to the extent of even telling us that this has to be done. This area needs a neocord, this area has to be resected. That is the level of experience our anesthetists have. So make sure that anesthetists are comfortable and get trained with TE. Thank you once again, Dr. Manjusha. Excellent presentation.
Thank you for your patient listening.
About the residual MR, rather than quantifying the MR it's very difficult to quantify the residual MR because many of the times it may be eccentric and you may have multiple jets. It's more important that you should not, accept anything more than trivial.
Yes.
If there is something more than trivial, we have a very good follow-up of our patients. We have found that majority of the time, if we accept even a mild MR at the time of discharge or at 3 months of follow-up, patients will come back with a recurrence of mitral regurgitation. And in our experience, we found that there are two causes of residual significant MR that happens. One is there is a residual prolapse.
Yes.
That usually, so any eccentric mitral regurgitation you find in OR, there is usually a problem. Second is the cleft. So we may think that the cleft, many times Tushara will say that cleft is there, and we are reluctant to go back saying that's a cleft. But many times we found that the clefts actually open up, especially when we do the resection. So anything above trivial, I think we'll have to, rather than looking at all the values.
Yes, numbers, you shouldn't be misled by numbers.
Yeah, rather than looking at the numbers, it is anything more than trivial, you'll have to really, really look at it. Second thing is that the mitral stenosis, it may be a little more than what we really think. Because even if we have a gradient of 5, we find that patients who have a gradient of more than 5 postoperatively, they actually have some restrictions in their
yes, functional classes,
functional classification. And we found that one of the main reason is using an undersized ring. A small sized ring, if you use, many of the time patients will have some residual obstruction, and this one. Then another thing which I wanted to tell you is when you have a residual MR, I think that is where the anesthesia I think plays a very role, and the 3D is very, very important, because if you are not able to communicate what is the real problem, it is very, very difficult for us to go back and re-repair, and we will muck up the valve more. So I think
so
you
that's
can.
A very important point which Sir raised. When you're going back, it's a very important decision. Are you going to do anything differently? So I've always felt this, like, because where first go, you have done a good job, and then still you've done what you can, and there is a residual MR. So that means maybe we have missed something.
Yeah.
So we have to identify what is the problem, then only we can go back. Yeah. So, and if it's a major jet, question of whether to again repair or replace depends on the patient's LV, and sometimes the problem is that already the pump time is prolonged, and then everybody's a little.
Yeah, I think this pump time and LV dysfunction and all those things are really? I think overestimated. Okay. I think most of the patients will tolerate the second or even a third run.
Yeah,
it's that you just don't clamp immediately. You allow the heart to recover for some time on pump, and then again cross clamp, and usually nothing will happen. Maybe a patient become a little edematous, but I don't think it is a big problem. I think, and third thing, I think this circumflex injury is, it may be more common than what we think. Many of these LV dysfunctions, which we think the post-operatively afterload mismatch and all those things, maybe something to do with the circumflex injury. It is more underestimated than.
Especially because younger patients are coming, they're not getting a coronary angiogram before they're coming for the surgery also. Yeah. And again, this issue is that if there is a distortion, there is some flow, but it is not enough flow. So it might be difficult to pick it up.
Thank you. It was a nice talk.
Thank you, madam.
And just when Sir was mentioning, I remember something that the gradients, actually post-op gradients. Now, mitral annular calcification is a very difficult subset. So when you have, they say that if you have a preoperative gradient of 3, mean gradient of 3, you should try not to repair those valves. So because invariably the gradients are going to worsen. That's somewhere I read about this.
Again, annular calcium is definitely a predictor for a challenging mitral repair. So if you're going to start off with a mitral repair, probably not the case with MAC.
I know it's very important to have a echocardiographer like Manjusha or many of the people sitting here. But when we look at the way we started, that was in 2008, I think. We started it without any echo on table. There was no TE, nothing. So it was preoperatively we go to the cardiologist, see the echo in detail, assess transthoracic echo, and then come to the theater, do it. And almost 99% your saline test is very accurate. And if you start assessing the cooptation and also, because I see many people from government sector is there. I don't know how many of you have access to TE.
Most of you, I think. Now so it's important to have tea. It makes a lot of difference. And then second thing is like as a surgeon, like no, we may not be very familiar with like I'm still unable to correlate between say all the cuts that Manjusha has shown to whatever we see on the table. So if you look at the mid-esophageal transesophageal views from 0 to the 120 degree as it sweeps around, if you just know what I started correlating it with the anatomy I see in the thorax, like, but I failed it. Now I just have that picture in my mind. Okay, 0 to this is what it is. Okay, I just picturized it and keeping it in mind. So as surgeons, we may not be able to like correlate between the anatomy to the echo finding and the pictures with you. If you can, that's good. So so the things which I look like, one is whether this is repairable or not. Probably if you get a good anterior mitral leaflet, most of the time I can say I will be able to repair it. Even if it is prolapsing, even if there is perforation, and if the AML is good enough, most of the time we will be able to repair it. And PML, most of the time, like even if something is there, we may be able to manage. And lot of calcification, like diffuse rheumatic, it may be difficult. And then say we have to see. Suppose you look at the pathology of it. You have to see whether it's a fibroelastic disease or towards the other spectrum of say the Barlow's spectrum. So if it is a fibroelastic level of disease, you should the basic thing in your mind will be you don't have enough tissue to play around. You should be very, very careful, because last repair with the adverse people, the first case I put PML, EC, and then actually Praveen was suggesting, why don't you put this? I said it's only a small resection I'm doing, but it took some time for us to fix it. So whenever you don't have enough tissue, better not to resect, better to go for, your bias will be to preserve as much tissue as possible. But when you have a lot of things, you can play around. And the other thing is, like when you are thinking about the repair part, next thing will come to my mind is the mitral annular dissection. Many times you see so many jets around here, and if you just fix the annulus, it is going to take it off. So there is something looks very, very, very difficult, but the moment you see the annular dissection, you are happy that most of the time it is going to be a simple thing. And then rheumatic is a different category. I think the expert is there, so we will discuss later about that. So that is how I look at the TE findings. And then, so the next question is, am I going to leave behind a lot of stenosis? Am I going to leave behind some regurgitation? Okay, and am I going to land up with circumflex injury? Am I going to land up with SAM? These are the things that we are going to face, isn't it? Once you have assessed the LV is good, like postoperative LV problem is a major thing, suppose preoperative LV dysfunction is there. So, so residual stenosis, more like with a rheumatic repair or a fibroelastic disease, if you land up with a lot of commissural sutures and then a lot of, say, additional sutures coming in between. And the residual regurgitation, you have to, like, you may generate new disease, it may become a new disease, like opening up a cleft or something like that. So we have to be careful with that. So am I going to have a regurgitation or stenosis? That is one thing. Second thing, circumflex. If somebody like Manjusha is there, you will be able to see how far is the circumflex. And one thing, keep this in mind always. Sometimes otherwise, when you are coming off some arrhythmia, sometimes you think it's going to settle down. Post-op, you are going to have a problem. Or in the post-op itself, you get some arrhythmia, some STT changes, don't hesitate to get a shoot. Because it may not be no flow, it may be inadequate flow. There were instances where we had just the coronary just got kinked, and then the patient had arrhythmias and we had to take back, got an angio and took back and put a graft, and then everything settled. So circumflex is a very, very important thing. SAM, all of us are well versed with the different problems of SAM, and say the pushing the cooptation anteriorly is going to be the most important problem, and a narrow LVOT, and you have to be careful. Like we have to anticipate SAM from the echo, and then if you do that, that will be good. So that is how the thinking process goes for a surgeon. That's what I feel. No? Anything else to add in that? Thank you.
How much correlation do you give to the transthoracic and the... So, means all of us see, we don't have the facility of, in a Western situation, anybody for a mitral repair undergoes a TE, then only they are posted for a mitral repair in the list. We don't have the luxury of doing a TE in all the patients preoperatively. So we just correlate with just the transthoracic and the trans-esophageal echo. Personally, I feel a transthoracic just gives you a guide of it, whether it's an AML prolapse or PML prolapse, and gives you a guide. But the detailed anatomy given by the anesthetist is more important. How much weightage do you give to the transthoracic? Do you think it gives you an idea of the commissural prolapses, or it just gives you an idea of whether it's an AML or a PML or a bilateral prolapse?
I don't usually go very much with the transthoracic, just to say whether it's possibly repairable or needs a replacement. That's the only thing I will think. No, the gross anatomy, nothing into details.
No, I think transthoracic echo is mostly for the decision to operate, because the severity of the MR, and it also gives some idea about whether it's a myxomatous valve or rheumatic valve. One thing which I found that in transthoracic echo, it gives the posterior annular calcium much better than transesophageal. So that is one thing which I carefully look at. And because I have to explain to the patient that if the calcification is there, first of all, I am not very comfortable operating these patients. I am very worried about this one. So if you find extensive posterior mitral calcification, that's something which is, so basically it is for a decision making, not for the surgical technique.
Yes, details of the valve are usually better appreciated in TE, but details of the LV and other structures, you will get it on the...
Now I want to ask you why transvaginal echo does not give the calcification as better than, much better than transthoracic. I find transthoracic much easier to identify the posterior annular calcium. Anything?
Usually because that what happens is in transthoracic, it's easy to get the short axis view, so you get that whole thing very easy. You can see the subvalvular structures. TE is coming from the esophagus into the LA, so sometimes if there is extensive calcium, there is a lot of dropout in those areas, and small areas sometimes you might be missing, and most of the end phase view of the valve, you will get it only in the transgastric view, so that is subjective among patients. In those cases, always this is better. Ultimately, for calcium, is there a role for CT? Because echo might not distinguish between fibrosis and calcium. Sometimes that's what we're seeing.
Yeah, CT may be useful, but how many times?
How many times are we doing?
So most of the posterior mitral annular calcium is actually not uncommon in myxomatous disease, especially in like mitral annular disjunction and young patients. So that is something which I carefully look at in transthoracic echo in all patients.
Completion now. This coming up to mitral annular calcification, usually it's in the elderly population. Makes a matter, but that means I may correct me if I'm wrong. With the amount of calcification you see in a younger patient is much less rather than an elderly patient. RAO caudal view of during the angiogram beautifully shows the amount of calcium. If the calcium is excessive in that view, we usually go for a CT, and our radiologist gives a beautiful reconstruction and opinion on how far it is from the coronary artery, how far is it from the external epicardial surface of the valve, and he beautifully gives an image and reconstructed it.
I just wanted to make two comments. One about this transthoracic versus transesophageal is that, speaking like a statistician, I will have a negative predictive value. I will decide that I am not repairing this valve by transthoracic. If I am if it looks repairable, or if I want to do something in the terms of repair, then maybe then we do TE and decide what we will do, if still or whatever. And second, to add on to Dr. Praveen's, this is that going on bypass 2 times, 3 times, yes, it's not very dangerous, but what happens is that usually everybody starts panicking that, oh, we are on CPB for say 90 minutes, 100 minutes, 200, so at the time that anxiety gets the better of you and you want to clamp faster, you want to, quickly run the cardioplegia, you want to arrest faster. On the contrary, if you relax the heart, everybody relaxes, takes their time, manages it better, gives, speak with the perfusionist, are you okay, do you want to add blood, do you want to do something, do you want to filter, all these things. Probably the conduct of the CPB and the outcome may be a little better.
And also, one thing to remember, that second CPB is always very short. You will find, if you have a cleft, it will take just one stitch to close it off. So second PP should not be feared of. Another thing, transthoracic versus transesophageal, what I have found that my cardiologist friends, they show me very good subvalvular apparatus in rheumatic patients by transthoracic rather than transesophageal. So I find use of transthoracic in rheumatic patients.
Thank you, everybody. Thank you.
Thank you very much.
So most of the time, the mitral stenosis, at least in our experience, is when we are using an undersized valve. Like if you use any ring in degenerative valve, I don't do much rheumatic repairs because it's hardly there in our practice. If you use any ring below 30, we find that patients can have some postoperative gradient, and they may be okay doing routine activities, but when they are not okay when they do climbing stairs and all, they will have some shortness of breath. So I think the ring size, what happens is, I think I will show that in my complications of mitral valve repair, I will show that. Actually not. See, if you look at the ring size previously, see, we have also evolved with our experience. And one of our best learning experience was when Dr. Patrick Perrier came in 2019. That's why when we had actually a big jump in our understanding of this one. So he says that he hardly uses any ring below 34. And most of the time in West, they even use a ring of 40. After that, I think we also started not putting, I think we hardly put anything now. What do you think, Tushara? Anything below 30? Yeah.
And
you undersize it when measuring the ring, you size it exactly or you undersize it or oversize it, and the effect of it.
We use actually the Physio 2 rings now. After that we changed to, from 2019 we changed to Physio 2 ring. So if you look at that ring, it is it changes its shape from a D-shaped, as you go up high, it becomes more and more oval kind of a shape thing. So that is one of the, I think, sir, I will show that when I come to that complications of mitral valve repair. I have some slides on that.
It's a wrong concept to think that the smaller the ring, the better the coaptation. It is actually other way around. And especially in a degenerative, this gradient issue is more of rheumatic repair. We don't do much of rheumatic repair. The results of rheumatic repair are not good, number one. Number two, the incidence of fresh rheumatic diseases needing a repair in this part of the country has come down drastically. The ones, the few rheumatics we get are the burnt out ones who have mixed lesions or more stenotic lesions with a lot of calcium, which we end up replacement. It's a misconception to think that this, you undersize a ring, you get a better coaptation. Actually, in a degenerative valve, when you size it, if you are confused between like a 30 or 32 or a 32 or 34, better to err it on the bigger size rather than on the smaller size. So undersizing is not advised for degenerative repairs.
So about the ring size we were discussing now, like I don't know, because we are getting a lot of fibroelastic disease, and in the fibroelastic disease the maximum size sometimes is only 28 or 30 you can put. You cannot put larger than that because the annulus is not dilated. So I go in for a smaller size in those cases. And another thing is about the annuloplasty. Do we have a discussion on annuloplasty ring separate or? Yeah, that would be fine. Yeah.
Sir, is there any issue of circumflex compromise when we oversize the sizer, the ring size? Because I have seen 3 patients during my UN method days where the valve was repaired by an oversized sizer and oversized ring was used, and it caused LCX compromise, and we had to graft in 3 patients. Sir. That is my experience. So in my experience, I do not oversize and I don't even undersize, but I routinely put around 28 mm ring, and I have seen actually no gradients in that patient, sir. I don't use 30 mm ring size, sir. But even 28 mm ring is quite good in case of our patients, because our patients are smaller as compared to European patients, sir. That's my experience.
For me also, if you look ask me, I put the correct size. So I don't go for any oversize, because one way of doing it is like once you take the annular sutures and did all the leaflet and other procedures, when you are testing with saline, you have both the AML and PML coming up. So that time if you size it, that will be correct. So if you try to put a bigger one in that situation, you may land in trouble, and no need to go for a smaller one also. So that is how we usually size. It's not that AML length alone or the inter trigonal distance, but it's just put it saline and then size it. You must be, most of the time it will be accurate. And then regarding the sizes, like we have now up to 38 or 40 we use, but no, it depends. Like in a Bowlow's disease, you need higher sizes. In a fibroelastic, smaller size. Rheumatic also it will be ready. Is ready?
Okay. Good morning, respected faculties. I am Dr. Jeevan, final year resident, Government Medical College, Kottayam. Today we are presenting case of 56-year-old male with a history of dyspnea on exertion, grade 2 for 9 months. He gives history of occasional palpitation and history of orthopnea. It's a non-case of hypertension. And vitals are pulse within normal limits only, and we are getting a pansystolic murmur at the apex. This is a chest X-ray of the patient.
ECG, anything is there?
ECG, sinus rhythm only, sir.
Any ectopics are there?
No ectopics. This is a transthoracic echo report. LA size of 4.47. Ejection fraction of 75, and MVP grade 3, PML P2 fluid, mild AR, mild TR, severe pH, and good LV function. And coronary angiogram shows normal coronaries.
So it looks like acute MR, or?
LA is not that dilated.
LV is also not dilated, severe pH.
History is of 6 months.
Yeah. More of. It's very rare to get a pH. So, okay. Manjusha?
Yes. Hello, sir. Okay.
Yeah, can you show
yes,
the...
Yes, yeah. I'll start. So, so I'll be starting with the BTC PGL-TE views of the mitral valve. It's always better to follow one pattern and you can use it. So, like what I mentioned before, is that arrowhead visible? Yes. Okay. So, this is one thing you have to see when you're seeing the TU is what is your sector angle. So, this is at 0 degrees. 0 degrees, you're seeing some part of the aortic valve, and you're seeing the leaflet close to the aortic valve is the anterior leaflet, and the leaflet away from that will be the posterior leaflet. As soon as you put I usually use color compare so that we can save some time also and can see both images simultaneously. So you can definitely see that there is an anteriorly directed jet. We can see that there is a prolapse come flail of the posterior leaflet. So this is more of A1, and this might be P1, P2, that portion. So as I said, that's more than the 0 degrees, it's always 0 degrees, it's better to go for the 120 degrees and commissural view, which will be more accurate on 2D rather than the other views. So as I'm now I've reached, I've advanced the multiplane angle little so that I'm getting, aortic valve is out.
Manjusha,
and you're seeing,
Manjusha,
hello.
for the sake
Yes.
of audience, can you say why you are saying it's a flail, not a prolapse?
Yes. So I'm going to freeze this image, and as you go slowly, you can see that this is in diastole, the leaflet is advancing into the LV. And as the patient is going into systole, can you see this? This is a posterior leaflet. This is definitely that the leaflet is moving into the LA, and the tip is directed towards the LA. So that's why it is a flail more than a prolapse.
Okay.
And usually flail means there will be an underlying caudal rupture also. So this is the bicommissural view. It's like that case which I showed earlier. So as JK sir also said, for me also this numbers 1, 2, 3 were a little difficult, but I found it easier when you correlate with anatomy. Whatever is close to the LA appendage will be P1. We can see the P1 segment here. We can see that there is an A2 which is below. The big leaflet which you're seeing behind the A2 is actually the prolapsed P2. So again, it is the cobra head sign. And the leaflet which is seen medially is going to be the P3 portion. So here it is a very large MR jet, but there is a tiny jet which is coming from the commissure, probably because of the extensive leaflet involvement. So you can see that the majority of the jet is... Hello?
Hello? Yeah, we can hear you. Yeah.
Okay. So there is a small jet over here also. It's always important to look for additional small jets because sometimes they may be a marker for an additional pathology. So you can see that small jet over here. In this direction, there is one more jet.
So this is which view? 60 degrees?
This is 60 degrees, so it's a bicommissural view.
Bicommissural
So you have
view.
the P1, you have the A2, you have the P3, and this is the prolapse which is happening behind that. So sometimes...
Cobra head.
Cobra head, yes.
Okay.
So, but it is a very large MR jet, so sometimes it might be related to that also. Yes. So coming to the 90-degree view, so this is one view where you can see portions of the multiple segments of the anterior leaflet, and the leaflet which you see here will usually be P3, and you can see the P2 which is prolapsing behind that. So coming...
just go back to the previous slide.
Yes.
Yeah. So this is a two-chamber view. Or
yes, 90 degree,
90
two-chamber
degree,
view.
two-chamber view.
Yes.
Okay. What is that thing? There's a coronary sinus?
Yes, this is the coronary sinus which you can see in the AV groove posteriorly.
Okay. Okay.
Yes. So this is the 120 degree view. Most of our analysis, most of the information we can get is from this view. So we can see that I got it a little more at 140 because sometimes it might be because of the LV dilatation. More than the numbers, again, I usually follow the views. So whichever view where you're getting the LA, mitral valve, LV, and you're getting the aortic valve in the long axis view. So here you can see that the leaflet closer to the aortic valve is going to be the anterior leaflet, and the leaflet behind that is going to be the posterior leaflet. Again, if I freeze and show, we can see that there is a leaflet tip, and there is a prolapse there is a flail in one segment also, and the jet is classically directed anteriorly. In addition to this, is just to show a zoomed view of the in this view, we don't need many measurements. We can immediately say that whenever you see this flow aliasing, that means it's a significant MR when you see these hemispheres forming. So vena contracta is 10 millimeters, definitely is a severe MR. Mitral annulus was 3.3 centimeters. So this comes to our measurements. Posterior leaflet was 1.18 millimeters. AML was 30. So C-sub distance, we have to check multiple views actually, because the coaptation is happening beyond that. So AL-PL ratio for this patient is around 1.1. Actually, this is the AL-PL ratio for this patient. So it is a little borderline. That is, it is 1.3. And the C-sub distance is also a little borderline. That is, it is around 2.44. That is so it's coming to the middle of all our numbers. LVOT is 1.8. It's not very dilated.
Is there any AR, trivial AR?
There is a trivial AR, very trivial AR. Vena contracta was 0.2.
Is the patient Marfan or Marfanoid?
No, he's actually very short-statured. His height is only 156.
Okay.
Then coming to this is another view. Sometimes even if 3D is not there, I found that if you can get a good 2D transgastric view, again you can see an on-face view of the mitral valve. This is the AML. This is the posterior leaflet. Here you can appreciate the prolapsed segment. And if you add color, again, it's like adding up information from multiple sources. So here we can see we can see the jet coming from here also. Again, explain is a very good imaging modality to see both the valve and the subvalvular apparatus. So here again we can see the P2 prolapse which is happening behind. This is like a modified bicommissural view only. You can measure the caudal, is there a caudal elongation? And for neocordae, there are multiple measures. Some people measure the subcost. Any view where you're getting the papillary muscle head, the coaptation length, you can use, but 2D probably not, because there is a parallax error. So that we can always correlate with the post-bypass findings. RV function is good. I'll just show the additional findings for this patient was ejection fraction was good, 86% EF was there. It gives more information than the 2D. Here we can easily see the flail segment with the ruptured chordae here. That is mostly happening in P2, but some portion of the commissure also getting involved. That is only doubt. MR jet is very extensive.
Is Dr. Jayakumar there in the theatre, Dr. Manjusha?
Yes, I will just show one of those transthoracic measurements also. So, advantage of 3D over 2D is that you can get your imaging planes right. So, since I had a little, because in two images I was getting two different numbers, if you can see this image, you can see that we can see the correct measurements of the C-sub distance here. I've got it as 1.45. Again, it is a little borderline. And the AML length is 30 and the PML length is 20 millimeters. So here again we can see we can use, so the advantage is that because the surgical measurement happens, as was discussed, sir measures it from the maximum distance of the AML, and usually it is measured in this plane. So we can use 3D to use the same cutting plane and get the same image, because 2D is always subject to parallax errors, is what I felt. Yes, this is the image which I wanted to show. So we can see that the C-sub distance is just 2.5. The AL-PL ratio, AML and PML are almost coming at the same level. The PL height is around 20, AL height is also coming to around 20. So AL-PL ratio is also a little on the borderline side. It's definitely not more than 1.4.
Manjusha?
Yes.
Can you show that circumflex?
Yes.
Yeah.
I'll show that.
She's prolapsing. Praveen, looking at these images, what do you think? Is it going to be a myxomatous valve with lot of tissue, or is it going to be a FED with less of tissue? Because we think it's just a PML prolapse, and I personally feel sometimes dealing with the isolated P2 prolapse and FED is a bit challenging to repair because you have less of tissue. You might end up having a mild leak intraoperatively, which progresses on to a bit significant leak in the 3rd month echo. Praveen, do you think it's going to be FED or excess tissue?
From the look of it, it looks like a FED plus. FED plus. Yeah. Manjusha,
Okay.
you're
Yes.
showing something there.
Yeah. So this is it's a midesophageal bicommissural view. You can see that this is the an annular level, and this is the circumflex which you're seeing. The distance of the circumflex from the annulus at this point is 6 millimeters, but there is a little echogensity in that part. That's all. So this is again a still image showing the LED which is coming, and this is the proximal portion of the circumflex. So this is, you can see when you add, you always have to make sure that the color scale is a little less, around 15, so you can see the flow well. So here you can see the proximal length of the circumflex, and you can see flow. This is a 2D image which is showing the same thing.
I think you said when it is less than 4 millimeter, you'll be worried, isn't it?
3 millimeters
3
is the cut. 3 is the cutoff. More than 5 should be okay. Okay, over to JK sir. Yeah, okay. Hello. Hello, Praveen sir. Are we audible from the?
Yes.
Okay.
Yes.
Okay.
So Manjusha, the question was whether it is fibroelastic deficiency, FED or FED plus kind of thing, rather than
Yes. Because what you can see is that other than the prolapse segment, the rest of the tissues are just okay. It's not. We don't have a luxury of tissues in this case.
Yeah.
So definitely, it's the FED spectrum.
FED spectrum.
And
are they ready to cross clamp there or?
Yes, ready.
Can you hear me?
Is there any more information you want to give?
No, sir. Is JK sir audible?
Can you hear me? Hello?
Jayakumar, can you increase the volume?
Yeah.
Barely audible.
Can you hear me now? Hello?
Some more please.
Hello?
Some more.
Hello? Hello?
Can we increase the volume some more?
They are doing it. Okay.
Hello?
Yeah, hello? Can you hear me?
Yeah, better.
Better, okay. So I was just listening to the discussions. I just cannulated. We are on pump and ready to clamp. Please, you ready? Yeah. Clamp on. Give. Yeah. Right. So it is something like a fibroelastic disease, but we have some extra tissue as such. Can you see the field?
Yes.
Yeah. Okay. Section. But it's a P2 prolapse. That is what I understood, isn't it?
Yeah.
And it's a large segment prolapse. That's what Manjusha was saying. But the AML PML length, she is raising some concern about risk of SAM.
Yeah.
Okay, and Otherwise, LV is good. Some trace of air is there, but we are able to give the plegia. That's going fine. And I think so. The bias will be. I will be think that I am dealing with an FED with less tissue, with the risk of SAM, and then say purely PML prolapse. But I don't think there was only single jet. No, there was no only single jet. No.
Yeah, she was having some concern about commissure. This is like a small jet in the commissure.
I was hearing something like that. Is there a commissional jet? Because if we see some commissional jet in a fibroelastic disease and try to do something with the PML, most of the time you will be opening up somewhere else. Okay. So that is something we have to be very careful. So the cannulation is aortic. Then bicable, I put always cannula into the SVC, and then right angle one, and then the IVC. And here I think the LS size is not very good, so we go for the supraceptal, especially looping, especially to demonstrate. I think supraceptal is the best thing to do, especially if your LV is not good. Means LS size is not good. So I am looping the SVC and IVC. I think when we saw the supraceptal first time, we were very much worried what the injury to the SA nodal artery and the arrhythmia risk and how to repair the supraceptal and all, no? Pravinji?
Yeah.
So I think now it has become more of a routine, like whenever you section, whenever you land up with a small, set the camera, small LA, I don't hesitate to go ahead with a supraceptal approach. What is the LA size here, Manjusha? Oh.
LA was small.
Yeah. 4.5, yeah. So LA is small. So in a small LA, I think one of the most important thing in mitral repair is exposure. If you don't see it properly, you will not be able to do a good job. Especially if you are thinking about a difficult repair, it is very important to do that. Okay. So. Okay, fine. So the plegia is in. We use Delnido here, and we go up to say 110 minutes, just less than 2 hours. Okay, so if needed with Delnido single dose. Okay, so do you use Delnido? I think.
Yeah, we use Delnido, but we repeat at 60 minutes.
Okay. What about Dr. Enparisu? Like
usually we repeat it 90 minutes.
90 minutes, okay. So
Delnido, but 90 minutes is our repeat time.
Yeah. Okay.
Very rarely in case of sick hearts or in hypertrophic LV where we do an AVR or a double valve replacement, then we repeat it 60 minutes.
Okay, right. So now the supraceptal approach. So this is the RA appendage. You can see it, no?
Yeah.
And this is the aortic root. This is the LA roof. So the incision into the LA roof will be going like this, just little away from the aortic root, and then to the RA like this and comes. Okay. Yeah. So first I open the RA.
For a workshop, this approach is beautiful because this is the best approach to expose the complete mitral valve.
Yeah. And get me some air is getting there. So it's just stay switcher. So I am cutting into the RA roof now. Okay. Section, just hold it like this. Yeah. Now I think we'll cut it off. Or put a stay switch. Just give me a stay. Half. One more stay. Are you stay there? Okay, got it. Yeah. Now, so this is knife here. Just give me a knife. Also. So this is the fossa ovalis. Just hold it. Hold it the forceps. So I'm just opening it. So you are into the LA. So this is. Now if you connect it like this into the LA roof, and then connect the intraocular septum into this, that opens up nicely. Okay, so that is LA roof. One more stay. Retractor, the laparoscopy camera, at the small eyelid. Just get me a frag. 30 degree alle. Just 30 degree alle. Hold your hand like, okay, you'll be able to manage, no? Kanalo. I'll just organize the cameras and get back to you. Just duals. One more dual. Okay, wait. 0 degree telescope എടുക്കാം. Let me see. Okay, that will be good. Huh? Okay. Huh? Can you see it now? The laparoscopy camera is projected there?
Yes, very well.
Okay. Session.
We can see very well.
Okay, right. Hook there, hook. So I think it's a little rotated one side. I think. Don't know. Okay.
Can we take a stay on the RA free wall and pull it towards the pericardium? So it might
this one
improve the exposure. Yeah.
Okay, so give me a stick. Give me a switcher.
There is a small risk of blocks in this approach. There's a slight, the Western literature says there's a slight increase in incidence of pacemaker implantation.
Right,
but
yeah.
Most of our surgeons, Dr. Tavisak uses this exposure routinely in all workshops, probably in all cases. But no, we just cut across into the roof of the LA, sir.
Okay, so hook there. Now this gold standard thing like the sequential segment. You see the entire valve. No, it is anteroposteriorly. Say it is the annulus is dilated.
Yeah,
okay?
exposure is very good, sir.
Yeah, annulus is dilated, and then this is the P1. One more hook. P1 chordae. I don't know whether you can see it now. No. And this is the P2, which is prolapsing. You can see it's a big area of prolapse, okay, and then this is the P3, okay, fine, okay, and this is A1. I think A1 is also a little bit, okay, we'll see. The A2 is okay, and this is A3, okay. So it's basically this large segment of P2 prolapse. So you can see this much area is prolapsing, okay. It's a big segment prolapse. So we'll so first we'll take the annular sutures, and then we'll plan I think probably for a big area of this, I think I will go ahead with an artificial chordae. That's better, isn't it? What is your opinion?
Yeah.
Any difference?
No. What do you feel about the amount of tissue available, Dr. Jayakumar? Is it adequate or just adequate, or?
It is say just adequate, I will say.
Yeah.
The AML is just normal.
Yeah.
No excess tissue is there. We have only minimum. Even though we say that you say start with a PML prolapse repair, but this is a little bit difficult subgroup, okay, because the tissue is not very well available with us. So that is the first suture I put, like always. I'll show you like forceps, one more forceps. So when you pull it down like that, next case I'll show. I forgot about it. This is the right trigone, and whatever you see on the other side, this dimple is the left trigone.
Dimpling, yeah.
Okay, and one thing. Okay, we'll see you. So I start with the right trigone, and then I would prefer to have say a projected sutures for this thing. So I usually put projected ones.
This is something which Dr. Jayakumar does it a bit different. Most of us use a 2O Ticron suture, which is about with a 25 mm needle.
Yeah.
And we don't use pledget, but Dr. Jayakumar uses it different. He always has a pledget like the mitral valve suture for the mitral valve repairs as well.
That's right. Because what I feel is even if the annulus is thin or something like that, it will hold nicely. So it may not cut through. But sometimes when we are tying down, if it cuts through, then it becomes a problem. So I am very comfortable with this technique. That's why. Maybe
how many sutures do you take for the posterior annulus, Dr. Jayakumar?
No, I don't keep the counts. No, I just go like that. Yeah. Do you have anything like that? You specifically count the numbers?
If it's not too dilated for the posterior annulus, we take about 7 sutures. If it's dilated for the posterior annulus, it's about 9 sutures. Okay. And 4 sutures for the anterior annulus is quite standard.
Yeah, for the AML, for me the same, like 4. 2 trigones, 1 in between 2. That's what. So this is something is important again in a case of, when you don't have enough tissue, like if you take this bites into the leaflet, then that area of the leaflet will get tethered up. So it's better always stick to the annulus itself. Okay, we should not get into the leaflets. That's something very important. Okay. So we have reached almost to the mid portion of the PML, and from here only we have to be very careful about the circumflex. I don't know, Manjusha, what she was telling about.
It's far away, 6 mm.
Yeah.
Don't worry.
Yeah. Can you pull it out a little bit? Pull the camera out a little bit. Or retract on it. Just get me an eyelid. Get me an eyelid. Oh, the dual, get me a dual. For a supraseptal, most of the time you may not need a retractor, but this is helpful, holding it with a dual. Okay? So forceps, give me forceps. So if you look at this, this is the early appendage, and this is the valve. So this area, this is the area where you are more worried about the circumflex. Okay. Yeah.
Ordinarily, I take, just like Carpentier has described,
Pardon?
into the annulus. But I take these kind of sutures in re-repair, where once you have removed the ring, there is a big trench, and then you don't know where to take the sutures. So I take these kind of sutures going through the left atrium, coming out just at the junction of the leaflet. So there, these kind of sutures I find very useful.
Okay.
Yes. In these kind of sutures, there is really no worry about taking circumflex artery.
As we are seeing the left appendage, I just wanted to ask all, say this patient was in atrial fibrillation and we were still trying to repair. Would anybody address the appendage? Close it from inside, outside, clip, whatever?
We would definitely excise the appendage. There's a small difference in LA appendage, the way we deal between a replacement and a repair. In a replacement, we just also the orifice of the appendage from within in 2 layers. But whereas in a repair, what we feel is the ring may not be a rigid structure to help in oversewing that from within. So we always excise it from outside. What do you do, Praveen?
No, always outside.
You excise it or just suture it off?
For thick, this one we excise and
suture
it.
Yeah.
If it is very thin like MR and all those things, we just like it. One with a plaget, 50 plaget. Jaykumar?
Yeah.
How common is, you do maze surgery along with do you do any maze?
No, because we don't have the cryo, but earlier I used to do the cut and sew once or twice.
Yeah.
Not very common because, what about you? I think recently I was there in Thailand with Tavisak with one of his workshops.
Yeah.
One person from Japan, he was doing it in almost all cases like cut and sew plus cryo, cryo, I think the radio frequency, I think cautery ablation.
Right.
Yeah. So
no, that's something which I am thinking whether we should, I'm not doing incorporate in our practice because recently a lot of reports about this cryo, almost 80% freedom from atrial fibrillation, combination of cryo and cut and sew. So
cryo, it's not very difficult because we've not used cryo.
Yeah.
It's not difficult because ophthalm guys always use cryo. And it's quite easy for us to get a cryo from the ophthalm theatre.
Yeah. So that is something
not very expensive as well because if you are going to use a radio frequency ablation,
no,
consumables are
consumables are very, and it can be used only like once.
Yeah.
After that it goes off.
Yeah.
So
there are a few surgeons who do the cautery maze. I've done a few, but I'm not sure how far it's reliable because you have no control on the depth of the lesions you're creating.
Right.
And the charring it causes in the tissues in left atrium, I'm a bit worried whether it's going to cause embolization or stroke later.
So Jaykumar, can you explain where you will take this the anterior sutures, because anterior annulus is not very well defined, isn't it?
Right. I'll tell you right now. 1 second. So sometimes this can be a problem, like looking into the anterior sinus. One thing is, once you move it like that, you will be you will be able to
see the hinge line.
Yeah, see the hinge like thing.
Yeah.
Or if you have any doubt, get me right angle. Still, sometimes it may be difficult. So put a right angle like this and see. Okay.
Yeah.
This is how it comes. Okay.
Right.
So that is how I do that.
So you have taken the annular switches first.
Yeah.
If you don't mind, can you again show for the how to analyze the valve?
Yeah, I'll show you,
Yeah.
because always it is better to, sometimes I straight away go and take the annular switcher and then only I will analyze the leaflets, because that improves exposure and you can really comfortably do it. Okay, so forceps. You can see once the annular switcher is taken, it just comes up like that. Okay, so hook.
Yeah.
So again, say you have the.
You use P1 as the reference point, isn't it?
Yeah, here the P1 is good because there is no issues with that.
Yeah.
And then say the. But here Manjusha was saying something in the commissure.
Yeah.
So I think there is some problem in the commissure. We'll just see right now. You can see, can you see that?
Yeah, yes, very well. Yeah.
Yeah, that area, the commissure, the corda is fanning out. And see the leaflet is getting attached little lower down there. Can you see that? This area.
Right.
This area.
Right.
And there is a small
defect in the
this portion is bulging out.
Yeah.
You can see now.
Yeah.
This is bulging out. Okay. That's going to produce a small jet there.
Yeah.
So probably we can put a commissure switcher and come out of that. Okay,
Right,
there is
right.
something. And then
So you will do A1 to P1 first and then A2 to P1.
Yeah. So A1, then A2, then this is A3. So that is A3, okay?
Yeah.
And then say this is P3. This is P3.
P3, yeah.
Okay.
At the same level,
yeah.
and then
this is coming up, okay?
Yeah.
This is just prolapsing, okay? Now once you...
Can you show the cleft also?
Yeah, I'll show you. Forceps. So right now, hook. If you see, this is the P2. Say, if I stress the P1 here, you can see, no?
Yeah.
This is the cleft here.
Yeah.
Okay. And this is the P3 area. If I pull it out, you can see this is the cleft. But this is not very marked.
Yeah.
But one thing, this area you can see, no? Can you see this?
Yeah.
This is being restricted down by one
Secondary chordae.
So segmental chordae. That we may have to do something. So I think we'll put two artificial chordae to both papillary muscles, because it's a P2 central portion. I think if I put it to one side, I think I can put it to one side also. So up to this is okay. So only this much. So this is the area which is prolapsing. You can see these are the two chordae on either side of the prolapse which I am holding. Okay?
Yeah.
So this is a segment which is prolapsing. Okay? So if
Right.
you have enough tissue, just placate it, suture it, then that will take care of it. Or just resect it, that much tissue. So this is how we assess. Okay?
Okay.
But I think here I will not do that, because when you are holding it like that, you can see that this area is opening up.
Yeah.
Yeah. So that is going to produce another jet there, and already we have a problem in the commissure, so better not to. This area will be all right, even if we do like this.
Right.
So I think we'll put it back. So I need 2 or 3 chordae. So get me the scale. So this is the chordae which I am going to keep it as a reference point. Okay?
Yeah.
This is the one. Can you see the papillary muscle down there?
Yes. Very well.
Okay. It means forceps. So I don't have a caliper. So I use this scale. So the scale will go down into the papillary muscle head like that. Can you see that? Just show that. Papillary muscle head. Can you see that? Yeah, and then so it is around 2.5, I feel. So this is where it is, and it goes up to this. That means 26 it comes.
What's the length you got? 16?
Yeah, one more time I'll just, I think I could not demonstrate it to you, so I have just taken it out. I'll show you once again.
Yeah.
Yeah, so this is the papillary muscle head. Is it pretty clear? Can you hold it? Wait. Can you see that?
Yeah.
Yeah, yeah.
Just, give me the scale. Forceps. Just get me the forceps.
Dr. Jayakumar.
Yes.
Amit Chandra this side.
Yes.
You can have the scale cut into half longitudinally.
Yeah, they do sometimes like that. Okay, it's
that
okay.
makes it very easy.
Yeah, it is 2. Okay. Yeah, it is 2. Huh? Okay, I'll cut it once again and show you because I use the same.
What is the plan you have in your mind, Dr. Jayakumar, right now?
How
are you going to deal with the valve now?
Yeah, I think I'll put an artificial cord.
Okay.
Yeah.
Why are you against limited P2 resection because of less of tissue, or what do you? What?
Yeah, lack of tissue. That's what I feel. No, isn't it? It's round 2. Okay. What do you feel? You want to do a resection?
The amount of tissue is not too bad. I would do a very, very small triangular resection. Yeah.
Yeah. What about
be very cautious to resect a very small amount of tissue.
Praveen, what? Yeah.
No, I think we move to artificial cord most of the time, unless the PML length is very high.
No.
Otherwise, most of the cases, no, it's artificial cord.
Yeah. No, because last time we were doing a similar workshop, and that time I did the same mistake. I resected a small portion. We could repair it, but it became a very difficult situation. Like we had to spend a lot of time on that. So I think artificial cord. I have shown you, when we are resecting a portion of it, we will be opening up
the clefts.
Yeah, clefts, and we will have, especially in this case, we have another lesion near the commissure. So I think it's better to preserve as much tissue as possible in this particular case. Okay.
Now, this artificial cords of PML, there are two concepts. Number one concept is like Dr. Patrick Perrier, he just plicates the whole PML over and above and just makes it as a sort of standard structure for the AML to go and coap there. The other one is like getting a proper length chordae where you get the PML at the annular level.
Yeah.
Like, what are your thoughts about the snail technique which Dr. Patrick Perry uses, where he just plicates the PML? He calls it snail technique.
Snail technique, yeah.
He just plicates the PML down. It's more like he gets it down into the left ventricle and makes it like a hinge mechanism for the AML to come and close.
Yeah, suppose that is more possible in Barlow's type of, means when you have a lot of tissue.
A lot of tissue, yeah.
Yeah, the PML can just go down. And that is why, if you look at some of the earlier artificial cord, it was fixed length for the PML. It was just 15 mm.
Yeah, 15 mm for the PML, yeah.
So that was based on that principle, I feel. Like, if you have a lot of it, no issues. Okay.
So you're making a loop cord?
Yeah.
Your own loop cord?
Yeah.
Can we zoom a little bit on that?
Yeah. Can you show that?
It's Jagmar, if you can keep it on that blue thing, it will be better because there's a lot of glare in the. Yeah.
So what I will do is, like, you measure it with the scale and just reduce it by 1 or 2 millimeter to take care of the knot here, and then put 3 or 4 loops, whatever I want, and then put the sutures, and then a plugette here. So that will be good enough. Yeah.
How many loops have you created?
This I have created 4.
4. Okay.
Yeah. So that is it. The loop. This is ready. Okay. Yeah. Maybe hold on.
So there's an announcement. If 3 people can, 3 people can join in the OR. That's what Jagumar.
Yeah, they can. No issues. Yeah.
If anybody wants to join, three persons can go to the OR and see. If anybody is interested.
Can you see the papillary muscle where I am just taking it through the head?
Yes.
Yeah. Yeah.
So, Dr. Jagumar,
yeah.
So you are going to take it to the posterior head of the anterolateral papillary muscle?
Yeah, posterior head of the anterior, because that is from where the things is going.
Can you see where the chorda is ruptured? Are you taking on the same place or?
No, I can see a chorda ruptured here, not like a tip, but we are not seeing any chorda as such here right now. Okay, yeah, almost to the same place, yeah. No, basically, I used to adjust a little bit on length by adjusting the where exactly I am going on the papillary muscle, because if you feel that after taking the loop a little longer, I may go a little down also in the papillary muscle, okay. Otherwise it's the tip. So, because the papillary muscle also is important to decide the length of the chorda, you know, the position of the papillary muscle. Sorry, a hook there, just get me a hook. Hook. Yeah. Forceps. And plugette. I put plugette on either side of it.
Have you tried this Colfidis technique?
No, I've gone through that.
The Roman arch technique, is it?
Yeah.
Praveen?
So many names, you know.
So many names are there, but have you tried that? No.
No, not yet.
What are your thoughts about it for using for AML flaps? I think for a PML flaps it works usually. But what are your thoughts about it working for an AML flaps? Because you got to get the length of cords exactly for a proper repair of the AML.
Because I feel we have to just try and see.
Yeah.
But since we are comfortable with other techniques, I thought, it should be. It's a good concept. Once this thing is ready there, we can again assess with the chordae, like whether you have done the correct length or not. Okay.
Okay.
Okay. Yeah. Switcher, probably.
So you are taking only from one papillary muscle, or?
Yeah, I thought I will take, because that is what I was also saying.
Yeah.
Like hook. So from the chordae from the other papillary muscle is already coming up to this level. So almost beyond almost up to the midpoint.
Oh, okay.
So I think it's okay. I don't have to cross the midpoint to take care of it. Okay.
Okay. So you use that cut portion of that chordae to, that artificial chordae to fix this?
Yeah.
Okay.
I use Prolene also sometimes because this is too costly.
Yeah.
So
this is 40?
Yeah, 40, CV4.
CV4.
Yeah. And then airlock വരുന്നുണ്ടോ? വലിച്ചിട്ട് just വലിച്ചിട്ട് put it down a minute. Some of the tips and tricks, like to bring it down is like when you have a PML, this also you see compared to the other areas of the PML, this is longer. So again, you can come little bit on to the PML and fix it sometimes. Okay, so that
helps in reducing the height of the PML.
Yeah. Or you plan for a shorter chord sometimes. Okay, so again, the problem there. അല്ല CV4 വരെ ഉണ്ടോ? This chord are placed almost 5 to 7 millimeter apart. Okay, so that like I think as Dr. Ambaresu said, sometimes we can get away with say resecting a small portion of it, but sometimes you land in trouble. There is one thing. Second thing I found is another technique again from Professor Tavisek is rotation plasty. So instead of cutting it off, you do a rotation plasty, especially that is useful in minimally invasive things. Okay, when minimally invasive, like if you find you cannot go deeply into the papillary muscle and hook something, so rotation plasty helps. The advantage with rotation plasty is you are not cutting off anything. So if you did a rotation plasty, if nothing is working, is not working, you can undo it and again go ahead. Okay. So in this case, if I was going for a rotation plasty, I will just rotate it like this and put it here, because that tight tissue, the other side I feel the tissues are adequate. Okay. So here I think I need only three ones, but I am not supposed to leave anything free. So I take 2 together for this last one. Okay.
Okay. I think somebody is snoring now. So
test.
So how many notes you are putting there, Dr. Jayakumar?
8 to 10.
8 to 10.
Yeah.
So you always use CV4 or sometimes you go for CV5 or?
No, mostly CV. Pediatric
you go for CV5.
Yeah. Is it the choice of yours?
CV4.
CV4 always.
So there is some one Indian company has come with Gore-Tex reduced cost. Have you tried that?
No.
What is that? Which company is that? Okay.
I don't know. But I'm very worried about trying out something there if it breaks. But I think our pediatric they started using CV5.
Check saline. I will just check once and then see what is how
if
it
at all
works.
if you like complete AV canal and if you are repairing the cleft or cleft AML or something, it's sometimes better to use the polyamide than proline, because proline is too rigid; it will cut through in a thinner tissues.
So proline to fix the loop.
Polyamide.
Okay.
Close the clefts.
Yeah.
Can you zoom out a little bit? Yeah. Yeah.
In this area, we are getting a small jet. I think
That's
mainly
a
because of
cleft.
the restriction that I think.
Would you wait till you implant the ring and then switch
Yeah,
to the
yeah.
clefts, or would you repair the clefts right now, Dr.
No,
Jayakumar?
right. I think just once more saline. I'll just see once again and then. Okay. I think probably I'm pulling it up too much. It should settle down once we put the ring. Okay.
Yeah.
But if there is less mobility, then that time we will see. Okay. Right. Okay. So I think we'll put the ring and then see. Okay.
Okay.
Then just size. We'll just hold it like this. Hold it like this. Okay.
Can you zoom out a little bit? Yeah.
Section there. Size of that 30, 28. Size of that 28, 30 there. I think 30 should be all right.
Yeah,
Okay.
she measured AML length of 30.
Yeah.
30 should be okay.
Just.
Do you pull the AML and measure the height of the AML, or you just measure the whole annulus
Yeah,
together?
the whole annulus I pull.
Together, okay.
So just I'll show you what the difference makes with the AML alone.
Yeah.
So this CG feature is it's a complete ring.
It's a complete ring.
3D profile. Is it?
No, complete ring, but it's it's a semi-rigid ring.
Okay.
That's all right. Okay. So this, if you measure with this AML alone, it will be only 28. 30 will not go. Okay.
So can you show that
28
sizer again? One more time.
Yeah, I'll put the 28 and show you. This is 28. Yeah. So actually, with the AML alone, it is just 28, even less than 28. Okay.
So the two notches are in the trigons?
Yeah, it is in the trigon right now. Yeah.
In the two trigons?
Yeah. And then we are measuring the length of the AML, isn't it? So even 28 is okay for him, but why I'm worried about 28 is because the PML is a little bigger. Okay. So we may
end up having a SAM.
Yeah, how is the LVOT? Manjushra was there, no?
Borderline SAM potential.
So we'll put
30.
Yeah. So 30 ring, please. 30 CG future. CG future, it's a semi-flexible ring, no? It's a semi-flexible one. Yeah. Semi-rigid. It's a semi-rigid one. No?
I think anterior is flexible and posterior is rigid.
Yeah.
Is that?
It is anteriorly it is flexible, posteriorly it is rigid, so that it will give room for the aortic valve for the movement.
Yeah.
So that is a
Calvin Galloway ring, isn't it?
What's that?
Calvin Galloway, isn't it? Calvin Galloway.
So that's the expansion of CG, is it?
Yeah.
Calvin
Galloway.
Okay.
So many times the choice of a ring is a very major question, no? Because
do you have any preference for any ring?
For me, if you ask me, I use whatever is available with us. I find all the same.
But you choose the ring. In the available means when you purchase, you decide.
It is like there's a rate contract from the government. There's a tender and the rate contract. So accordingly we use. Okay.
Oh, okay.
So the overhead camera, please. Can you see this CG feature? Can you see this?
Can we get that
No.
image into the main screen, please?
We are seeing the valve now.
Okay.
It's in a side screen, sir. Yeah.
So here I think.
Can you show the lateral profile a bit? Lateral, I mean, yeah.
Yeah.
Oh, it's a 3D shaped.
Yeah, there is a little saddling, saddle
Okay, saddle shape.
shaped.
Okay.
So is it going to really make a different saddle or not? That's always question, isn't it? Maybe I feel like in a fibroelastic disease, still the annulus is mobile and flexible, unlike say, and it is still keeping the saddle shape.
Yeah.
Compared to say the Barlow's disease where it is already flattened out, isn't it?
Yeah.
So I think saddle is really good at this situation, and just take it out that way. And I think their SIMU form, Medtronic SIMU form, they say the entire thing is
flexible.
Flexible, so it may help to have that sphincteric action, isn't it?
Yeah.
I don't know to what extent and how long, but still, how many switches? No? 12. So that is one of our major concerns. Even if we would put a flexible, whether we are going to have a long-term flexibility or whether everything is going to get fibrous. What is your take on that?
Yeah. So most of the rings after implantation of 3 months, they don't find much of, like usually has to be a 30% reduction in systole.
Yeah.
Those things don't really happen because it gets fibrosed.
Yeah, but I think now people are doing something like MRI or other things at 2 years and saying that okay, some of the flexibility is retained. Okay, I don't know. There are means.
No, I think that's why these 2 new rings have come. One from Medtronic and Edwards, thinking that it might be better.
Yeah. But the problem with us is like no, because when they come out with something and say, okay, this feature persists for long, we always take it with a pinch of salt. So, hope Medtronic people are hearing us.
That is a basic defect in surgeons compared to cardiologists.
Yeah.
They are, they will try out everything new. Well, we'll always be worried about
cowboys.
Yeah.
Because whatever we switch down, it is for a lifetime. Okay, that is what we are thinking at least sometimes. So another thing is in the fibroelastic we can have this real D-shaped one. But as you go for the Barlow's thing, it becomes more of oval. It goes, this is the last one. No? Okay, so 12 switches. Actually, always I go for the AML thing first and then the PML, and I divide the switches equally and place it all around. So this was 12, so I calculate as 4 for the AML, that is always there. Then the remaining 8, 4 plus 4 on either side. Okay, so since it is flexible anteriorly, I will not remove this part of it till we tie it down, because otherwise sometimes it will crumble down there and it may not be cut. Table down a little bit. One thing is because when we started off, it was just the Taylor ring, which was a totally flexible ring, isn't it?
Yeah.
And even those patients are coming back now without any issue. So I think I don't know whether.
I'm not sure whether the type of ring really makes a difference.
Yeah. I think the pathology and the extended is we can correct it. That is something.
Yeah.
So again, in the AML, I tied down first from the trigon to trigon.
I think there's a paper saying that the ring or the make or type of ring doesn't matter in long-term results.
But then,
Like the original Carpentier ring was a rigid uniplanar ring, and those patients still have a good result. The
That's
long-term
right.
results are good results.
That's right.
Yeah. Good fibros. Yeah, doesn't matter.
I think there is an interesting article by Songwan
I'm not
in
sure.
Analysis. No,
We choose the type of ring depending upon the payment of the patient, because scheme patients we can't use the expensive rings. So we end up the government scheme patients we end up using the Abbott's the St Jude's Seguin ring, because that's the cheapest ring. And paying patients we use either the Medtronic or the Edwards rings.
okay.
No, this one probably no. No. Yeah. You like really that bad myxomatous valves? Yes, I go for. Felt. I had to redo 2 cases. Long time back using felt. That was done some 5-6 years back. Before that, done by me only. But I found that severe pannus kind of formation. That was the cause of failure of the repair. The whole felt and everything was covered by pannus, and the leaflet was totally restricted.
What was the primary pathology during the first surgery?
P2 prolapse. P2 prolapse, yeah.
Degenerative, not a rheumatic valve.
Rheumatic valve, no.
Because most of the cases which Dr. Sampath Kumar did were rheumatic valves.
So the felt has caused severe pannus formation.
But I believe a lot of these patients are coming for follow-up 10, 15 years later after surgery, and they come back for redo. My colleague is from All India, Praveen is here. He says that a lot of patients come back like 15 years, 18 years later for a redo, after the original Dr. Sampath Kumar's repair.
Same pathology, pannus or?
Not sure. Praveen, any idea what the... Is Praveen there? Oh, he's gone out. Okay, sure. Once he's back.
Knife. First knife. Knife.
With the standard rings, yeah.
Standard rings.
It's probably the pathology which happens with the prosthetic valve, so because the sewing cuff is the one which promotes the fibrous growth.
Fill let's close it. Can you see it all actually?
Yeah. Cleft.
There is, it is not cleft actually, I feel. Went down, please. There is a this area it is not coming up properly. And so we'll see. Session. I was telling that area there is some restriction of the
secondary chord you said.
Yeah. And there is a cleft also, of course, but that area is not coming up. We'll see. Hook. Hook, please.
It's directly attaching the papillary muscle?
No, there is chord. You can see now. Can you see that? Just hold it. First. Alright, keep it away.
Yeah, very short chord.
Yeah. We'll release that and see. Okay.
Yeah.
Smaller scissors less. Hook. Okay. Hooker. It's improving a little bit, but still I feel you may have to hook it like this. Okay.
Yeah.
For cerebralin.
Any questions from the audience? Do you have any doubts? Yeah. No, not so. Yeah. So he was finding that between the P2 and the P3, there is an area where there is some restriction of the leaflet. So he released that area, and this is between P2 and P3. That area, that cleft is closing. Restriction is there, yeah. Cleft is there. Cleft is there. Yeah, so no, because if it is not leaking, then probably, because if you close all the cleft, it causes severe stress on the leaflet. Stiff also. Yeah. So Carpentier never closes any of the clefts. He says that those are natural. This one. But Patrick Perry religiously closes all the. So most of the clefts open up when you do a resection rather than when you do an artificial coding.
Actually, with the cleft, the problem is if we try to close all of them, mostly we'll end up with some gradient.
Gradient, yeah.
So it's better only you do it only if necessary. That's what I felt, no? Yeah.
Jayakumar, there's a question.
Yeah.
How much is the objectivity in this saline test?
Yeah, if we look at, there are so many things which is going to come.
Yeah.
Where is the cooptation, whether that is smile or not.
Yeah.
And then, say, if you put ink, you can see, even assess the cooptation height. Okay.
Yeah.
So many things we can, it's not just a visual impression of what is happening. Okay.
Yeah.
So, I think.
So, recently there was a paper from Japan
Yeah.
So he said that after a perfect repair,
Yeah.
the surgeon felt like a perfect repair. 6% of the time there was a residual leak where they had to go back.
Okay. Yeah.
So but it is the best what we can do.
Yeah. Is there a restriction of the AML? That's what I was saying. It has to come up, no? This section. Forceps, huh? Hook.
Yeah.
Just. Zero problem.
So, Jagumar, you feel there is like a small prolapse on the
Yeah.
A1 segment or cleft?
So that is from that very beginning when we were analyzing, no, I was not very happy with the height of the AML, no, I was telling there is some problem here.
Yeah.
So I feel, it looks like a little bit opened up here, no, small cleft-like thing.
Yeah.
So we'll try to close it and see how it works. Huh?
Yeah.
So many times it becomes such things,
Yeah.
trial and error, like sort of thing we have to see backhand.
So many of the pediatric cardiac surgery in our unit, when they inject the saline, they keep the root open. They think that the cardioplegia will get washed off by too much of saline inside this. We are not doing it, but they are very, very particular about keeping the root open.
Yeah, I am also doing that. Most of the time I keep it open, like, at least for the initial injection. If yeah, because one is that, and second is there can be some air inside. No?
Yeah.
If it gets in, that will be a problem. So.
Late Dr. P.V. Rao also got the concept of you should not use too many testing with saline because it washes out
cardioplegia.
Yeah.
Another thing, we are stressing the LV. That's another thing, isn't it? This is check 1 second. Fill. Okay. And now check. That's going to make it worse.
Worse, yeah.
We'll take it.
Yeah. Bike.
Knife.
Alfieri stitch in.
Yeah.
Ambarish, what is your?
Now say no, yeah, no. Yeah. The thing is, the MITRA clip guys are there all around the thing. The MITRA clip guys say that they are going to put a MITRA clip for a young female with a P2 prolapse also. There are reports of, with good LV. And their explanation is patients not willing for surgery. Personally, I wouldn't do it. I would do H repair only for the commissures, never for the middle of the leaflet. A to P2, mid of the leaflet. I don't do it. Very, very rare instances where we do aortic valve replacement or a Bental for a very dilated LV where we think it's an elderly patient, like a 65, 68-year-old patient, where we do an AVR or a Bental and you have a moderate MR where you think leaving off the MR or going behind the mitral was going to extend the cross clamp in a very, very sick heart, then we would do a Alfieri through the aorta, identify the midpoint of A2 and P2 and do a suture. only if the patient is elderly, more than 65, and LV is dilated, and we don't want to extend the cross clamp too much. There are very, very few instances, but otherwise we wouldn't do a Alfear as a routine, especially in younger patients.
Can you clean the camera?
Actually, there is some tissue deficiency at that area. I'm trying to bring in some tissue from the side to see whether it works.
Yeah.
If it's not working, then we may have to either augment the one of the leaflets or put an alfieri. Okay.
Yeah.
So these are the two options available right now.
So alfieri is mainly used as a bailout procedure.
Yeah.
In two situations, one is when there is a SAM,
Yeah.
you think there is a SAM. Second is like this.
But if you look at the long-term results of alfieri, it was not good because it was not supported.
Yeah.
But with the support, I think it should be all right. So we'll see how it works.
Hmm? Yeah, there is a small.
Forceps, forceps. I think that is working better.
Yeah.
Okay, but only thing that area.
That area there is a.
Yeah, little tether down. We'll see how is the little fill in then.
Jayakumar?
Yes.
If I may suggest, that first chord, is it a little short? The first chord, the first, that chord near that cleft.
All of them are equal length only.
Yeah, but has it little tethered a little bit there?
No, actually, I will show you now. Can you see it now?
Not really.
I will empty it once again and show you.
No, the camera is some off angle.
Camera, show please.
Yeah, better now. Yeah.
Because you see, this is how this leaflet comes up. Okay.
Yeah.
And this is how it comes up. But in between this portion, now it looks little because I have sutured forceps.
Yeah.
Forceps. So, since I have sutured it there into that tethered portion, we feel that it is going down. Okay, otherwise it is the same length as others. Okay.
Yeah.
That's why. I think most probably this will work. We'll just see whether the cooptation is adequate. Okay, 1 second. Just 1 second. Just get me this thing. That this triangular area, but that's okay, I think.
That's okay, yeah.
Yeah. Well, I think one of my pledges has come inside. That's okay. The
So this is probably that area where there was an additional, there was an additional straight jet somewhere that. So you're looking at the coaptation depth?
Yeah, I thought so because.
Yeah. Looks okay.
Hook. Forceps.
No, it's very difficult to judge from here. Mitral valve repair. Yeah. Because we are seeing only visual. This one.
I think it should be all right because I was worried about this portion. I think that area is okay.
Yeah.
Others should be all right. Yeah. So it's okay. So that's okay. I think we'll come off and see if there is something to go in. Eh?
Yeah.
Okay, that's fine. Yeah. Probably, if you ask me, if you want a very perfect result and don't want anything, this area is restricted still. Can you see that?
Yeah, yeah.
So maybe if we put a PML augmentation, that will take, because little bit more mobility here. That's what I feel, it is not there. Okay, that's why it's still holding on a little bit. So we'll see. Any other opinions whether we should have done better in any other way?
Not really. See this Patrick Perrier, when he came, he said actually if you think that fibroelastic deficiency and P2 is the easiest one to get a perfect repair, he said that is probably one of the most difficult thing, because lack of tissues and so.
Yeah, definitely fibroelastic disease with PML prolapse is not a very
straightforward.
Yeah,
not a very straightforward. Even though we started at the earliest repairs, it's not a very.
Just take it out.
It's not as easy as we think.
So end off. So this is how you go ahead with the closure of the
superior septal approach.
Superior septal approach. So that corner stitch is very important. It has to really take care of the.
Yeah.
And if sometimes the LA may be very thin, in that case I use some pericardial felt or pledget on either side, because otherwise once it starts bleeding, it's a headache. Bend off. Start rewarming.
The valve repair or the approach? I think we'll just accept it, and most of the times when the LV fills and the valve cracks, it should become all right.
I'll also do the same. When you are not very sure, trying to do so many things, it may not be. So most of the time it works.
Yeah, when you do a functional assessment, you actually realize that the PML is a standard fixed structure.
Yeah.
Because when we assess it functionally with a saline test, we look at the PML, we look at it, how much it comes up. But when you look at the TE at the end of the surgery, the PML actually is a standard structure. It is a rigid or like a door and a closing mechanism and a frame mechanism where PML contributes less, and it's the majority, 90% of work is done by the AML after a mitral valve repair.
Ventilator holding on ready.
If it is a small LA, it's better to go through a biatrial approach.
Superior
septal approach, yeah. It's a good size LA. Always a paraseptal approach is easier to go in, easier to close and come off.
Ventilate and
Sorry?
please.
45, 50. And for a demonstration, I think this is the best view. When you're doing a workshop for demonstration, this is the best view.
Ventilate.
Yeah.
Hold in. Some more saline there.
In a very difficult redo, we might do that, because approach, the view for the leaflet, for the mitral valve becomes very less.
Disconnect the ventilator. Disconnect.
Yeah. So recently, Indian Journal, there's a paper from Chitra, almost close to 50 cases. So at the end of this one, they had a lot of incidents of tachybrady syndrome in the immediate post-op, but at the end of 6 months, only 2 patients had sinus node dysfunction, but not amounting to requirement of pacemaker. But in Western, this one, they say that up to 12% of patients may require pacemaker. So I asked the same question to my cardiology professor, cardiology chief Natarajan, why Western people? So it seems that in West, when the tachybrady syndrome occurs in the ICU, immediately they will put a pacemaker, because they can then give a beta blocker and everything. So most of the time it may not be required. Because Yeah. So they actually, any tachybrady syndrome in the ICU, in the West, first thing they will do is to put a pacemaker, and then they will give all the beta blocker and everything. This one. So the incidence of pacemaker will be high in there.
I think in our society we afford to wait and watch.
Wait and watch.
For medical legal reasons, I don't think they can wait and watch.
But that Chitra paper recently came, sir, some 6 months back.
No, permanent pacemaker. When they talk about pacemaker implantation, they talk about permanent pacemaker implantation. Sometime later. I think within the first 6 months.
Which one?
The PPA implantation, PPA need.
PPA need in West is mostly in the patient in the ICU.
In the ICU.
ICU itself, they take the patient and put the implant. But this paper is followed up for 6 months. It's a good paper from Varghese Pankavas. So they had only like 2 patients who had got sinus brady, but no incidence of pacemaker.
So of the 50 patients, none of them needed a pacemaker.
Pacemaker, no. Shiva, you are also doing something like that. No? Are you doing some work on that? Huh? On this superior septal approach? Shiva, did you do some work here in when you are in Kottayam about the superior septal?
What's your returns?
Very personal and very political question. And if you say something, no, we may not have room in the back of the papers. Yeah, so I think it's just a.
All three companies make the same things, kind of.
The philosophy behind it is
anteriorly flexible, easier to implant. I mean, with their own little caveats here and there. So whatever you are comfortable with.
I think close to 20 or 30 rings are there in the market. Each company have their own, like 3-4 different types of ring. CG Futures, I think they have a 3D profile, Medtronic has 3D profile, then they have a band, and then the Simu form. Similarly, Edwards have.
3D profile is more rigid ring, which is used, and it's. Means earlier we used to use. The grading of ischemic MR was quite different. So those days for moderate MRs we used to do angioplasty. So those we used to use 3D profile. But after we stopped addressing those moderate MRs very aggressively, we accept moderate MRs, ischemic MR I mean, we've stopped using, but 3D profile doesn't have much role now. So most of the rings right now used are semi-rigid, semi-flexible rings.
Shall we go to some other topic?
Till the heart ventilate, roton.
Next case or?
I think shall we have the discussion about the other case by now so that I can from
Can we start the second case discussion? Hello, Manjusha.
We will call her. She's here out. We'll arrange it now.
Yeah, can we present the second case?
Hello. Hello.
Okay.
Hello.
Yeah, we will have a discussion on the second case.
Okay.
The case presentation. Then we'll go. Have you induced the case? Second case?
Yes. Patient is ready. Hello?
Okay. Then we'll go look at the TE.
Sorry, just 5 minutes. I'll just get the machine to the other OT. 1 second. So we can check that case also. Just 5 minutes. 1 second.
Yeah. So we will have a discussion here. Case presentation here.
Okay. Okay. Yes. Okay, sir.
Yeah, Lalit. Yeah. Can you introduce yourself?
Good morning, faculties. I'm Dr. Gokul, second year resident at City West Kottayam.
Gokul is Dr. Manoj, sir. His father is a very famous cardiac surgeon in Aster. He was in Amrita earlier, and father is Manoj Nair in Astor. So,
Can I start?
yeah.
So we have a 30.
Can we change our this? Sir, can.
So we have a 38-year-old male patient came with complaint of dyspnea on exertion, class 2 with orthopnea and PND, and there's no comorbidities for the patients. So vitals were stable, heart rate around 80, BP 130 by 80, bilateral chest, fine cribs and pansystolic murmur in the mitral area. And ECG, there's no ectopics in sinus rhythm, and patient is having LVH suggestive of tall R waves in lead 5, and X-ray is within normal limits. So echo-wise, LAAO dimensions were 4.64 and 2.24, and left ventricular null diameter diastole by systole was 6.8 and 4.12, and EF was 69%. And on echo, there was a mitral valve prolapse, AML A2 prolapse with severe MR and posterior directed eccentric jet. And annular size was 4.2 centimeters and mild TR and mild AR. LV was good and mild PH. And coronaries, there was a proximal Primus 90% lesion and RCA mid CTO. So now handing over to Manjusha ma'am.
The ejection fraction is how much? 69.
69.
So it's a good left ventricle.
Yes, yes sir.
Yeah. Dilated,
Yes,
very
sir.
dilated, and there's a
Yes, sir.
posteriorly directed jet.
Yes.
Okay, posteriorly directed. Okay. So it's not it's not a central jet.
Posterior jet, sir.
It's not because of dilated. It's probably tethering. Tethering of the,
Short history, 1 month duration first.
Can you hear us, Dr. Jayakumar?
I can hear you.
Yeah, good. Have you ever had any problem with the superior septal approach at the aortic level, at the top, just near the LA?
Yeah, that is one area. I never had a problem so far to shoot, but the thing is, suppose one thing which can happen is the left atrium can be very thin, and when you are trying to take sutures, it can just give way. So actually, in one of the cases recently I did, the left atrium was thin, and I had to just take it through the aortic adventitia also and close it off.
Yeah, you sometimes need the help of the aorta.
Yeah, we can use. Yeah. So that's,
Yeah,
that's
we
okay.
had a similar problem once. So what we started doing is we use a pledgeted stitch first to start with. We just don't do it without a pledget. Never.
Yes, sir. Yeah, sir. Actually, if I anticipate in advance, like a thin left atrium, sometimes after cutting open, no, I put pericardial long fell, and then take the horizontal mattress sutures, and use only 5-0 for the LA roof. So then I finished the remaining. This case, I used the same suture.
Yeah, it is
So,
fine.
and then I just came back. But that was,
It was a very healthy looking wall, yeah.
yeah, that was good. Yeah, that's it. Manjusha is just getting the tea ready for the other case.
Yeah, Dr.
Yeah.
Jayakumar, there was a nice question. Why did you put a pulmonary vein vent? We normally have the.
Yeah. No, yeah, I usually put it in the mitral case, like, no, better to keep the field dry, because putting the vent through a separate is the same incision.
Yeah.
Many times it comes in front, especially when we are demonstrating.
Yeah.
It comes in the way of the camera, so it's better always to have a separate one. In an adult, I don't worry about putting a pulmonary vent.
Okay, just because you are in the demonstration situation, right? I can understand.
Yeah. Even otherwise, most of the time we go for the right superior because it will stay out.
Yep.
We don't have to,
Yeah.
But if it's a pediatric case, of course I will not. I'll be going for the same, like left atrium or right atrium where we open.
It's okay. I got a bin here, right?
So, sir, what is your choice of cardioplegia? The same delta you use, sir?
Yeah,
That
I'm using St. Thomas.
Oh.
I just use St. Thomas and repeat it, yeah.
Right, okay.
You've used only a single plegia today, so we finished
Yeah.
quite fast, yeah.
Yeah, most of the time, only when we go for some, say, redo cases or, say, aortic root work, sometimes, sometimes we land in trouble, then we have to otherwise.
Yeah.
It takes away a lot of our headache. Previously, we had every 20 minutes looking at the time, giving plegia, then again,
It is quite comfortable. And I think myocardial protection is fair enough. We don't. There is one argument saying that you get some amount of RV dysfunction with Del Nido. Do you have any experience like that, or you feel it's comfortable?
Do you prepare it in-house, Dr. Jayakumar?
We prepare it in-house. Yeah. Is there a commercially available solution for Del Nido?
I think custodiol is available, but
yeah,
not the Del Nido one.
Yeah. Custodiol we use only for transplants because it's too costly, but it's difficult to get nowadays. The supply is a problem. At Medanta, you must be using a lot of custodiol, no? Because
sorry?
At Medanta, you get a lot of custodiol. You use a lot of custodiol.
We are using same age-old St. Thomas.
Oh, same.
Multi-dose.
Okay, right. Why? Any specific reason why?
Just never had the courage to shift to
Okay,
a new cardioplegia.
Okay, sir. So I think Manjusha is ready with the next case.
Hello, am I audible? But
yes, Dr. Manjusha, you are audible.
Yes, okay.
We need a bit of volume from your side.
Switch off this camera.
Hello. Okay, is volume okay? Yes.
Yes, it is.
Okay, fine. So this is our second patient, as Gokul has already said. He's a younger patient. He had a history of paroxysmal nocturnal dyspnea 1 month ago. He's on anti-failure medications. So this is his echo. So again, we are starting from the 0 degree mid-esophageal view. So we are seeing immediately you can see that there is an anterior leaflet. It is again, there is a flail segment here, and it's a completely posteriorly directed jet. Usually these kind of images, it's always good to freeze it and go frame by frame, because when you're seeing an obvious jet, sometimes you might miss minor jets which may be there. Because of the big jet, they may be masked. Second, this is the same view. Now I'm advancing to the commissural view. So here you can see the LA appendage. So the segment, this is the P1 segment. This is the A2 segment which we are seeing here, and this is the P3 segment over here. So it's an A2 prolapse. So again, it is, just like the first case, this is a large segment prolapse. So probably the jet you're seeing is all over the place. This is the 90-degree view. So 90-degree view, so just like what I showed in that image, you're seeing the anterior leaflet flail here, and you can see that this is a portion of the, this is a portion of A1, and this will be the portion of A2 which is going like that. The leaflet here will be P3. Again, it is a posteriorly directed jet. The question is there any other differently directed jet? That's the issue here. Like, there is a small jet over here. I'll tell why I'm just emphasizing on that, because when we come ahead, this is now the mid-esophageal 120 degrees LV long axis view. So we can see that this is the anterior mitral leaflet. There is a flail. It's a completely posteriorly directed leaflet. But the additional thing is that the posterior leaflet is not coming up to the annular plane. So is there an additional issue here? That is the question. So again, if it is not coming up, again it is going to cause a posteriorly directed jet only. So that is only additional concern I have for this patient. The distances are okay. ALPL height ratio is only, it's 1.7. It is okay. C-sub distance is well away. It is 3.2. Coming to the, this is the transgastric view. So here, short axis view of the mitral valve. Actually, I prefer this view because sometimes if the 3D images are not good, if you can get a good image here, again it is informative. So there is a prolapse. Is there a cleft in this portion? That is one doubt. Second thing is that the indentations of the PML are a little prominent, whether it's at P1 or it's at P3. This is the AML PML length. AML length is coming to around 32. Some portion of that prolapse has been excluded, and the PML length is 1.8. So this is the 3D phase view of the valve. We can see that there is a A2 segment. Definitely there is a flail here, but is this portion, is there a cleft over there? That's a doubt. So in these cases, I usually prefer to have a ventricular phase view, so you can see the coaptation better here. So one thing is that definitely there is a cleft that is between A1 and A2. You can see that here. And in addition, the indentations on the posterior leaflet are also a little prominent here. Here we can see that this is going to be P1, this is going to be P2, this is going to be P3. So this is a frozen image. We can see this is the cleft which is going all the way here, and these are those indentations on the posterior leaflet. You can see we can appreciate it much better here actually. So those are the additional morphological findings in this case.
Is this the ventricular view?
This is the ventricular view, because sometimes I find it easier to see the morphology well from here rather than from the atrial side.
Can we have a look at the atrial side again?
Yeah, yes.
There looks like a doubt of a papillary muscle rupture there. What is that little tissue there?
That's that AML flail with that segment which is coming here.
Yes.
So there is definitely caudal. Yes. There is a caudal rupture.
Yeah, it could be a tip of a papillary muscle there.
Okay. Maybe, but.
And that will explain your posteriorly directed jet.
Yes, it's a posteriorly directed jet really.
Yeah.
Then.
And a little annular dilatation would have caused the posterior tethering, which means the angle of the posterior leaflet is down.
Yes. But there is usually when that happens, there is usually a little RWMA, but there is nothing like that for this patient. I'll just show the long axis view again. So here, that LV geometry doesn't seem to be too distorted actually.
Is the LV dilated?
Yes, LV is dilated.
What is the dimension?
LV dimensions on transthoracic echo. Just show those images. T usually sometimes there is some underestimation actually. Even if you see it, end-diastolic dimensions here is 7 and systolic dimensions is 4.8.
Very much
That's
dilated.
big. That's a big LV.
Yes, a big LV. And I've always felt the best place to start your assessment is always with the patient. So actually, he had already contacted me 1 month back, giving classical symptoms of paroxysmal nocturnal dyspnea. He had a lot.
Your lights gone off. We can't see the screen. Yeah, it's back on.
Yeah.
It's back on. Yeah.
Yes.
Please go on, ma'am.
Yes, so those are the issues. So to summarize for this patient, there is definitely A2 segment, there is a flail. It looks like there is a cleft between A1 and A2. The indentations on the posterior leaflet are a little prominent, plus the posterior leaflet, there is a little restriction. It's not coming up to the annular plane, especially at that A2 level. And his LV is definitely dilated.
Yeah.
Yes. T for this patient.
So what do you think is the etiology, Dr. Manjusha?
It looks like that caudal rupture, and because he had an acute onset of symptoms just within the last 1 month, and that coronary disease was incidentally detected as part of the workup. He didn't have any other symptoms, and it is mostly only heart failure symptoms.
Is he marfanoid, habitus?
He's a little well-built, but not marfanoid. 90 kilos.
Can you hear me?
Yeah, we can hear you.
Yeah, we are off pump and we are on minimal supports. The BP is around 100 and I've kept him on pacing 90. I didn't see whether sinus is there or not. And so CVP is around 12 or 13. Saturation is okay. Ventilation check, yeah, 18. Yeah. So we'll just see the echo and then you can discuss on the TE of that next case, okay? So that I will just get out of this place so that I can move to the other table. Okay, is it okay?
That sounds good, yeah.
Yeah. Yeah. She is Manjusha. Is the TE shown? Just can you connect the TE to the seminar hall? Can you see the TE in the screen?
No, not yet, not yet.
Yeah, we are getting it right now.
Yeah, it's come now.
Okay. Okay. Some more filling. You can fill a little bit more. What's volume down? It's okay. Ventilation is there. No, some more volume. Okay. Can give some more volume. Are you seeing it?
Yes.
Hello, am I audible? Okay,
Yes.
fine. Yes. So whenever I start a post-bypass assessment, usually I'll always start, again, what I'm reiterating is your hemodynamics have to be good before you see the valve. So usually I'll just have a first look as a transgastric short axis view, the ventricular, all the walls are contracting well or not, how is the volume status, you'll get an idea with this.
Volume.
It's only after that that I usually go to the valve. So this is the repaired valve. So always it's good to have a 2D assessment before you start putting the color. We can see that the leaflets are meeting well. Coaptation seems to be adequate. There is a small jet. Okay. There is a tiny jet. That is, again, it's a small jet. Our pressures are 130.
130.
Mean BP is 76. Vena contractor. Vena contractor is 0.2. Okay. So we'll just go to the other views also. Fill the patient a little more. Okay. Now I'm advancing to the bicommissural view. Again, there is a jet actually. It is. So there is a MR jet actually close to the medial lateral commissure actually in that area. So we'll see the. It's a short jet. It is not extending into the LA. It's okay here. This view, it looks good. Coming to the 90-degree view, again, there is a little. Oh, yes. Good fills here. Volume. Okay. So, is there a small component of. There is a flow turbulence in the LVOT. Can everybody appreciate it actually? There is. Then that is causing an MR jet actually.
കുറച്ചുകൂടെ വോളിയം ഫിൽ ചെയ്യണ്ട some
Volume കൊടുക്കണേ.
Are we off totally at this time, or we are still on partial bypass?
We are off. We are off.
It looks like that. It looks like a dynamic MR. We'll just go to the access one. It's hypercontracted. So it's okay.
It can in some patients.
Yeah.
Yes.
So this is the LVOT.
I routinely put atrial wires and pace atrially as far as possible.
Is it because it's
In this way. One more atrial wire. We'll put an atrial wire and okay, this is one case where I was again anticipating a small jet at that particular area, but right now Manjusha is saying it is near the lateral commissure rather than this thing, no? Or so in that case, if we are going in, what is the next we can do? We'll see. Anyhow, right. Most of the time, I think it will settle down. It may not be a significant one. Or try then, I guess. Silk tie, number 2, hold it. Hold it, hold it. Even though there is some flow acceleration seen at the LVOT, I feel the cooptation is still posterior only, isn't it? It's not very anterior.
No.
Even if it is some mild.
Looks like something which we can control with hemodynamics probably.
Probably atrial wires and then AV sequential. No?
So it's only a very small jet actually.
Looks better now.
Yeah, it looks much better now.
Looks better.
Sometimes because of that, does that pacing actually cause a problem? That septal dysynchrony, and does it add to issues?
Let me see. Let it be there. Let's see whether it's...
Okay.
It's atrial.
Okay.
Cardiothoracic.
Now that jet has, it's not as much as it was there before. Is it a subvalvular thing?
Plants. Separate. This is
Wait.
clamps, knife. Is there an MR? Or is it?
Okay, that MR has gone anyway. The flow acceleration is actually happening inside the LV. It's not a valve per se, but it's around this portion that it's in within the LV that there is some flow acceleration. Other than that, the MR has come down. Coaptation depth is There is a good coaptation height is 9 millimeters. We'll just check the gradients also, transmitral gradients. Peak gradient is 8, mean gradient is 4.
Section cadet. Switcher. Right hand. I'm distorting the heart a little bit. You're comfortable, eh? Backhand. Backhand.
It looks otherwise good. Valve is opening well. We can check a 3D valve area. I'll do it shortly and just inform. But even with 2D, opening seems to be... no. 3. It must be a little overestimated, but otherwise it looks good. So the rest of the things I think we'll reevaluate after hemodynamic optimization. There doesn't seem to be an indication to go back at this point anyway.
We agree.
LVAT, VTA is a little more, but it is probably just mild. We'll fill the patient a little more, optimize the hemodynamics a little more, and then come back. So one of the things which, since we were talking about that elevated gradients, so the question is, one index which you can always check is the dimensionless index. Or you can, what is the role for actually, is there patient processes mismatch for mitral valves when, just like we have it for aortic? It's a question.
Usually not. Usually not.
Usually no, because around 7 months back we had a patient. She had she came back after mitral valve repair. Valve area was good. Otherwise, there was no gradients, nothing. But her functional class was not good. She was still having symptoms. Finally, and post replacement, she did very well. So the only question there was that area which we got when indexed to her body surface area, was it not enough for her? In this case, everything is good. Numbers are good. Dimensionless index is less than 2.1, it's only 1.5. Indexed valve area is 1.8. LVAT, the velocities are slightly on the higher side. Peak velocity is 1.8, but mean gradients are only 5. Coaptation depth was 9 millimeters. So,
how is that
any
MR
comments?
Yeah.
It's once you've gone into the rhythm, it looks much better.
Yes,
now.
yes,
it
yes,
looks much better.
definitely. Especially because this patient, he was already a hypertensive, and he had some amount of LV hypertrophy. Like even the septal measurement was 13, and transthoracic also they got 14. So for these patients, sinus rhythm is very important.
Very important.
Very important. And he had some diastolic dysfunction also. So those are the small things which will add to the big picture, rather than again just going behind just one number or just behind one jet. Hemodynamic optimization is very crucial.
Can you just show that MR jet again? How is it?
I think it has come down from before. One second, sir.
Section cardiotomy.
Now the LV is looking much better with his own sinus rhythm. That septal dyskinesia has gone out.
This is mild, less low, mild, trivial to mild.
It's a very trivial jet only. We'll just see again. RV is good. LV is a little. We can actually feel the LV a little more. Is what I feel. There is still some flow turbulence actually. That's all. Right now we are in the 0 degrees, we are not seeing it. We had actually seen that small jet in that commissional view, but now it's almost not there.
This is section.
Yes.
It looks good. Looks
Yes,
very good.
it looks very good right now. So it's always best to have a staged approach. And I think for this patient, definitely sinus rhythm is going to make a big difference. So we'll probably have an ATM pacing there also.
Are you seeing any jet now?
No, there's a very tiny, very tiny one here. That's all.
We look good, Dr. Jayakumar.
It's good.
Looks very good. Looks very good.
We can move to the next patient.
Yep. Looks good.
Yeah. I think that initial thing could be due to that flow acceleration
yes, it's
and
still there,
underfilling, probably something like that. But coaptation height is good, and I think gradients are fine. Yeah. So, thank you so much. Thank you.
Thank you very much. That is very good.
Thank you.
Thank you. Back to the other case.
Yes. Can we have a presentation in the meantime?
Dr. Jayakumar, are you there? Should we have a presentation in the middle? Can we start a presentation because we are waiting? And we can stop the presentation when the stuff starts again. Or
Does the audience have a question? You see, what I do, I'll tell you what I do. For a valve that is for Barlow's or myxomatous valves, I fill up the ventricle after repair and choose the whole valve. Use the whole valve as the sizer. Of course, when I'm putting in water inside the ventricle, I use the ink test also to see how much the coaptation is. And if the coaptation is say 7 to 8 millimeters, then I use the whole valve as a ring size. Yes, use the whole valve. For rheumatics, I go by the anterior leaflet size. For ischemics, I go maybe one size down. I always downsize for ischemics. Yes. AML height. Yes. Yes. For myxomatous. No, but we did not resect in this case. Oh, you mean the resection would have been better? No. You see, leaflet tissue was very less, and it opened even artificial cords opened up the the wedge between P2 and P3, the area between P2 and P3. So resection would not have been a good idea, retrospectively at least. Sorry? Yes, my idea of ring is very, very different from what is discussed. For rheumatics, I always choose a rigid ring. And for myxomatous, I will use Carpentier Physio 2 ring. And for ischemics, again, I will use a rigid ring.
Is it clear?
That's what I have found.
Clear?
My results with rigid ring last 10 years are very, very stable. What happens is 70% of these myxomatous patients, they come back with, they have, if you examine them 7 years later, 5 or 7 years later, 70% of them will have mild to moderate leak. And that leak will enlarge in the area where there is no rigid support. But if there is a rigid support, that leak will not enlarge that much. So in all patients where I have had a semi-rigid or soft ring, their leak progressed very rapidly. In all patients. So my choice of ring is always rigid as far as possible. But in myxomatous, where there is a chance of SAM, I would like to use a semi-rigid, and that too Physio 2. And remember, Physio 2 is always 2 or 3 millimeters larger than the sizer. If you see the ring, if you size the ring after implantation or before implantation, using the sizer is always 2 or 3 millimeters smaller. So that should also be taken into account while using a Physio 2 ring.
Carry on. We'll continue with one presentation. Dr. Praveen, please.
So, first of all, thank you for inviting me. So this is about mitral valve analysis by a surgeon. So first thing we should understand is that when Alan Carpentier started his mitral valve repair, there was no echo, there was no TE. So his classification was based on purely surgical analysis. And then later on, echo actually corroborated his findings. So as Dr. Jayakumar said earlier, many of us, we all started our mitral valve repair program. I started in 2002 without having a transesophageal echo inside the OR in Srijitra. So we were all, I saw Dr. Sylvian Shaward in one of the workshops in Hyderabad, and he was explaining to us how we can analyze the valve. Of course, at the current scenario, this may not be a good practice not to have a transesophageal echo inside the OR. But a surgeon can always, or most of the time, by analysis of the valve, can find out what is the pathology and make a corrective action. And of course, you should always have an echocardiograph and look at the echo. So basically, when Dr. Patrick Perrier came in 2019, he was looking at only the direction of the jet. So he told me three things. When the jet is anteriorly directed, it's a posterior mitral leaflet prolapse. When the jet is posteriorly directed, it's an anterolateral, it's an anterior leaflet prolapse. And when you are not sure where the jet is coming from, it's almost always it's coming from the commissure. That is so he was not actually looking at all those parameters and looking at the measurements and everything. He was just looking at where the jet is, and then he was doing the analysis. So that is a classical Alan Carpentier's way of doing things. So this is a video of a few cases. Some of them are mine, and most of them are mine, and I think there are 3 cases. One case is, I think, was done by Professor Perrier when he came. So, it's a completely a video of repair. So this is how we look at the valve. First, we take all the annular sutures. So exposure is very important. Most of the time we go through left atrium, but some of the cases we go through a superior septal approach. And this is the first is the look at the valve. So this is a classical Barlow's valve. That is the fourth type of myxomatous disease. So fibroelastic deficiency, FED plus, then formi frustae, and then this is the Barlow's valve. When you have a lot of thickened valve inside annulus, then you call it as a Barlow's valve. So you start with the P1, that is the P1, that is the reference point. So it's only very rarely that you get an isolated P1 prolapse. So if you have a P1 prolapse, usually it is associated with the A1 prolapse. It's a commissural prolapse. So P1 is the reference point, and you measure you look at the all other areas referring to the P1. So if you look at this patient, he has a large P2. Look at that, that is a P2. So you got a large P2, and then there is a small indentation, and then the other part of the P2 also there is like a ruptured chordae. So that is the A2. You can see that sometimes it is very, very difficult because of the bulky valve actually to look at the comparison. See that P2 is coming up. So that is the P1. So that is the P2. So the P2 has got two portions. One is on this side and on the other side is on the other side. In between there is a small area where it is normal. So you can see the ruptured chordae. So when you look at the valve, and then what we do is that we pass a 33 mm onyx sizer into this one and look at where the ruptured chordae are there. You can see there are like two ruptured chordae. One is there, and you can see there is another one on this side, on the anterolateral papillary muscle. So this is the basic thing what we do. That is, we look at the P1 and each area, like that is the A1 P1 area. There is no prolapse, and that is the A2 P1 area. Why I am using a right angle is that the second hook is a little sharp, so I am worried whether it will perforate the PML. So that's why I am using this right angle to this one. So now you can see see this is a classical prolapse because of the flail leaflet. So when you have a ruptured chordae there, it says that it's a flail leaflet. And with that sizer inside, we were able to identify where actually the ruptured chordae is arising from. So one ruptured chordae was coming from the posterior medial papillary muscle, and one ruptured chordae is coming from the anterolateral papillary muscle. So when we use artificial chordae, we try to correspond it to that level of where the ruptured chordae is. So segment by segment we analyze. Now if you pull, can you see the cleft between the P1 and P2? P2? That area is a cleft. But most of the time we don't do anything for the cleft, and so this case, we usually put an artificial chordae in this case. So that is one way of analyzing it. Second is that I will also show you how we use artificial chordae. We don't use measured chordae. We try to put an individual chordae into each this one. So this is also another step. This is only for, I usually don't do this, but this is only for demonstration, that we measure actually the length. So it's actually a good idea to start measuring each segment, P1, P2 and P3 with a thread. It's a little cumbersome, but with a thread you can look at the measurement of each segment. So this is the measurement of P2, the length of the P2. Yeah. So it came to around 2 centimeter. So any posterior leaflet prolapse or any posterior leaflet that is more than 15 millimeter there is a chance of there's having a SAM potential. So this patient has got a large posterior leaflet, but it's not very large. It's only 20 mm or 2 centimeter. And similarly, we measure the anterior AML length also. You pull down the AML. So this is only for demonstration purpose. We now don't do all these things, but this is for beginners. Like it's a good idea to actually measure the length of the PML as well as the AML. I think it came to 34 mm. So if you listen to the anesthetist talk, it is not the actual PML length alone that matters, but it's a ratio between AML and PML. If it is less than 1.3, there is a chance of SAM. So this patient had 35 mm AML and 20 mm PML. So the AML PML ratio will be roughly around 1.7. So there is not much chance of SAM. So that's how we can think whether the SAM will occur. Then what we do is that we don't do this now, but for demonstration, where we are going to place the artificial chordae, and then where the artificial chordae was ruptured, we take the 2 artificial chordae. So it is important that you don't cross the midline. So one chordae should come from the anterolateral papillary muscle where it's ruptured, and other comes from the posterior medial papillary muscle. And how we adjust the chordae is this also by Professor Patrick Perrier's method. It is like a Freighter stitch, what we use for aortic valve. So you take sutures from the anterior A2 and P2, then A1 and P1 and A3 and this one, and pull it together, and then tie the chordae, so that the chordae will never be long or short. It's actually quite a simple technique, but may not be very easy through minimally invasive approach, but with the open approach it is quite. Can you see that sutures? These are the sutures, and then you just tie the sutures. Did you understand the concept? Yeah. So your assistant should pull all the 3 sutures tight, and then you just go on tying the chordae. So we typically put 12 sutures. Which one? So first comes from the A2 and P2, the middle, and then the other side. Which one? Which suture? The chordae. Tip of the leaflets. Yeah. So this way, chordae can never become short or long. Most of the time it becomes okay. So this is after the water test. So yeah, one way of looking at it is that once you fill the heart with the water, you should never see the chordae. If you see the chordae, that means that the chordae is long, because chordae has to be in the rough zone. You understood? So if you see the chordae at the water test, that means that the chordae is long. And then you look for the smile, and you can see the chordae inside. Then we place the ring. So this was a saddle ring, and finally you should see that smile. So this is another patient, the same thing. You are seeing the P1. So we always take the annular sutures. We place 4 sutures in the anterior annulus, and rest of the thing we fill it up with the sutures. I take more sutures on this side because that area is thin and the circumflex is there. So if you put big sutures, first thing is that it can tear off. Second thing is that it can cause a concertina like compression of the circumflex. So put smaller sutures on this side. So this is also Barlow's disease. You can see that there is no prolapse of the A2. Sorry, there is a prolapse of the A2. So this patient is actually a bileaflet prolapse. So she had a P2 prolapse as well as an A2 prolapse. So same way we are putting the that sizer. We found it actually quite useful to see the papillary muscle. So this side is anterolateral papillary muscle and that side is the posterior medial papillary muscle.
You only use the onyx sizer, is it? Because that has it on the side.
Yeah, that's a onyx sizer, but because that is we have only 2 valves in our this one is onyx and chitra. So that's why we use this onyx sizer. Any sizer can be used.
No, it's got to stick on the side. The handle is on this side. The other one have it in the middle.
I mean, I just used onyx sizer. So I find it actually quite useful. So when you are taking a suture, I mean, chordae for anterior leaflet and posterior leaflet, we take the anterior leaflet chordae from the anterior head and posterior leaflet chordae from the posterior head. And we try to take it through there is like a fibrous head. Most of the time we take it through the fibrous head of the papillary muscle. We use Cooley's retractor. We have a self-retaining retractor, but it's very difficult to arrange this one. So most of the time we use Cooley's retractor. So that is to the posterior medial papillary muscle. So in this patient there was no posterior head of the posterior medial papillary muscle. So I had taken it from there was only one head. So I had taken the sutures, both AML and PML chordae on the same head. We found this sizer very useful. But for minimally invasive, I think they have a Senjude, there is you can keep it inside it, and then it will retract all the see there is no head there is no posterior head, there is only single head papillary muscle. And make sure that when you place the chordae, you don't entangle the other chordae. So same way we marked where the prolapse segment where we are going to put the artificial chordae. So it is much better to place the artificial chordae at least 4 or 5 millimeter away from the free edge. Hmm? No, just a pluggeted switcher. One plugget. So one codec comes, one of the arms of the codec comes straight, the other one we use it like a figure of 8. You can see the other one. So this is a figure of 8 stitch. So one chord is taken as figure of 8. So same way we use this freightes kind of stitch. What is that, sir?
Not at the margin. Not at the margin.
Not at the margin. It is 4 millimeter away from the margin. Yeah. No, it is on either side of the midline. Either side of the midline. Now in bileaflet prolapse, it is a little tricky to adjust the chordae. So what we do is that this side of one segment will be normal. So we adjust the chordae depending on that plane. So this segment is normal segment. So we are going to tie it based on that. Can you understand?
A1 is normal.
Yeah, A1, this area is normal. Yeah. That is my reference point. Then you just tie. So if your assistant loosen this, then all the chordae become short. So when I was looking at how to measure for the neochordae, I found 40 techniques, different techniques. That means that none of the technique is perfect. You will have to, have your own technique, adapt your own technique. Because when you have multiple techniques, that means that there is not a single perfect technique. So this patient was done in 2019, some 5 years back. Some old slide. Yeah, it is recorded by a scope camera. Yeah, this is the final result.
Even before ring implantation. Even before ring
Yeah,
implantation. Looks
even before
extremely
ring
good.
implantation. Yeah, she's
Nice.
still coming for follow-up. 5 years, there's no MR. So this is a very useful technique I learned from Professor Perrier. This artificial chordae. So artificial chordae is now our standard of care for all degenerative valve. And why we did that is that first thing is that if you start resecting, clefts will open up. Second thing is that artificial chordae, even if we fail at the first time, it also gives you multiple options on the next time. Like next time you can go and resect or something like that. But only worry in artificial chordae is patients who have a SAM potential. In that case, you have to be very, very careful. In that case, we shorten the chordae a little bit, posterior chordae a little bit. Thank you. Where is my, this one? Can I take this? Which one? This one, not this one.
We can get back to the theatre. Can you all hear us?
Is my this thing open on? Can you hear?
Have you finished the case? Hello?
Hello, can you hear me? Hello? Hello?
Hello?
Hello?
Hello, can you hear us?
Have you finished the case?
Hello?
Hello, can you hear us? Can you hear us?
We can hear you, Dr. Jayakumar.
Yeah, we are on pump and I have done the distals for the PDA and the ramas. Okay, and now I think I opened the array, just closing the array and then going inside the, I think the LA is dilated, actually the LV is very big, dilated, and the PA is bit tense here, and so since the LA is big, I thought I will go for the usual transatrial approach. The retractor. Can you see it now? Yeah, I'll get the camera. I'll just organize the camera in a minute. Yep. Table up and away from me. Bend down. Bend. Lab camera on ako, light on ako. Light on. Table up, please. Table up, korchum Given knock. Clean the saline clean. Saline clean. Chumar saline tanas. Clear gossip there. Okay. All right. Yeah. Always keep it up. Okay, this should not move. Okay. Okay.
Can you zoom out a bit more?
Yeah, can you see it now?
Yeah, we can see it, but need to zoom
Are
out.
you comfortable? I think.
The lens seems smeared.
Click. Cylinder. Okay.
It's better now. Yeah.
Yeah, it's better.
Cardiothoracic.
So what is your plan, Dr. Jaikumar, looking at the echo?
I'll just see the valve and then clean the camera.
The lens, please.
Yeah, I'll clean it. Right. Even if this is you have to show it properly. Okay, you just concentrate on that. Can I zoom in a little bit? Yeah, forceps. Just holding on to the P1. So this is P2, and you can see the entire. I think, as you have rightly pointed out, this is rupture of the papillary muscle.
Yeah, it looks
so
like that. Yeah.
Yeah, this is a ruptured papillary muscle, and the other areas are fine. Okay. So again, we will be going for an artificial chordae here. That will be the plan. Okay. Yeah, I will get the annular sutures. Okay.
Yeah, she had, must be ischemic rupture, looks like, because he had OM and a RIMA. A ramus intermedius and a right. She must have had a small infarct somewhere.
Could be, yeah, it's a yeah, could be that one. Otherwise, the leaflet, this is not a myxomatous, doesn't look like a myxomatous valve or anything. No, the leaflets are same only. Yeah.
Just would like to ask you, suppose this was an acute rupture.
Yeah.
Would your plan would be different for fixing the chordae of the papillary muscle, or because this is chronic, you can go for artificial chordae?
Yeah. In an acute case, now again, it depends on the particular scenario. Like once you open up and if the tissues are good, but if it's an infarcted area, I may prefer to go for something else rather than fixing it back. Once it becomes chronic, of course, yeah, you will be able to fix it better. That's what I feel. What is your opinion, sir?
Yeah, I was just asking you because I did one case acute where we managed to put the pledgets outside the LV and use the LV as support. We went through.
Okay, right, yeah.
We put artificial chordae, but we went through and put the support from outside the left ventricle.
Okay.
But we were really scared. Maybe the whole thing was ruptured.
But then to adjust
it's coming up. Yeah, now they're coming up with the idea of percutaneous cords as well. You can just do the same thing, but percutaneously.
Yeah, but in this case, I think there is LV dilatation and annular dilatation. We may have to deal with that also, no? Because the patient is young, otherwise healthy, active. So I think just putting some cords alone without annular support may not be long lasting, no?
No, I think everybody agrees on the putting an annular a ring. But I was just asking how you would fix the chordae on the papillary muscle area. That was because it may be friable, maybe
that is one challenge. But sometimes we can put it in the LV itself, where you have a good which is not infarcted in an acute situation. As you said, trans LV I have not done so far, but I have put it into a healthy area. Means away from that. Only thing, the length may be different. It takes a little bit of, eyeballing or measurements and then adjusting and all, no? When you're putting it back. because it may not be the papillary muscle alone which is infected in an acute case. Right now we have one case, I told them not to send it today. Patient is on ventilator in one of the private hospitals nearby. They are asking for a repair. Patient is stable on ventilator. I told, okay, wait. Because so what is your thing? Suppose the patient is stable. Will you wait on that patient or take it immediately?
Patient's got an acute rupture on ventilator.
Yeah.
Oh. You will have to do it early because you can't wait. He probably won't come off the ventilator.
Yeah. So that patient had an MI 2 weeks back, now on ventilator for almost 1 week. And then now they are referring, okay, for a, they say, because the same thing, they could not wean off from the ventilator. So I told maybe by Monday they can send off because the techno college and other things, and patient is otherwise doing well. So I told it's okay. By Monday we will take up. Is that okay, or you would like to do it off? Because logistics has to work, isn't it?
You could have brought it today for the workshop.
Now the problem is workshop is fine, but then post-op, we are organizing the techno college also, so we will be there. So I don't want to have a sick patient in the ICU when we are all away, no? Like only the residents will be around. So I thought it may be safer to. And I talked to the cardiologist. He said, okay, wait, no issues. We are keeping him on ventilator for 1 week. And he is better. And he is hopeful that he may be able to wean off and then send also. Like, okay, I said, okay, you see. Yeah. Backhand, same.
So you're going to have basically be doing an acute case now after this in a couple of days.
Yeah.
That was my question actually.
Yeah, yeah. That's what we were discussing here also, like, when to take up. Now, of course, immediately only we usually go ahead, but there is something with the government institutions and this thing, Already we have one patient in our ICU, VSR on IABP, okay. And usually we put them on IABP, then stabilize a little bit and then only take up. Then one more patient coming up, I thought, okay, we'll wait. So what was the circumflex in this case? Was it away? I didn't see the detailed echo. Did Manjusha told anything about that?
No, we didn't see that. No, we didn't see it because we were discussing the other case.
Oh, yeah. Right. Now, one thing, like suppose already the patient had an angio, this non-projected backhand. Already had an angio, and so early good dramas is there, and circumflex is not a major one, and the RCA is supplying with a good PLV and all. So most of the time we are not that worried, just like a circumflex which is say big one and is supplying most of the LV and going up to the inferior wall, or maybe a left dominant system, isn't it?
Yeah.
So the angio, if it is done, that can be used to analyze your chance of having some issue. Means you may be safer and you may not have be worrying that much about the circumflex. If the right system is good and early ramas with a small branch which is going into the lateral portion.
So have you ever come across when the LV starts reverse remodeling and your caudal length is become inappropriate and then patient develops a
prolapse? That is one thing actually. We had a discussion, Praveen and all, earlier also. The thing is, I feel, because in pediatric, again, we are doing mitral valve repair with the projects, and adult also dilated LV we are doing, but I am yet to see one who is coming back because of the chordae becoming lax or shortened in pediatric. Basically, I feel the papillary muscle also manages little bit. Now, papillary muscle also remodels to some extent, and some length adjustment is happening. That's what I feel, because this sort of case, it is reported, but still, I am yet to see one.
Have you seen one, ma'am? Oh, you have.
Yeah, we have seen one, and we actually sent it for publication to JTCVS. They rejected it. Annals, they rejected it. European Journal, they rejected it. Because then recently from Cleveland, they published a series of cases, similar cases, and yeah, they call it as abnormal reverse remodeling. And they think that that is one of the reasons. They were analyzing the cause of their failure of mitral valve repair, late failures, and one of the reasons now they have put this as abnormal reverse remodeling in dilated LV. And there is a audio commentary by Dr. Gilino also. I think it is in JTCVS. I think last month came. Yeah.
Became small. And how would the LV become small and cause more MR? I mean, it doesn't work sense. No? There's MR increasing because of the long length, and the second is the LV remodeling, logically.
So in a LV, when it becomes spherical, it goes longitudinal as well as transverse diameter. So when we measure the chordae and then put the chordae, that will be like when the LV comes from 7 centimeter to 5 centimeter, then the chordae will be long. Chordae will be long. Yeah. Then it will prolapse. MR will increase. Then again it will go back to this one. Yeah. So yeah, I think it is, and Dr. Bashizar also said the same thing, that he stopped putting artificial chordae mainly in dilated LV because of. So he has also probably has seen it. So when it came from Cleveland, I think they, they put it. It is there in the last month of JTCVS. Have you read that? Large series of cases on failures of mitral valve.
But that's an interesting concept. So that means you should probably avoid chordae, artificial chordae in coronary, remodeled ventricles, in remodeled ventricles. Yes. There's no other way.
Usually in dilated LVs, that much of remodeling very uncommonly occurs. That is why we don't see so many cases.
This is
7 centimeter.
The implant is.
Ischemic 6.5, anything above 65.
But that much enlarged ventricle becoming 4.5, 7 centimeters becoming 4.5.
It's amazing.
It's very unusual.
Very unusual.
I was just saying, can you hear us? Can you hear me?
We can hear you.
Yeah, I was just saying whether reimplantation of this is possible, but I feel maybe, I don't know whether it's same length or we will have a shortened chordae. I think it is a little bit contracted over time, isn't it? What do you feel? Reimplantation of the same thing back into this hook. So this is the papillary muscle head.
You can mobilize the posterior papillary muscle a bit more to bring it up.
I'll just fix it and see if it works well. Okay, otherwise we'll go ahead for a. Okay,
It'll become short. It'll become short, I think.
I think if we fix it to the head of the posterior papillary muscle, it should be all right. That's what I feel overall. Okay. Or should we go for an artificial chordae? Like, we'll have a trial once. Just fix it and see once. Okay.
Yeah.
Let's see.
Plageted for seropraline. backhand. So maybe the options we have to think about artificial corda versus fixing it back. Fixing it back is easy because we don't have to measure anything and just put it. But sometimes it may be shorter because long standing thing, the corda must have been shortened and the papillary muscle is well down. So, but it looks healthy. That's why I thought, okay, we'll have a trial backhand. So,
Can you see any scar inside? I don't. It looks pink to from here. Is there any scarring of the ventricle?
Not much.
Huh. And when you were doing the distal on the outside of the LV, did you see any scarring?
No, no.
No. Okay.
The coronaries are not very good. There are some small diffuse disease, but it's okay. It's good size vessels. This way. Should we put an artificial cord? I'm not very happy with this.
You have to be careful it doesn't twist, isn't it?
Yeah, it's okay. I'm just saying it. Yeah, it is forceps.
Would you think that the difference using Gore-Tex or Prolene in this fixation, would it make a difference?
Not much, I think, because it is just tissue to tissue approximation and we are not using it as a substitute, no?
Yeah.
Because the Gore-Tex has advantages because it is used in that way. Like
yeah, basically tubular structure goes up and down.
So, ഇപ്പുറത്ത് വിട്ടില്ലല്ലോ അല്ലേ രണ്ട് സൈഡ് വിട്ടില്ലല്ലോ forceps. ഒരെണ്ണം എടുത്താൽ ഇതൊന്ന് പുറത്തെടുക്കണം ജസ്റ്റ് വലിക്കാതിരിക്കാവോ ഓക്കെ അത് കൊടുത്തിട്ട് ഇത് കട്ട് ചെയ്തല്ലോ അല്ലേ ആ ആ ഇതെന്ത് ഭയങ്കര വലിയ ഇനിയിപ്പോൾ ഒരു നീഡിൽ വൈറ്റ് ബോർഡ് നീഡിൽ ഒരെണ്ണം എടുക്കാവോ അതങ്ങനെ ഇവിടെ കിട്ടത്തില്ല ഇത് ഇവിടെ നിന്ന് കയറ്റണം ഒരു നീഡിൽ തരാനാണ് പറയുന്നത് അല്ല ഞാൻ പറഞ്ഞത് ഒരു സാധാരണ നീഡിലെടുത്ത് അതേ കൂടെ കുത്തിയിട്ട് അത് പ്രോപ്പറായിട്ട് കാണിച്ചു കൊടുക്കണം ഒന്ന് കയറ്റാമോ അതിൽ വിട്ടോ വലിയ നീട്ടില്ലായിരുന്നു അല്ലേ
Does the cordae look twisted, don't they? I mean, from here at least.
Yeah, I think once you put it down, it should be alright. That's what I was looking in between.
Okay. No, I said here it's not so clear.
So, yeah. There's some twisting I feel, but we'll see once. Okay. Yes, scissors. Forceps. Scissors. Session. We'll just see once it is fist one, then just check in that. So we'll just see if it is working well. I'll put one more feature to make sure that. It's a big LV. I think it will become a little restrictive, isn't it? What do you feel?
Looks a bit restricted, yes.
It will become a little restricted. I think we'll go for artificial cordage. That will be better, I feel. Okay.
I think the LV has remodeled too much to allow this,
Yeah, it has become distended too much. So, we'll go for artificial cordage. Okay. Bend down. Yeah. Hook. Forceps. Knife. Fifteen, 11. Forceps. Forceps. Run out. Pludgetaki on velipathu scissors ella ante corded the cordal measurement there forceps there scissors, artificial cordage, CV4. Cut it. Scale there. Hook scale. Scale. Forceps. Again, same 2. Okay. Yeah, it is 2. Scissors. Top camera, please. Scissors. അതവരെ അയക്കാം. അത് വിട്ടോ. വിട്ടിട്ട് വിളിച്ചു.
So essentially it is 3 or 4 loops, and
Yeah.
then each needle is passed between the loops and then tied.
That's right, yeah. That's right. Which was ചെറുതായിട്ട്
1, 2, 3, 4.
Give me
And
this.
then each needle passes through this loop. This side, this side. 1, 2, 3, 4. And then you have 2 ends of the needle. Each needle passes through the loop. Through all the 4 loops.
Sometimes after tie, no, we may feel that if it is not properly tied, if there is independent mobility between the loops, it can be a problem. One will get stressed on when you are doing the other one. So you have to. Table cursor down nakamo, some more down. Forceps. Are you seeing the other one, the camera? Cardiotomy. Cardiotomy. Table little away from me, some more, away from me. These are long forceps around, long forceps. Okay, attend this.
So this is anterolateral papillary muscle?
No, actually, yeah, this is a posteromedial one, okay? Because if you look at the, I'll show you how the hook. So, if you look at the AML thing, so yeah, I had to forceps, I had to hook, forceps hook. So this is the anterolateral papillary muscle, and you see all the attachments are there intact. Can you see that?
Right.
Okay, so and this is the postero medial, and from there this particular bunch which was getting attached was gone. So we will be putting it only that area. Okay. Felt cherry planted. But if it was something which crosses the midline, I must have put two to say on either side of it, means on either side means two loops, two caudal loops will be prepared, and then they will be getting attached to the anterolateral and posteromedial papillary muscle separately. That is how it is done normally. The basic principle is not to cross the midline, no? The same.
Right.
Yeah. This is I didn't put enough, I feel. I think I'll use prolene here because if you look at this leaflet, the edges are very thin. Sometimes if I put prolene there, 50, yeah, 50. Forceps, one more forceps. You can again see the length is looking okay. Okay. Yeah. Because Gore-Tex, otherwise I have to use CV5. I think this is a very thin leaflet. Looks a little friable also at the tip, isn't it?
You can use pericardial pledgets.
Yeah.
Is there any adjustment on camera scope?
Pardon?
Scope camera, is there any adjustment? Because I can see double images. The focus is not there.
Okay. So
I think turning some knob.
I'll just see. Is it better now?
Yeah, it's better now.
Yeah. I think the focus has changed a little bit. പെരിക്കാർഡിയൊക്കെ ഇത് കട്ട് ചെയ്തതിൻ്റെ പീസൊക്കെ അങ്ങോട്ട് കയറി വരും നോക്കിയിട്ട്. cases. Long one. Backhand. Switch it is a long bit backhand. Section. Sorry, backhand switcher. Cut. Check. Check here and there. Check here and there. Went off. Okay. Okay. Ah. Okay. Okay. I think this should be all right. Camera clean 32 size, 32, 34 size cell. orientation should be. I think this should be alright. We'll see after
should be
putting the
alright.
yeah.
Should be alright.
32 ring. So I think 32 will be okay.
Looks good.
Yeah. So 32 will take.
It's a ischemic, so would you like to downsize?
Actually, even though it is ischemic, the pathology is different, no? The pathology is ruptured papillary muscle, not the PML, which is, but Manjusha was saying there was some problem with the PML,
Yes.
isn't it?
Tethering.
Tethering. So 30, 30. Clean the end. Clean the end. I'll just see 30 also. That is. So 30 will be downsize. Shall we go for 30? Okay?
I think that's a good idea. I think that's
Yeah,
good.
then 30. Yeah. Because Manjusha was telling there is some problem with the PML movement, isn't it? I think it's better maybe. Yeah. But if you look at the LV, it is globular dilatation, not an RWMA, no? Okay. So what about your lens? By the time I fix the, say, put the ring and no, but then we will see. After putting the ring, we will see the. Then by the time we are coming up, we can have the lens. That's what I felt, isn't it? Okay. Close-ups.
Or people could go in
Yeah.
batches for lunch, maybe.
Yeah, that's good. Yeah. So this is the one. Yeah, bring it. Table in area come. You can take it out.
Those who want to have lunch, it's ready outside. They can go in batches and come back. This is again CG Future Ring or Profile 3D?
No, CG Future only. You would prefer to have a Profile 3D here, rigid one?
My personal choice, yes.
Yeah. Okay, since it's a this thing, probably yeah. Yes, Profile 3D available with us. I am not very sure. Yeah. Okay. Yeah. ഇവിടെ എടുത്തോളൂ. ഇവിടെ അല്ലേ ഉള്ളൂ സിസ്റ്ററിൻ്റെ കയ്യിൽ പ്ലീസ് റിട്രാക്ടർ മറ്റേ അതിലിട്ട് തന്നാൽ മതി പാടാണോ അതുകൊണ്ട് പിടിച്ചെങ്കിൽ ക്യാമറ തുടയ്ക്കാൻ തന്നെ ക്യാമറ ക്ലീൻ ചെയ്യാം ക്യാമറ ക്ലീൻ അല്ലേ കുഴപ്പമില്ല Actually, if you remember that echo pre-op, we were seeing actually the papillary muscle coming into the LA, no?
Right, right.
Yeah.
There was a small papillary muscle
Yeah.
bed.
It was coming there.
Dr. Jayakumar.
Yes, please.
You made loops according to the length of the posterior leaflet.
Yeah.
But then attached it to the anterior leaflet.
Right.
Usually anterior leaflet caudal length is more than the posterior leaflet caudal length.
Yeah. There is, I don't know, so I cannot still understand. So, means some people say fixed length like 24 and
Yeah,
15,
right.
and yeah, some people make it for the PML and put it to the AML, and but I follow the original Carpenter's thing like the P1. If it does not enlarge, that's a reference code and take the measurement of that. And if that prolapse or something like that, I want, but always I go for that same length of the P1, but it works well for me. I don't know how, because last case also we were discussing like now, if the PML is lot of prolapsed and lot of tissue is there, even if you make a short chord and bring it down, or even if you suture it down to the LV directly,
right.
it will hold. But AML, it is always a question of the correct length. I think for me it works, so I'm fine. So what about you? You go for the A1 instead of P1 in this case?
Actually, I use adjustable caudal technique.
Okay, right, yeah.
So I measure the chords till the posterior annulus for anterior mitral leaflet.
Okay, yeah. So you go for the physiological, filling the heart and then measuring, yeah.
Exactly. Fill the heart, measure, and readjust.
Okay, nice, yeah.
And then tie the knot.
Nice. So multiple chords means different times.
Yeah, multiple chord
Yeah.
means
Yeah.
each chord arising from a different
Yes.
location.
Yeah. Check your body. Table away from me. ഇതെന്ത് സ്റ്റേജ് നിറച്ച് എടുക്കാൻ ഇത്ര പാടുണ്ടോ?
Looks good, yes.
It should be alright.
This should be alright.
Yeah, it's good. Okay. Yeah. I think it will be fine. Maybe I'm not very sure whether this particular small portion has to be taken care of. Bend down. Forceps. Okay, yeah. Scissors. A hook and a hook. No, I am worried about small cord. If it is hanging down, after some time the cardiologists come and say that this is an infective endocarditis vegetation.
Yes.
And then you have to be after that.
I'm sure it has happened with everybody.
Yeah.
So we will disperse for lunch, Dr. Jayakumar.
Yeah, sure, please. Yeah.
Thank you so much. Wonderful.
Thank you.
Good job.
Thank you. Thank you. Table towards me. Table ended the cacao. അതെടുത്തു കൊടുത്തു. വിനിതയ്ക്കിനി ഉച്ച കഴിഞ്ഞ് അങ്ങോട്ട് പോകേണ്ട ആവശ്യമുണ്ടോ? ആ ഓക്കെ. ആ ആ ഓ ഓക്കെ ഓക്കെ ഓ ആ അത് കുഴപ്പമില്ല. അത് നമുക്കിപ്പോൾ ഈവൻ അന്നത്തേക്ക് ഞായറാഴ്ച രാവിലത്തേക്കാണെങ്കിലും മതി ഇൻ കേസേ. അതെ അതെ ആ അല്ല ആ ഇൻ കേസ് ലേറ്റ് ആവുകയാണെങ്കിലും അതെ 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 അതെ. വെന്റിലേറ്റർ ആൻഡ് ഹോൾഡ് പ്ലീസ്. Ventilate and hold. Okay, fine. മറ്റേ സ്റ്റാർട്ട് ചെയ്തല്ലോ അല്ലേ? അത് ഏത് കേസാണ് കയറ്റിയിരിക്കുന്നത്? മഞ്ജുഷ കണ്ടായിരുന്നോ അത്? ഏത് P1-ൻ്റെ ഇവിടെ? അത് A1. ആ ആ ഓക്കെ. ഓ ശരി. എന്തോ? ആ ആ അതിന് സിമോഫോം വെച്ചാലോ എന്നാ? സിമോഫോം റിങ് വെച്ചാലോ അതിന്? സിമോഫോമിനുള്ള കൊണ്ടെന്ന് പറഞ്ഞാൽ അത് കുറച്ചുകൂടി മെയിൻറ്റൈൻഡ് ആയിട്ട്. പൊടിയോ 20,000 കൂടുതലായിരുന്നു. അല്ല പിന്നെ ഇതിൻ്റെ സെയിം കോസ്റ്റിൽ അങ്ങ് ചെയ്യിക്കണം അല്ല, അവർ വേണേൽ സബ്സിഡൈസ്ഡ് ആയിട്ട് തരാമെന്ന് പറഞ്ഞിട്ട് വേണം. ഇത് ഈ ഇൻഫെക്റ്റീവ് എൻഡോകാർഡൈറ്റിസും അതുപോലത്തെ ഇതിനൊക്കെ കുറച്ചുകൂടെ ഓക്കെ. റൂട്ട് ഓൺ. Fill the heart, ventilate. Okay, no problem. Empty the heart. Close down. Okay, clamp off slowly back on. Correct. Okay, take back. എന്തോ പത്ത് അത് ശരി, നല്ല ഷേപ്പ് ചോദിച്ചല്ലോ. എനിക്ക് ഞാൻ MI അടിച്ചിട്ടേ അല്ലേ, ഇവിടെ ഇതിവിടെ കൊടുത്താൽ മതി. അതോ കൊടുത്താൽ കൊടുക്കണം ഈ ഒരു ഗ്യാപ്പിൽ ടൈമിൽ അല്ലേ? അതെ അതെ ഇരിക്കുന്നത്. ഇന്നിവിടെ കൊടുക്കാം, ഇന്നിവിടെയും കൊടുക്കാം അല്ലേ? അതെ അതെ. എയർ ഉണ്ടോന്ന്, എയറില്ലെങ്കിൽ റൂട്ട് അങ്ങ് എടുത്തേക്കാം. ഇഞ്ചക്ഷൻസ് ഉണ്ടോ? വെച്ചോ റിട്ടേൺസ്. ഓക്കെ വെച്ചോ. അതെല്ലാം പ്രൊഡക്ഷൻ ഉണ്ടോ? ആയില്ല ആയില്ല അവിടെ ആയില്ല. എന്നാ പറ്റി? സപ്പോർട്ട് ഇച്ചിരി വേണമായിരിക്കും. ഏട്രിയലും ഏട്രിയൽ എന്തോ അല്ല അതെന്നുവെച്ചാൽ എനിക്ക് എയർ ഇല്ലെങ്കിൽ എനിക്ക് റൂട്ട് അങ്ങ് എടുക്കാമായിരുന്നു, അതുകൊണ്ട്. എന്തെങ്കിലും പ്രോബ്ലം ഉണ്ടോ? ടെക്നിക്കൽ ഇഷ്യൂ ഉണ്ടോ? കയറിയിട്ടില്ല നന്നായിട്ട്. ഓക്കെ. വേറെ ഒന്നും കാണുന്നില്ലല്ലേ? ഞാൻ ഒന്ന് മസാജ് ചെയ്ത് നോക്കാം. അതെ അതെ. ആ പേസിങ് കണക്ട് ചെയ്യാം ഞാൻ. അത് പേസിങ് തന്നെ, എൽ വി പേസിങ് തരും, വെൻട്രിക്കുലർ പേസിങ്. സൈറ്റിലാകുമ്പോട്ട് പിടിപ്പിച്ചാലോ? സൈറ്റിലാകുമ്പോട്ട് രണ്ടും ഒരു കാര്യം ചെയ്ത് വലിയ എയറില്ലെങ്കിൽ റൂട്ട് വെൻ്റ് അങ്ങ് എടുക്കട്ടെ, എന്നിട്ട് ഇത് കൊറോണ രണ്ടും പഠിപ്പിക്കണം. വലിയ എയർ ഇല്ലല്ലോ വലിയ. അതല്ല എന്നുവെച്ചാൽ ഇപ്പോൾ ഫുൾ പമ്പിലാണ്. അല്ല ഇത് സൈഡ് ക്ലാമ്പ് ഇടാൻ പറ്റുമോ? എന്നുവെച്ചാൽ എയർ ഇല്ലെങ്കിൽ ഇത് സൈഡ് ക്ലാമ്പ് ഇട്ടങ്ങ് ചെയ്യാറുണ്ട്. വലിയ എയർ ഇല്ലല്ലോ. ആ ആ വരുമോ എന്നൊരു പേടിയില്ലേ? What's your returns? കുഴപ്പമില്ല. ആ ഓക്കെ കുഴപ്പമില്ല. ഞാൻ അതാ പറഞ്ഞ വാച്ച് റിട്ടേൺസ് പറഞ്ഞത്. ഓക്കെ ഫൈൻ. ശരി, ടേക്ക് ബാക്ക്. സൈഡ് ക്ലാമ്പ്. സൈഡ് ക്ലാമ്പ് എല്ലാം എടുത്തോളാം. അത് പ്രോക്സിമൽ എടുക്കാം. ഡിവാൽവ് ലൈറ്റ് ഇവിടെ കറക്റ്റായിട്ടുണ്ട്. ഓക്കെ. പഞ്ച് അപ്പുറത്ത് വേറെ ഒന്നാണ് പഞ്ച് വരും. അതാണ് ഇതാണ്. ഇതാണ് അതാ അതാ ഇവിടെ ഒരു ഇത് വന്നിരിക്കുന്നത്, ടയർ വന്നിരിക്കുന്നത്. അത് ആ സ്വിച്ച് ഇട്ടതിനെ ഇത് കണ്ടോ, ഫുള്ളില്ലത് കണ്ടോ. ഓക്കെ പോട്ട്സ് സിക്സോ.
ബിൻസനെ വിളിച്ചിട്ടേ ഫൈനൽ സർട്ടിഫിക്കറ്റ് എനിക്ക് അയച്ചു തന്ന സാധ്യതയുണ്ട്. അത് അയച്ചോ, റെഡി ആയോ കിട്ടിയോന്ന് ചോദിക്കുക. എനിക്ക് വിഷ്ണുവിന് അയച്ചു തരാൻ പറയാം.
നേരെ ബെൻസനാണോ അതിൽ സർട്ടിഫിക്കറ്റിൻ്റെ ഒക്കെ ചെയ്യുന്നത്?
ബിൻസൺ അവർ വേറൊരാളിനെ ഏൽപ്പിക്കുക. ബിൻസനാണ് നമ്മളായിട്ട് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുന്നത്. രാവിലെ റെഡിയാക്കാമെന്ന് പറഞ്ഞാണ് കയറുന്നവരും ആണെന്നില്ല.
ഫിഷ് കഴിയും. ഓ ആ സ്പോസ് രജിസ്ട്രേഷനൊക്കെ അല്ലേ.
അതെല്ലാം അയച്ചു കൊടുത്തു. അതൊക്കെ വരുത്തണം.
Thank you, sir. Thank you. Thank you, sir. Thank you, sir. Done, sir. ഇതാകട്ടെ. ആ ആ അതെ അതെ ആ അത് നമ്മൾ അഞ്ചാമത്തെ അത് മതി. ഇപ്പം 4 മതിയാകുമെന്ന് തോന്നുന്നു അല്ലേ? അത് നടക്കുള്ളായിരിക്കും. കോട്ടറി പോരെ, 4 നടക്കുള്ളായിരിക്കും. ഇന്നിപ്പോൾ ഇത്രയും താമസിച്ചല്ലേ തുടങ്ങി അല്ലേ? ഫസ്റ്റ് കേസ് നമ്മളൊരു 11 മണിയെങ്കിലും അയക്കണം അല്ലേ? വാട്ട് ടൈം വി സ്റ്റാർട്ടഡ്?
One minute.
ഏതാ? ആ അത് ശരി. പക്ഷെ അവർ അത്ര കോസ്റ്റുള്ളത് അവർ പറയല്ലേ ശ്രദ്ധിക്കല്ലേ അങ്ങനെയുള്ള പക്ഷെ അതന്നെ ഇങ്ങനെയൊരെല്ലാം ഇന്നലെ തന്നെ അവർ പ്ലാൻ ചെയ്ത് പറഞ്ഞിരുന്നെങ്കിലേ നമ്മളറിയില്ലല്ലോ ഇപ്പം അല്ലേ? PP എത്രയുണ്ട്? എന്തോ? അതെയോ? 11 ഇത് ready? Can you hear me in the seminar room? You're back after lunch.
Everybody's here now.
Okay, right. I think I have done the proximals and we are off. We are just coming off, no? Are we off? Okay, we are off the palm and hemodynamics are good, I feel. 120, 67, 85 mean, CVP 11, and we are on RA pacing. Yeah. So we'll see how it is. Manjusha, TE can be seen, no?
Yes,
yeah,
yes, we
right,
can see.
Yeah. അല്ല അത് ഇച്ചിരി ഡയലേറ്റഡ് ഹാർട്ടാണ്. ഇറ്റ്സ് എ ഡയലേറ്റഡ് ഹാർട്ട്. Yeah.
Can you explain, Dr. Manjusha?
Hello? Hello?
Yes, we
yes,
can.
Yes, I'm okay, fine. So this is a post-bypass examination. Our hemodynamics are relatively good. Heart is, I think it's a little overfilled actually. It's looking a little full. This is the neo-mitral valve. We can see that this is at 0 degrees. So again we have the A2 P2 segment. So it's always better to freeze and go frame by frame, but there is no significant jet. Only thing I'm worried about, there is some, can you see this funnel shape forming? So is there a gradient? I'll just see. Coming to the, this is the commissural view. Commissural view also looks good. Advancing the multiplane to 90 degrees. This is okay. Okay. So this is a long axis view. So definitely there is no residual MR, but coaptation is well away from the aortic annulus. Coaptation depth, there is some dropout because of that ring, but anyway it is 7 millimeters is there. The transmittal gradient peak is 9, mean gradient is only 4, so that is also acceptable.
Probably we are getting that turbulence because we have put a smaller thing, but it's
yes,
okay. I think.
Yes, that's it. So I just
because since you told that there is some PML restriction,
Yeah.
we put it as ischemic and then used a 30 size rings, so 32.
Because he's...
Yeah. I think the gradients are okay, isn't it? 4.
Gradient is okay. It's only that flow acceleration which
Yeah.
was a little concerning. So sometimes in the, if you're not getting a good coaptation height in the midesophageal views, you'll get a very good coaptation height in the transgastric view, because here the shadowing from the ring is not going to happen. He had a trace AR even before surgery, so that is okay. Otherwise, sometimes when sutures are placed near the AML, there is always a possibility that the non-coronary cusp or the left can get injured.
So the LVOT is well open and no gradients, no?
Well open, there is no gradient.
So shall I describe?
Yes, good.
Because
Yes,
it looks good.
Good.
Okay, thank you.
Everything is good.
Any questions from the floor?
Thank you, Dr. Jayakumar. Nice
Thank
job.
you.
Thank you so much.
Thank you, sir. Thank you.
Right. It becomes, yeah, more restricted. Even more, right. Under the ring, yes. The coaptation is at a very deeper level. Yes, that should always be done. Taking out secondary cords, at least from the PML, to lift it up, that should be done. And if preoperatively the posterior leaflet angle is more than 70, definitely you should enlarge the posterior mitral leaflet using a pericardium. If it is around 40, then probably it will work. Yes. So preoperative posterior leaflet angle is a very important determinant of long-term failure, especially in dilated and restricted leaflets.
But for this patient, for instance, suppose we didn't put a ring of this size and you put a larger ring, then the coaptation height would have been much smaller. It's only 7 at the moment. So then you would have you'll have MR from the middle.
It's a trade-off. It's everything is a trade-off in mitral valve repair. Yeah, sorry. Dr. Priyank is going to tell us, Dr. Priyank Bhatt, he's going to be talking on basics of mitral valve repair. So since we have some time, let's do this presentation now. Thank you, sir.
Welcome back from the lunch. I am Priyank. I work at this hospital called Sal Hospital in Ahmedabad. Though I'm speaking from this side of the dais, but I am actually on that side. Point being that I am going to talk about things which I learned or what difficulties or what points I understood over the last few years when I was beginning or when I was trying to repair valves. So I have kept it very basic and very simplified things. And also I am, I've included a few points about mini repairs if anybody wanted to do. So mitral repair, of course, is a technical surgery, as was just being mentioned. You have to know the anatomy, physiology, pathology of the mitral valve. Surgical decision making, we were just discussing that in the morning, that time on the CPB, whether you really want to repair, understanding your own, whether you can do it, whether it should be done. So there are a lot of decisions that surgeon has to make before, during and after the surgery. Before, as in you see the T, you only can decide that, look, this valve can be repaired by somebody but not me, probably, or no, I mean I'll attempt repair, I'll do this, that. So it's the decision making is entirely yours, and you should know what to attempt on and what to not, which is probably true for all surgical decisions. Mitral valve especially is very surgeon specific. So if you really are beginning, or you are just starting off, or few years into repairs, you may not want to do the advanced techniques, augmentations, chordal transfers, this Roman arch technique of Cofidis, or I mean, you may not want to do it. Instead, it's better to maybe change the valve with a bioprocess if the compelling reasons to avoid anticoagulation is there, but kind of err on a side of a competent valve, which is the must, even after a repair. Standard mitral valve replacement we have to get familiar with, because if at the end of a long repair you have to replace, then it should not be like there also we are kind of taking time, or it's if we are doing mini, then especially we should know the mitral valve and be kind of proficient in it. Certain things you won't be able to manage, whether it is repair or replacement in mini. Anyway, these are difficult to manage with sternotomy, but it's not possible with a mini. Tying with a knot pusher, especially in a mini, is a trick that all of us have to know. Trying to tie with the hands and going in depth, it's going to be difficult. For example, if there is a bigger LV and probably it's quite deep, you are trying, say, mini or even in open sometimes, it would be much less stress on the papillary muscle if we were using a knot pusher to tie. Unnecessary and undue tears can easily be avoided. If we are doing a mini, this is just a quick few minutes, that cannulation is one of the important steps, probably if not the most. If it is done perfectly, then the surgery becomes very easy. Our stress is also much less. I tend to cannulate. This is again Cleveland Clinic teaching that cannulate the femoral vein first, kind of makes the artery stable and come up, so that the arterial cannula glides over it. Always cut the adventitia, that is the most restrictive part of the cannulation. So it is going to hold your cannula, whether it is percutaneous ECMO cannulation, whether it is IABP, or whether it is the femoral cannulation. Always, I mean, I take a 6/0 purse string around the cannula so that I don't have to snare the arteries later on and avoid distal limb malperfusion. Vein at the end, if you have taken a purse string, you can just tie it off. There won't be even a need for repair. These are just small short videos. You go in by Seldinger. This is a vein dilated. I pull the lower go around, make vein little straighter, use the knife, open the adventitia, and then I'll just rush through this. This is not required. This is a TE image where the cannula is sitting across the RA into the SBC. So this is how it's going to look at the end. Newer generation cannulas are there from companies which have side holes, which is going to make life easier. You will be able to put one size smaller cannula, And these are all for, you know, these points are not for people who are doing mini for last say 15 years. This is for somebody who is going to begin it, so that, you know, instead of trying to shove in a 21 cannula, he can use a better cannula, 19 cannula, and his life and stress easier. VAVD, vacuum assist devices, and vacuum assist drainage is very important. It will keep the field dry and empty. You can ask your anesthesiologist if she or he knows SVC cannulas under USC guidance. Less cluttering of the field, saves time, less return. I use Delnido in all my patients. Duration of it usually lasts the duration of the surgery, and repeating and ensuring, like you will have to release the stays, or you will have to release the annular sutures if you have taken, if you are repeating at 20 minutes, or sometimes some people as they do in 14-15 minutes. Usually we all use superoseptal approach if the LA is smaller. It's an excellent approach. There is no two ways about it. This again is a point which I learned. I mean, I heard Dr. Tavishak speak in one of his lectures, that you cut the limbus, the fossa ovalis anteriorly, like 1/3, 2/3, so that the chance of any damage to the conduction system is much less. And if you are going transeptally, then go towards the, once you do that, go towards the floor of the roof if you are going transeptally. And of course, anteriorly towards the LA roof if you are going to the superoseptal. I usually put the standard, all the ring sutures, which is like a standard. Then you start assessing from the P1, which is relatively fixed, less likely to prolapse, very rarely. Otherwise, as both, I mean, it will be kind of a commissural prolapse. Indian rheumatics, you see, you assess the valve. Most of the times, you will think that, look, not worth repairing, or not, I should not attempt, or not not only the short term, but even maybe it may not work in a long term, just change it probably. I am not trying to favor replacement, but what I am trying to say is that a better replacement is better and certainly longer lasting than a not so good repair. If you think that this valve is fit for repair, then it will require two areas to be addressed, leaflets and annulars. So this is the standard ring, I mean the placement of the sutures. The retractors, I'll show them in a better this. So if, again, I usually use 3 or 4 techniques. If I have to go beyond them, then I'll be very, very skeptical if I really want to go do that. These are, again, as cleft repairs, neocord placements, limited resections. So most of the times it is neocords, but limited resections also make life very easy. It's not as dangerous or as difficult as we think. And this, I am talking about limited resections. I am not talking about sliding plasties. But like in the morning's first case, if we had tissue, just resecting that P2 in the middle between the 2 cords and repairing it would have addressed a lot of problems in the, if we had tissues. So we all have, last say 10 years, we have come from resect to respect, but resection is still a good surgery. It's still a good modality, and it probably takes out the diseased part. You don't need to put measure cords and I mean just resect that part, put a ring. Sometimes or many times it works. It again makes the geometry, takes it back, and repair is also quite durable. If you have to put neocord, what I mean, these are various things, as Dr. Praveen said, that there are 40 odd techniques. But what Dr. Jaikumar has been showing is the loop techniques, which Dr. Moore used to do with Prolene. But then Japanese modified it to loop and loop, where you had the flexibility of adjusting the length again, even after a loop. What I do is that what Dr. Tavishak and many of us are doing is that I take a CV4 or CV5, pass it through a pledget, pericardial pledget most of the times for the conformity, and then I pass that suture through a bulk or kind of belly of the papillary muscle. pass another, I mean both the needles, then pass another pledget and tie it off. Now that part is secured between two pledgets. Then I pass it through the leaflet, not exactly at the edge, but around 2 to 3 centimeters towards the annulus, where actually, so that it kind of pushes the edge little down, gets little more coaptation length. And then, you do a saline test, let the AML come up, use hooks, saline, and as the ring sutures are around it, so they will also, I mean, you can pull on the posterior annulus, so they will also bring the posterior PML up. So now there will be some sort of opposition, and you will know what sort of length approximately you want. You put a Liga clip across, and then you tie it. This Liga clip is for two reasons. One, it gives approximate idea where you are supposed to tie, and second, it prevents the knots from slipping down and making it shorter, the cannula, I mean the cord, neocord. And then again you test. If you are happy, okay. Not happy, you can again shorten, tighten. You have room and you have freedom to wriggle. One thing I use, because now when you put the clip is across, I mean it is at 90 degrees to your forceps where it will go. So I'm sorry, the forceps is going to go like this, and the clip is applied like this. So and these are small clips, and we all know our forceps, our clips, everything. So they are not going to be pitch perfect. So sometimes they may slip, and then you will have a hell of a time searching for it. So what I do is we use this Lima forceps, the angled Kirkland forceps, which are not so much used as our normal forceps. So most of the times they hold the clip better. And of course, because they are angled, the clip is like this. They will also go and hold it at their length, rather than holding them at an angle, at a 90 angle, and less chances of slipping. So this is one of the points. Ring selection we have been discussing since morning. It's a cementing step. It is going to make the repair viable and durable. It's going to restore the repair. It's also going to give the necessary height to the coaptation. Usually I use complete rigid and saddle shape ring. All companies make these, at least one ring with this kind of a specification. But again, it can be very, very personal and very, very, it's a choice driven by a lot of factors, but most importantly, comfort. If you like a ring, if you are happy with your result, I don't see any reason to making small changes. Yes, in pediatric population, or in where you want the annulus to grow and anteriorly to grow, and you want that part out, and you want a flexible, all that is fine. But in most of the cases, maybe 99 out of 100, this kind of complete rigid and saddle ship ring is going to work. Annulus, as we know, it dilates anteroposteriorly. It's fixed kind of at, a ring is sized as per the intertrigonal distance, and in AML, in rheumatics, the sizing, what we used to do in 2007, 8, 9, when I was studying, Steve Bowling used to do a gross undersizing, and he used to advocate, because he used to resect a lot, and he used to need that kind of support and bring the tissues nearby by undersizing. But now, because we are respecting the leaflets, we kind of not oversize, but we match the size. At least we are not undersizing the repairs. We don't even want to oversize it too much, otherwise there will be SAM. So AML, if you put your sizer, AML should not extend maybe more than 2-3 millimeters beyond the lower edge of the sizer, and that should probably, and of course the intertrigonal distance, it should work well. This is one of the important things, is that ring holding mechanisms are different with all different companies. So you should know, because somebody will have a clip mechanism where you press on the clip and the holder will come out. Medtronic does not have any mechanism. It's fixed. So I have been after their lives that at least have something where I want to remove the holder when I'm tying the sutures, but I can't. If I have to, I really have to hold the ring with something and push it down, and sometimes my forceps may slip and hit something. So this is one of the things. always tie the ring sutures with the ring holder in place. Ring holder, I mean the plastic one, the transparent plastic one. Otherwise, there is a chance of it distorting, because we are going to have longer bites or wider bites on the annulus and smaller, so as we are trying to bring the annulus together. At that time, if we have removed the holder, the ring may buckle under it. So that's one of the points. They have written like this is 28 profile 3D or 30 physio 3D, whatever it may be. So that kind of reading should be kind of in the center or little off center to the, say it can be little 7, 1 and 7. But try to have it so that fix the intertrigonal markers first to the, the sutures to the markers, so that the ring is oriented, then the lower one, and then probably you can take the other sutures. So this is just a way to look at it. So this is taken from little bit, from my left shoulder, so it is looking little rotated. But as you can see, it is it in effect, if you look at it from this side, it is 6 o'clock this. And what I meant by the the holder is this one. What the inside transparent one you are seeing, you should keep it in place when you, while you are tying. Saline test, of course, we all do at the end. We have to especially look for the height of the coaptation. We kind of just are happy that it is coapting and there is no MR. But do look at the height. If height is not enough, if it is not 7 millimeter, 8 millimeter, that repair will last now, but it will not last for long. So that is one of the thing. This is what I meant when I said 6 o'clock. So I'll just share 2-3 my things. So I'll show you this one.
Mitral valve repair for Wilson-Mendes valve. So there was a cleft here which we have closed. There was another cleft here. This is a neocord which is put to the A3. There was a prolapse of A3 now. We will do the saline test. Pardon my hand. Post-refractory is absolutely no. This patient has a 32 size Medtronic profile 3D saddle ring.
So I wanted to show two things in this. One, what Dr. Praveen Verma was saying before, that the cord, but the method I described about fixing the loop, the method I described about fixing the loop, the knots will always be on the outside of the AML, so, or PML, whatever it may be. So you will be able to see that in this method. Second, the retractors that I am using here, they are small fellows retractors which we use for aortic valve or fellows, tetralogy of fellow repair. But this work very well, and I many times don't have to go superoseptal. I can just be transeptal and two retractors, and it will expose the valve.
This is a mitral valve repair. This PML which was little threaded, we have released it.
Yeah, so there is one more point for the mini. If you are doing mini mitral repair or replacement, place the pacing wire on the arrested heart before you remove the cross clamp. This is very important. In our anxiety, we tend to forget that, and then at the end, if the heart is full, it's very difficult to put the valve. I don't know how this will work. This is, I didn't have time to edit this. This is the repair I did on Monday. So this again an ischemic mitral repair. I don't know how well you can see it, but anyway, because I don't know what to do. So as we were talking, and that you can see the blue dome kind of a thing of the AML, and in my next 2 seconds of video, I'll show that how the LV. If you see, look at the LV. Once you push the suction inside, you will realize that how it empties. So how it was holding the, see? So how it was holding the water and now it is not. So this is again very important that when you are checking the LV, especially if it is very much dilated, it has to be full. and it is holding the water. So the suction is not just showed in to just suck the water. It's just that there is actually enough water which it is holding and not regurgitating. These are various methods, many more are there. Papillary muscle encircling for the ischemic and separated papillary muscle, dilated LV, sliding plasty, which Dr. Schaeffer has taught us, Roman arch repair of Dr. Kofidis. He's come up with another 2 or 3 versions of this as recently as maybe 2-3 months ago. Pericardial augmentation, caudal transfer, shortening, all these methods can be attempted, can be tried, but probably in my opinion, not in your maybe early 15, 20, 30 cases, because these require much more insights or much more experience to master or perfect, and maybe you spend a lot of time, lot of energy, lot of effort, lot of this on doing all this, and just because the lack of experience it doesn't work. And the other methods, putting a ring, neocords, they have evolved so much that now they are kind of they are quite standardized and simplified. So it's easier to reproduce those than these techniques. I thank you all for your attention. So we usually, very young children, say 5 years, 7 years, 10 years, so we just repair, and if at all required, we augment it with a Teflon plasty. Usually they say that 8 to 9 years, if the valve is big enough, you can use the now those what you call Taylor valve or something. Ring, where only the posterior annulus is supported up to the trigon, and anterior part you leave behind. But my experience is that I don't use the ring. I most of the times use only posterior plasty, and then let them grow up to 18 or 19 years, and then maybe take them back. But I have not much. I may have 7-8 cases. That's about it. He wants to know your experience. How much is the prolapse? How many segments and how big is the prolapse? And more the merrier. Number 3, one from each probably. So again, if you ask me particularly, if I have to say put 6 cords, for example, that A2 is also prolapsing, P2 is also prolapsing, probably I'll err on the side of replacement. This is my philosophy. But again, if it is, say, like today morning's case or something, maybe 2 or 3 cords. Yes, please. You comment?
You see, for every 4 or 5 millimeters, there should be a cord for every 4 or 5 millimeters of prolapse. I think we are already into the 3rd case. Yeah. Hello, OT? Can you hear us? Dr. Manjusha?
Hello? Yes,
Yeah.
am I audible?
Yes, go ahead.
Yeah, okay. Third case was already, was it presented?
Somebody has presented the case?
So, okay, the third case today is a 41-year-old male. He was admitted to our hospital with dyspnea for 2 weeks and fever of 1 week. So when he was evaluated at cardiology, they found a vegetation in his anterior leaflet. He was on injection ceftriaxone and he's completed 1 month course of antibiotic. So the last transthoracic echo showed that he's having echogenic mass of 1.8 into 1 with intrinsic mobility attached to the AML on the LA side. And there is severe MR, which is a posteriorly directed jet. The mitral annulus is 3.6. There is no PAH. He's having a grade 3 diastolic dysfunction, no other issues. So his EF is 63%. LV dimensions, end systole is 36 and end diastole is 55. So coming over to our transthoracic echo, I mean TE. So okay, so so this is a midesophageal 4-chamber view. It is at 0 degrees. We can see that this is A2 and P2. Here there doesn't seem to be much of a coaptation defect. So as I'm advancing it further, can we see that there is a more than a vegetation, I felt it is more like the leaflet prolapse only, and with there is a ruptured chordae and one failed segment. In addition, some restriction because of the secondary chordae is also there at this point. This is the 90-degree view. Again, we can see that there is no major issues over here. I'll get a better view in the other image. So again, this is the A2, P2. We are not seeing much of a major issue. Coming down to the yeah. So this is the transgastric short axis view. You can see that the jet origin is happening close to A1. This is the area where there is a the jet is coming here and it is directed posteriorly. So without color, what we can make out over here is that definitely we can appreciate there is a, this is the A1 segment, this is the P1 segment. There is some hypermobility here and it looks like there is a indentation here, and also probably there is a cleft in that AML also around that A1. So we'll just go to the 3D images. 3D, so all these things which I've said is a little more clear. We can clearly see that there is a prolapse segment at A1, and if I'm going to freeze it and go slowly, can we see? So this is in systole, and in diastole there is a there is a cleft over here also, and in addition this is P1. Between P1 and P2 also there is a prominent indentation. So coming out to the next image, it's more appreciated here. Here you can, this is the atrial view. Atrial side you can see between P1 and P2 there is defect here, and this is on because from the atrial view actually because that prolapse segment is coming, it's more evident on the ventricular side. So this is just to freeze it and show this cleft which is coming here. We can see it in this view also. Other issues are AML length is 28, so there is not a lot of tissue. So AML length is 28, PML length is 12, C-sub distance is 33, well away from the annulus. No other issues for this patient. There is no pH, LV function is good. There is no RWA. Coronary sinus is well away from this is the circumflex. Circumflex is well away from the annulus at P1. So that is the place where we should be measuring the distance.
And the mic on.
I think, yes. Over to JK sir. I think he's already seeing the valve.
Yeah. Can you see it now?
Yes, we can see it very well.
Yeah. Yeah. So I have already placed the sutures, annular sutures, and hook. You can see this is the P1, okay, and as Manjusha was rightly saying, between P1 and P2 this is the cleft, okay, you can see it. Can you see it?
Yes,
So
we can
there's
see
a
it.
cleft. So if I hook the P1 around and then get another hook, then you see this is actually the A1 which is prolapsing. Okay, you can make it out, no? The
This
chorda
looks
is ruptured and it is prolapsing. Okay, there
looks
is no
more like
rotating.
commissure.
Yeah, it is. Commissure is, I'll show you. Actually, the entire posterior leaflet is good. So, just hold it. Hold it. One more. So, if you look at this, this is the commissure. Can you see this?
Yes.
That is a commissure chordae. Okay. So, up to this, that is the initial portion of the A1, it is good. There is no prolapse with that. Okay. So, beyond that, it is prolapsing. So, we cannot say exactly it is a commissure prolapse. It is just beyond that, because you see up to here, this is a commissure. So, that area looks fine. But beyond that, it is coming like this. So, and then so this is the other end of the A2, and then the A3. This is P3, fine, and this is P2, and this is the cleft about which we are a little worried about. So, only this much. Forceps. Hold this. Forceps. So, what do you think? Should I go for an artificial chordae or try with some little rotation plasty? That will take care. Scissors. Scissors. So, it is an isolated prolapse at the A1 just beyond the commissure. Okay. Just get me some saline, water, saline. Suction, all suction. Went off. Suction, just suction on work in. Just check the suction, somebody, please. Please check the suction. Somebody please check the section. Okay. Just hold it like this. It's still weak. Yes, sir. So now if you see, hold it this much. I think I will just try with the rotation plus 3. 3 options I can think about here right now. One is to put an artificial chordae. Second is rotation plus 3 like this. Third is going ahead with an alfieri. Okay. What is your opinion there from the floor?
Let us see rotation plasty this time.
Yeah. I think so. It may work with the rotation plasty. We'll see. Get me a trolley in 50. So what we do with the rotation plasty is for a hook. Give me a hook. Give me a hook. I think you can see it well. So see which chordae is the normal one. So up to here, I think it is normal. So and up to here it is normal. That means this portion. So only this is the small area which is prolapsing. So I think if I rotate it like this, it is going to hold. Let us see how it works. Probably another thing which we can think about at this place is Collar transfer. Double arm or single arm? Forceps. Let's switch over there. Right hand switcher. Then alarm. Fill in there. Check here and there. Check here. Let's see. We'll see how it works now. Okay. Section. All section. Section. Okay. Fill it already. Just give fill it. Fill it. Forceps to me. I think you can see that jet coming here, and that jet is at this place. Little away.
That cleft needs to be addressed.
Yeah, I think if we little bit more rotate, it will settle down, and the cleft also we may have to close. Okay, these are the two things. I think that we'll do after putting the ring. Okay, or we'll do it now. And this is the second place where we got it. So This actually I'm into the commissure a little bit on the other side. Till now we were not coming into the commissure, but this is okay. This will take care. Session. Switch off. Where is switch off? We really have to close this. I will put the ring and then see whether we have to close the cleft or not.
I think we'll get the ring, Dr. Jaikmar.
Yeah.
I think we'll get the ring in, and most probably you may not need to close that cleft also. Yeah.
Same. I also felt the same.
Because that commissure leak has been leak there has been fixed with a small commissuroplasty.
Yeah.
The ring should do the work.
That's right. Yeah. Sizer, ring sizer. Sizer, 32, 30.
Can they clean the camera, please? There's a bit of moisture on the camera.
Right. It's not in the proper position. Don't fight with me. Yeah. Section. Okay. Went down. You should. Is it okay with that? Some more out. Okay? Yeah. Hope you can see it now.
Yeah, looking good now.
Yeah. Sizer. This is 32. Or you want to go for a 34? 34? I think 34 will be good. What is the AML length?
32.
I think we'll go for a 34. Okay. 34.
34.
Actually, one thing. Using prejudiced stitches, does it make the ring size change? Because you are slightly making it smaller.
This is cut time.
Yeah, you are actually bringing that in, so your size of the ring may be smaller.
So shall we? I think we'll go for a 34. What about the ring of choice in this case? We'll go for the same. There's no advantage for a rigid ring in this case.
Dr. Jaikman, on the TE, Dr. Manjusha, when Dr. Manjusha was showing, that PML was quite short. It was not didn't have much tissue. The height of PML is not really great.
This get me a hook. But I think. But if you look at it, is here, no?
Okay.
Yeah, I think should be alright. So you would prefer to go for 32?
Yeah, that's what.
I think it should be alright. I feel. Anyhow. So it's okay.
No vegetation.
Yeah. No. Between the CG feature and simuform, probably this is an infective endocarditis case. So, any difference in selection of the ring for this particular case? Do you think about?
Simuforms available.
I think if the annulus is going to remain flexible with any sort of ring, maybe simuform in that case may be better, but it's a little bit costly than what we have told them. That's why okay. I'm missing it.
Sorry.
Total. Total Total how many switches?
Vilas and top.
Four more. No? Mix here. Not. Cut it. Cut. Needle എടുത്തു ഇതോടെ കട്ട് നീഡിൽ എടുക്കുക ഇതിൻ്റെ തന്നെ മറ്റേ അത് the other end of it. Yeah. Sorry. There. Leave it like this. Yeah.
Jayakumar?
Yes.
Praveen here.
Yeah.
So, active endocarditis, do you repair valve or?
Yeah, definitely. No, active endocarditis also, like if it is repairable, it is better to repair. Like say there are few indications where you will go in early, like say the patient is hemodynamically unstable, or say patient has large vegetation and all. So all these situations, if it is repairable, my preference will be to repair it.
What about ring? Will you place a ring or? Because that's always a dilemma with me. Whether active endocarditis, because whether to put a ring or.
Actually, the literature says to put a ring, and I put it whenever I feel okay. It is important, like in a pediatric case and all. Sometimes I may avoid it, but in a adult case, especially if there is lot of pericardium is used and all, I think putting a ring will not be a major issue, I feel. Okay.
So how often do you have to repair the tricuspid valve when you do the mitral valve repair? How often?
Maybe say
in degenerative valve.
It's not very common, like but
it's very unusual, isn't it?
Yeah.
But if you look at the Western literature, it is. I think they're very aggressive about. I don't know what is the reason for that, but even in our patients, when you see LV dilatation of 7, we don't see much TR.
Yeah. But we are also aggressive, like now even moderate TR we don't leave alone.
Yeah, but we are not finding that kind of TR.
That's right. I don't know why. Yeah. Maybe say total, if you look at the percentage,
Yeah.
maybe 5 to 8% of the repairs we have to go for the tricuspid. That's all. Yeah.
So in those cases, do you use superior septal or
No, it is not like the main criteria I go for supraseptal is small LA.
LA.
And complicated repairs.
So you will do both LA and RA.
Yeah.
Okay.
And suppose moderate size ASD, LA also, if you feel that you are going to have a complicated, means a difficult repair, sometimes I would prefer to, especially like your active infective endocarditis, ischemic mitral if we are repairing, and then say cases like very short duration of MR where the LA is not at all good, it's better. And some of the fibroelastic disease also, I don't know why, even if it is long standing, the LA will not be that big.
Yeah.
Yeah, so we have to go in for that.
So is there any cutoff for the number of cords you place? Beyond that, you think that it is not, it's not good to repair and replace the valve? Like
no, actually I was hearing that talk, like I was saying 6, but the problem is, like we believe in the cords that is going to work. So if the leaflets are good and if I feel that I will be able to do a good repair and good cooptation, I don't just look at the number of cords. Yeah, especially if you look at the commissural prolapse, when you have extensive, say, AML and PML, like it's a large area of prolapse may be there. So if you put 1 or 2 loop chordae into that particular papillary muscle, and then you can take it to both sides. Okay, so those cases now even 8 or 10 chordae sometimes I put to take care of that. So I think especially if you have a very much dilated annulus and a big valve. So
what is your preference for posterior PML prolapse? Is it resection or chordae?
Yeah, if we have enough tissue, resect. That's all. I don't hesitate to resect if it is needed. But if tissues are inadequate, I am worried because new jets will appear.
Yeah, I think that's a very important point. Dr. Jayagama said. So don't stick to one particular kind of repair. If you have to resect, but if you have to respectfully resect, isn't it?
Yeah.
Don't too much resection. Respectfully resect, but yeah.
One thing I felt is like in repair, you have so many techniques in your armamentarium, and use it judiciously.
Yeah.
And so whatever, and of course it comes with some experience and seeing and watching, observing others doing, but the right technique will help. Yeah.
But AML, you mostly go for neocords, isn't it?
Yeah, mostly go for. But here you have seen, no?
Yeah.
Because even though it was AML, I thought rather than putting a chordae, it is.
Can we clean the camera a bit?
Yeah. There it goes.
So there is a question from one of my anesthesiologists.
Yeah.
Was there any mitral annular disjunction in this patient?
I didn't see, because I didn't see the T also, but I think it was not seen, because I think Manjusha can just run the T once again and see.
Manjusha?
Manjusha is here around? I'll call her.
Dr. Jaykumar and Dr. Praveen also. See, mitral annular disjunction is more an echo diagnosis. What are the actual, do you diagnose it on table through a surgical examination? I always thought it's more diagnosed easily on a TE rather than surgical examination.
No, it's a real thing. You can actually see the gap between the atrialized area where the leaflet is attached and ventricle. Second thing is this, when you pull these switches, you see the whole valve coming to you. Yeah, that is also a kind of mitral, more suggestive of mitral annular disjunction. And it is not uncommon. It's actually, it's quite common, especially in these big myxomatous valves. So I have a feeling that even the echo also, I also thought that there was some amount of mitral annular disjunction.
This case.
Yeah.
That I didn't see it in detail because by the time I scrubbed in, the Manjusha was the other side section. Yeah. Okay. But here on table, I think it's difficult to say, Some cases where you see a lot of dilatation. Yeah. And in such cases, what section to me? Yeah. One second. Cut it. One second. Don't give. I think in such cases, only long-standing cases, we get a lot of mitral annular calcification.
Yeah.
Camera clean alle. Just let me.
Can you clean the camera with?
Show it properly. Can I show it the corner?
Cleft.
Do you feel that we need to close that cleft?
Yes.
Because what I think the camera is showing it. It's a very small thing coming here, isn't it? Close it or leave it?
Close it.
Yeah. I think when it is pressurized, it's not going to have a problem. Okay? But still, you feel it's better to close it. Okay? Yeah. We can make out, no?
Yeah.
Exactly, yeah. The small cleft. Verify zero probably.
Because I've always seen that, not felt that after you put the ring, if there is something coming there, then probably it is better to close it.
Right, yeah.
Otherwise, if you see a small jet there, no?
Yeah.
These people will torment me for the rest of my day.
Problem is when that narrow jet goes and hits the
Especially Manjusha is a very strict examiner. Every time after the repair, I feel like sitting in front of sitting in for my MS or MC Shoiva. She will be looking into each and every small thing and come out.
Yeah, but I think that kind of examination is the one that improves us.
Yeah, that's what, that's why.
Yeah, absolutely. No doubt about it.
It gives us a lot of confidence as well as feedback, and then, that it is so. Okay, Phil. Session. That is increased rate. Okay. Better we take it out. Okay. Yeah. section. Went on. That will accept, no? I don't think we have to go afterward.
Yeah.
We'll take it out, no?
Yeah, take it out.
Knife. Two things can happen. If I have done too much also, the same thing can happen. But sometimes this is needed for the hook. So this is a cleft, okay? So I've tried like this, but I think probably when I'm closing it, this is coming in.
The
like
other one is opening up.
Yeah. And this is the commissure. I think we'll leave it, okay? Yeah, when it is pressurized, we may not have much.
Jayakumar,
yeah.
Have a look at the papillary muscle also, because in that echo there was some bright shadow in the papillary muscle, anterolateral papillary muscle head.
Okay,
there is no
get
vegetation.
me a
Just
highly
make sure.
retracted, long retract. I'll see now. Yeah, right now. Small one less. Okay. So, can you see that now?
Yeah.
This is the one. These are the two. Yeah, looks fine, no?
No vegetation.
No vegetation. Yeah.
Okay.
Okay. Yeah, that's fine, I feel. Okay.
Okay.
Yeah.
Can we talk or?
Yes.
Jayakumar?
Yes.
Can we leave you now and have a talk?
Oh, sure, please.
Okay. Thank you.
ഒരു പ്രശ്നം ഉണ്ടെന്ന് ചെക്ക് ചെയ്യണേ. My mic's off. Mic off. എന്നിട്ട് ചെക്ക് ചെയ്യാൻ നിനക്ക്. അവിടെ അവരോട് പറഞ്ഞാൽ മതി. They will close it.
I think it started working. Does the video should not have a problem with this? Yeah, video should. Okay, sure. Now, a few of these videos which I have, a few of these points I have, maybe a repetition here. Thank you everybody, and thanks to the Kottayam team for giving me opportunity here. No financial disclosures. Now, we are about 100 years from the first mitral valve repair, though it was a closed start surgery by Dr. Elliot Cutler at Beta Penn Hospital in Boston. It's exactly 100 years now. And then open heart surgery started evolving, and Dr. Walton C. Lillihei did the first documented open mitral valve repair. And then early 80s, Dr. Alan Carpentier came out with the results of mitral valve repair, standardized repair, and he presented a French correction. The earliest illustration of the mitral valve is by Leonardo da Vinci in the 14th century. It was an oxen heart, and he beautifully showed the commissures, the papillary muscles, the chordae, and according to him, he's divided it into an anterior leaflet, posterior leaflet, and a medial commissure and a lateral commissure. The mitral valve apparatus is a beautiful apparatus. This diagram, actually, this concept of this basilica from Spain, I stole it off, the concept I stole it off from Dr. Patrick Perea. He shows how beautifully the inner structure supports the beautiful outer structure there. Now, most of the discussions we are having today and tomorrow is going to be on mitral valve degenerative disease. There's a beautiful paper by Dr. David Adams, which all of us should read. And he divides the mitral valve degenerative pathology is divided into fibroelastic elastic deficiency, FED plus, forme frustrae, and the extreme extent is the Barlow's disease, where both the AML and PML have excessive tissue. It affects 2% of the population. There is a spectrum of disease, as I said, and the timing of surgery depends upon the symptoms, the LV size, the ejection fraction, onset of PH, and very rarely with the onset of atrial fibrillation. And better to repair. These are the ideal valves to be repaired. A few basic principles which I stick to when I repair a valve is, first, do a detailed assessment of the pre-op echo and the TEE, and have a best approach whatever suits you. Usually a dilated LA will can be approached through a paraseptal approach, but the key is to have an adequate exposure. What we do generally is to take the posterior annuloplasty sutures first. We don't take the 4 anterior annuloplasty sutures. As I already mentioned, always devise a method which is suitable for you and always stick to that method which is comfortable. What I do is I take a 6 o'clock position first suture, build up the sutures up to the left fibrous trigone, then build up the sutures up to the right fibrous trigone. It's usually 7, 8 or 9 sutures. And then once again we do a detailed analysis of the valve. Now we have a fair idea of whether it's bileaflet prolapse or a PML prolapse or a commissure prolapse or an AML prolapse, and then work accordingly. If it's a PML prolapse at this point of time, whether we are taking neocords, most of the cases I prefer to do a small triangular resection. And at this point of time, especially if you're a beginner, if you've done the basic part of the repair, if you're worried that whether your repair is going to work or not, when you've done the basic part of the repair, before you open the ring, you can check the valve once. If the valve holds at this stage, usually it holds, you can boldly open the ring now. And annuloplasty ring is always a must. We've already discussed about the concept of SAM. And avoid assessment of the valve till the ventricular function is normal. Don't be in a haste to looking at small leaks and moderate leaks, even before the contractions are good, even before the filling is adequate. And finally, never ever accept a bad repair. Now, the history of the neocords started somewhere in, the concept of neocords started somewhere in 1960 by Megoon, but the concept of caudal rupture was described exactly 150 years back. And then Megoon, Henley, Kay, and other people came out with the concepts of neocords. And remember 1960s was a time when echo was not developed fully. I think probably they had the M-mode echo alone those days, and they had to go on clinical features. And in fact, they could, from the murmur, they could say whether it was caudal rupture or just some other pathology of mitral regurgitation. And the initial cases were done through a right thoracotomy with a paraseptal approach. Initial cases, they did cut a 1 centimeter thick Teflon cloth, tied it onto the papillary muscle, brought it up to the prolapsing segment, and splayed this Teflon cloth and sutured these individual bits onto the prolapsing leaflet. And Dr. Frater, who's famous for his aortic work, even described repairing these ruptured cords or flail segments with pericardial felts. And Kay came out with this concept of annuloplasty. Now, we've already talked about this segmental analysis of mitral valve. It's very, very important, just a repetition of the segmental analysis. P1 segment is usually normal. Very, very rarely do we see a prolapsed P1 segment. P1 segment is compared with all the other segments. That's comparing P1 with A1, P1 with A2, A3. That's the P2 segment. And a P3 segment. Once again, analysis of the valve here. A detailed analysis is very, very important. There's a gross prolapse of the A2 segment here. You can see the subvalvular apparatus there. You can see the elongated chordae there. That's showing the prolapse after the leaflet, after the annuloplasty sutures. And one more video on bileaflet prolapse. You can see the tall P2 here, long elongated chordae, and a prolapsing P2 segment, A2 segment as well with elongated chordae. Now we have various surgical techniques. I'll not go into the details of this. I'll go to a video of AML prolapse. Now, looking into the evolution of a mitral valve surgeon, you start with the isolated P2 segment, and usually if there's excess tissue, you do a triangular resection. Understanding the pathology of the mitral valve is very important. We should be aware that there is a spectrum of diseases right from Barlow's disease up till about FED, FED plus, and mitral annular distinction. And then once you're confident with good PML repairs, you can proceed with AML repairs and then bileaflet prolapses. And this is a case of a 28-year-old gentleman who presented with class 3 dyspnea. His LV dimensions were 58/40 and the EF was 50%. And that's the TE images. And this is a short video of how we take the neocords. As I said, we take the posterior annular sutures first and then analyze the valve, then do the rest of the repair. Now, I've taken a full round evolution in terms of neocords. In my initial days, when I started trying to do neocords, I couldn't get the length properly. I moved on to the Fred Moore's loop technique. And then once we had done enough loop techniques, then I moved once again to individual cord technique. Now, most of the cases we do individual cords. We fix it to the base of the papillary muscle, the tip of the papillary muscle, sorry. Initially we were taking pledgeted sutures, now we take only figure of eights. And our routine practice is to get these sutures in, push them back into the LV, get the ring in, and then once the ring is in place, then we pull these sutures out and get the sutures at the correct length. We pretty much basically use the Liga clip to get at the annular level, check the valve competence, and then tie it down. So once we are happy with the competence of valve, we tie down the sutures. Remove the clip. Be very careful when you remove the clip because you should not miss the clip and it should not fall into the LV cavity. If it falls into the LV cavity, retrieving the clip can be really difficult. And then check the valve once again. This is the technique pretty much we follow routinely nowadays. And those are the post-op echoes. And the last image on the right side is a 3D reconstruction from the LV side where you can see the two neocord holding on to the valve, anterior-mitral leaflet there. Now, there are various ways of anchoring the neocords at the level of the papillary muscle, at the level of the leaflet. Now, initially what we were doing, as I said, is we were using pledgets on both sides, tying down the pledgets and then fixing the cords. Then we moved on to simple sutures. Nowadays, routinely we use figure of 8 sutures. And regarding tying at the valvular level, what we do usually is to tie it up and leave the edges onto the atrial surface. There are a few surgeons who don't feel comfortable about it. They once it's tied onto the anti-mitral leaflet, they take a suture back and bury the suture and tie it down to the ventricular level. Now, AML repair in pediatric patients, we discussed a bit. LV grows in size as these kids grow. The neocords remain the constant length, but usually the papillary muscles grow to keep up the height as the LV grows. And when these kids grow, it can be re-repaired or replaced later. But if it is a pathology which can be repaired later, it can be easily repaired. And dilated LV has been discussed already by Praveen. And what are the complications of neocord? You can have ruptures of MR after a rupture of these cords. It could rupture at the papillary muscle head if you don't anchor it properly. It could rupture at the leaflet level. And if you have a thin jet, especially if it hits the mitral valve ring, you can have hemolysis. And there are so many methods of getting the cords at right height and right length. Now, the commonly used methods are fixed length cords with calipers. You could use without calipers. You could have anatomical cord lengths and adjustable cords. And there are people who use fixed cords like the French group uses a 2.5 centimeters cord for the AML and a standard 1.5 centimeters cord for the PML. And this is a technique which Dr. Jayakumar was showing in the morning, which we used to use earlier. Just for the benefit of beginners of AML repair, I'm just showing, if you don't have calipers, if you want to use fixed loop cords, this is how you can easily, in a single scale, you can cut down various lengths and keep it, you can restylize the scale whenever you want a case. You can have a 1.5, 2.5 centimeter cuts there and keep it ready. And this is a simple way of making fixed loop cords here. Very similar to what Dr. Jayakumar showed in the morning. We usually used to make 3 cords with one single CV4 suture. I'll fast forward a bit. When I was in Madras Medical Mission, later we got a caliper, but now I moved out of this fixed loop, fixed length cords. I used to adjust, routinely I use adjustable cords now, the routine single ones. But for a beginner, I think this is a very, very useful technique.
So what made you change your decision? Once you were comfortable with this good technique, why did you change it to?
No specific reason. But when I started, that's the stage I moved on from a single leaflet prolapse to bileaflet prolapses. When I moved on to bileaflet prolapses, then I thought too many cords is going to confuse there. So whenever we do a bileaflet prolapse, my standard technique, because all these bileaflet prolapses we've seen have excessive tissue. They are mostly Barlow's disease or end of spectrum where there is excessive tissue. So the way we deal with bileaflet prolapse now is to do a proper standard triangular resection of the PML and get neocords, 2 sets of neocords, one from each head of papillary muscle, from lateral and medial papillary muscle, fix it to the AML. Usually the bileaflet valve works very well. And then once this loop is ready, we get this end of these 2 needles into a pledget. And when we were using these fixed loops, we used to have pledgets on either side. We used to tie the pledgets onto the papillary muscle. But I was worried whether this tying of the papillary muscle will cause a bit of necrosis of the head of the papillary muscle. Probably that is one other reason I moved out from this loops to individual cords. Now failures are very rare. Most of these repairs last more than 20 years. The initial repair by the early surgeons, by the pioneers of this mitral valve repair, which was done in 80s, 90s, are still lasting. Tyrone David has a 25 years follow-up of his mitral valve repairs. It could be because of technical failure or disease progression or new lesions. And when you do a neocord, avoid holding PTFE with forceps and don't cause undue trauma to it. we should have special consideration in children and in dilated LV. And principles in AML, just to wind up, is never resect, and perforations of healed infected endocardium could be repaired with pericardial patch, but never ever try to do a primary closure of this small perforations. Neocords is the standard of care for AML repair. It could be fixed leg cords versus dynamic cords. Thank you. Yeah, yeah.
In the last phase, Jayakumar was doing.
What I would have done is, I would have taken I don't go out and close any of these clefts unless otherwise it causes leak after the ring is in and test the valve. And testing the valve also, there are various techniques. Nothing is foolproof. And I don't push the end of the nostril of the thing into the LV and push. I try to blow saline from outside and fill the LV rather than trying to push the thing into getting the LV filled from inside. I fill it from outside. Thank you.
So what we have seen is that when you use too much of saline, saline actually causes softening of the tissue. So use for like if you have a callus and all, you keep saline there, on saline. So if you keep on pushing saline into the left ventricle, the chordae will lose its tensile strength, and you will see that every place it is collapsing. So that time we stop and we actually come off bypass.
Yeah.
And see what is the. You don't go and check for
multiple times. Don't keep on testing it for multiple times. Yeah. And the other thing is like try to keep it as simple as possible. Like what we've learned over a period of time, the more and more steps you need, more and more time you take to repair valves. Obviously, the repair is complicated. The durability of the repair or the immediate result of repair or midterm result of repair may not be good. If you feel that multiple steps are needed and at the end of your multiple steps, if still the leak is very bad, instead of trying to spend more time on it, it's better to electively replace the valve. And a decision has to be taken, especially in our situation where we have to be very cost effective. A decision has to be taken before you open the ring. Thank you.
See, as I said earlier, I don't really mind going back on the second time and sometimes even the third time. So I come off bypass and see whether there is any residual lesion. But what I found that 90% of the time we are okay. We don't have to go back. But 10% of the time, so in my experience, it differs from surgeon to surgeon. But my experience, at least 10 to 15% of the time, I make a second CPB run. So yeah, so in general, I don't post any other case, afternoon case or anything for repair. So repair is the only case that is going to be posted in my OR. Very, very rarely only second case will be done.
So when do you decide to that is multiple small leaks at
Yeah, so initially I was very worried because second time when you go back, you have to identify what is the lesion that is causing. Otherwise, you are going to make it worse. So that is where as a team, we have grown together. From 2014, we are having the same team, Tushara, So every case, it's a continuous learning curve. And we had also an excellent anesthesiologist with us, Rashmi. Unfortunately, she passed away 2 months back. So we as a team group together. So it's mostly a teamwork. So second time, if you have to go back, you have to be and re-repair. You have to be very sure what is the lesion going to be. Otherwise, you are going to muck it up. So in our experience of second time going back, most of the time it is a residual prolapse. That is the reason. Second is the cleft, and third is the commissural, missed commissural prolapse. It settles. Yeah, I think the saline test is imperfect. Because if you look at the saline test, it is a diastolic filling, isn't it? Yeah, it is not a systolic filling, it's a diastolic filling on a flaccid heart.
But the tensile strain must be taking time to come back.
No, no, it will immediately come back. Immediately it will come back. Come off bypass, it will come back.
So are there any certain points where you decide that you don't want to fiddle more and wait to go out CPV? What are the criteria you
Basically we initially look at the echo and see what is the problem. So there are three, as I said, either anterior jet, posterior jet, or central jet, or unknown jet. You are not sure where it is coming from. Most of the time we find that it is from in the commissure. So we go back and we go and fix, and then you put the ring. It's very important that the geometry of the ring is perfect. So
lateral commission
posterior suture, and in the ring you place it somewhere else, then the whole.
If you need a second run, more than the surgical analysis, I think the TE gives you a better idea. Because once the ring is in, analyzing the valve becomes a bit tricky.
Yeah.
The role of TE is very, very important when you want to go back in.
So most of it's a 3D.
Usually it's difficult to find out the cause of recurrent or residual leak. So unless we can explain why there is a leak, probably it's a dilemma whether to go back. So and there may be multiple mechanisms. Sometimes it's a caudal length. Sometimes it was a missed restriction which was initially missed. There was a restriction of the leaflet, and you find the opposite leaflet was prolapsing, so you may miss the restriction. So, or a newly formed cleft.
So if you are, as I said, we have a good follow-up. So we have found that if you leave a central MR, usually it's okay. And if you leave like a cleft also, it does not progress. But if you have a residual prolapse, it will recur, and sometimes patients will come back with hemolysis. You have to reoperate. So ideally any leak more than trivial should not be accepted. That is in drop, because it is under anesthesia. So all the MRs will be underestimated. But the other side is that, especially young patients, putting a mechanical valve, you're going to have a lifelong problems with anticoagulation. And bioprosthetic valve is very, very notorious in young patients. We have even found like 4 years down the line coming back degeneration. So that is the importance of mitral valve repair. That we don't have a good substitute for it. Yeah.
No, it's not, but maybe it will give us 10 years. And now we have probably better medicines than what we had 10 years ago.
There is a rotation plasty. Rotation plasty has a thick tissue at all.
Yeah.
We have a leak, central leak. Though in other patients, maybe say 40-year-old boy or men, we may not accept.
That rotation plasty fails.
Even rheumatic in 2016 or 15, Tavisa came there. to Amrita, he did some very bad rheumatic valves. Now it's how many years? 9 years. None of the valves have come back for reoperation. Everybody has got some moderate MR, moderate MS and all those things. Not so bad. Yeah.
Off.
Hello,
Okay.
can you hear us?
Yeah.
In the OT?
Yeah, can you hear me?
Yes, sir. Go
Yeah.
ahead.
Yeah, we are off now, and the pressures are good. How much? 70 mean, and we are on ventricular pacing for the time being. Yeah. So Manjusha is already there. She's looking at the TE. So I was just hearing to Anbarash's presentation of the loop chordae versus single chordae. What is Praveen ji, what is your present practice? You go for the single one or means dynamic?
Yeah, single one.
Okay.
Always single
you
one.
don't, yeah.
Yeah. I tried loop chordae one case.
Yeah.
And unfortunately 3 months later he came back with rupture and hemolysis.
So for me, like if you have only a small 1 or 2 chordae means I may just put it down. Like there means do that, and then how will you measure? What is your technique of measuring and measuring the length?
Yeah, measuring length. Initially, we used to use the. I saw you using the scale inside.
Yeah, no, not about the loop chordae. No, when you are putting it down.
Single chordae.
Yeah, you with saline you inject and then.
No. What we do is we clip it. We use a lega clip, the red clip or the smaller clip, and try to get it at the annular level.
Yeah.
And then test the valve before tying it down.
Okay.
And if the length is not adequate, then slightly adjust the clip.
Okay.
Most of the time we'll be erring on making it too taut rather than too loose. Most of the time we pull it sort of clip it slightly lower down. Usually it's more of eyeballing and then gradually you get experience.
Yeah.
Right now we clip it at the annular level and then test it. If we are happy, we tie it off. The other useful technique is like what Praveen showed. You could get like a temporary alfieri of AML, PML tips so that you know at what level that clip has to be there and you can tie it down at that level.
I think that is one I also prefer, like you just put a loop between the anterior and posterior leaflet in the normal zones on either side, and then you just put it down. Okay, that is one thing. And the another is like if you, I think the Simuform also has the code, like or the Kottayam, they also the Memo 4D with Neocode. That also works well, I think.
Yeah. Memo 4D is more for a PML prolapse rather than AML prolapse. The concept which Simuform has brought out is quite good. They have a sort of string at the annular level there. You can fix the cord there and then later release the frame so that the whole suture comes out and the cords are fixed at the AML there at the annular level.
Yeah. Okay, I think Manjusha
so that thing we can actually do it on table. You keep one of the sutures down. I think there is a video on one of the annals of thoracic surgery. No, so you're tying the sutures. No, one of the sutures you can put behind the ring multiple times. So that there you can tie it off and then cut the suture.
Okay.
That idea, I think Simuform came from that video.
And just for the beginners who started mitral valve, it is not difficult to get the AML cord length perfectly at all. You might do mistakes 1 or 2 times, but it's not difficult to get the AML cord length properly.
Yeah. I think
the best way for a beginner to start AML prolapse, I feel, we all started like this, is to do a caudal transposition. I think it is very easy. You don't have to adjust any other chordae and take a chordae from P2 and put it in the A2. Most of the time it works well.
Or even
caudal
transfer.
Yeah.
Caudal transfer also sometimes if you have a secondary good chordae. But one problem is like the central portion of the AML, there is one secondary chordae most of the time, and if you take it out, is it going to add strain onto the AML? That is one thing which was discussed, no? So sometimes we just transfer the chordae from the AML itself, means chordal transfer rather than transposition, isn't it?
So there is one more method of just keep on tying the knots.
Yeah.
It's like laying bricks one over the other.
Yeah,
so once you fix it down on the papillary muscle, tie a knot, tie a knot, tie a knot, tie. So it's like a braid. It comes up. Keep it just there, not, I mean, little shortish. Pass the needles, check. It's still, so take it out another 2-3 knots, pass it. So because it's a braid, it's solid, kind of, so it can't move. But maybe you will be tying some 25-30 knots.
I think Dr. Manjusha is ready. Shall we see the echo?
Yes, sir. Please go ahead.
Okay.
Okay. Hello. Hello.
Yes, Dr.
Yes,
Manjusha,
yes.
please go.
Hello, yes.
Yeah.
So this is a post-bypass echo. Again, we'll be starting at 0 degrees. So we are seeing the 4-chamber view. So this is going to be the A2P2 segment. So always make it a point to check your 2D first, and then only put color. So here here, this is that, even in the pre-image, there was that, like a hockey stick, inverted tick sign was there. But here coaptation is happening anyway. So once you see that, you can just put a color on it. But there is no regurgitation. It's looking good only. Only thing that lie is looking a little eccentric. So I'm advancing to the commissural view. Again, there is no MR here. It's good. Now we are going to the 90-degree view. I think because of that repair, a lot of the tissue is crumpled together. Here also again, it's good. There is no MR, there is no flow acceleration proximally. It looks good only. So moving over to the long axis view, we can see that the coaptation is well away from the septum. It's happening well. Coaptation distance is 7 millimeters minimum is definitely there. Can you appreciate it? There is a, can you see that the tip of the AML is getting pulled into the LVOT, but there is no flow turbulence per se, because filling status is good.
That's the cord that.
Oh, okay. Yes, yes, it's this structure which is moving in. Yeah, correct. But there is no MR in this view also. Transmitral gradient is also, mean gradient is only 3.
So, you know,
it's a good repair.
Yeah, your OT notes should mention that thing. Otherwise,
yes,
3 months later, a patient has got UTA, it will be diagnosed as infected endocarditis.
Yes.
Yeah.
So, mean gradient is only 3, peak gradient is 6. Yes, we have to mention it actually, because otherwise it looks like a lot of loose tissue in the LVOT. So that's the problem. Hemodynamics are good. Short axis view of the mitral valve. LV function is good. There is no RWMA.
Praveen rightly pointed out, they will say sessile vegetation near the medial lateral commissure.
PML was a little on the very list.
Then?
Dr. Jaikumar, can you hear us?
Yes, yes.
So we've just had our tea here, and we, in few seconds you are going to hear all of us clap so that we also wake up and we appreciate you more.
Okay, thank you so
Wonderful
much.
job, sir.
Thank you so much.
Any more presentation, or do we have a? Is the next case ready, Jagumar, or?
Not yet. I think they are just shifting and.
Yeah, shall we have one presentation?
Yeah, sure. We can. We
Okay.
have enough time.
Manjusha? Hello?
Yes, hello.
Was there any mitral annular disjunction?
I know, I heard that question, but I'll just show you the reviewed images. But I didn't feel that it was that like there was a disjunction.
No, pre-op.
Yeah, the pre-op. Anup. There is some mobility of the annulus, but the PML is arising from the ventricular septum only, right, sir? I didn't feel that this is a. We can focus on this area.
Yeah.
But,
yeah.
So probably maybe grade 1 or something.
Yeah, less than 5 millimeter.
Yes.
Yeah.
But
Tushara has some doubts.
Yeah.
Actually, I think the distance, there's a spectrum that can happen.
Yes,
so
yes,
sometimes
yes.
The zero mitral annular dissection, grade 0, that means the distance is not significant, but you find that hypermobility of the annulus.
Yes.
So probably that is there, but whatever said and done, the final treatment is annuloplasty. We are not going to do anything different for that, unless the distance is more than 8.5. I think that's the cutoff for ventricular arrhythmias. So otherwise, I don't think they'll make a difference in the post-op.
Mitral annular disjunction comes under the arrhythmogenic spectrum of MVP, so that's also something.
Since we were just talking about mitral annular disjunction, I can just show the images of a 17-year-old boy whom we did last week. So he's a textbook case of mitral annular disjunction. One look itself. Tomorrow I think we will be having probably one more case where there is mitral annular disjunction. No. Directory.
Yeah.
This is a classic.
Yeah.
This is it's like a textbook case only. He was a 17-year-old boy who presented to us with severe mitral regurgitation 2 months back. His mother also underwent surgery for mitral valve repair 8 years ago. Both of them are very tall. They fit into that marfanoid habitus. It is a myxomatous valve. So the interesting thing about this case is that again there is disjunction, but there is a little hypermobility here. I'll just show the 3D image. So the interesting thing about this case is that that hypermobility was related to, you can see that indentation here, which is there. But so finally, sir just put a 38 ring, and that was enough. That cleft didn't cause a problem post-operatively. Nothing else was done, just the ring was placed. It was a very dilated annulus, was 56, and the LV dimensions are also very enlarged. But he's doing well.
Okay.
So this is what I mentioned. So this was there, but it just got corrected with the ring. We didn't have to do anything else for it.
What we see on table is, of course, there is a gap. Second thing is, and the ventricular surface. Second thing, on the atrial surface, you will see some kind of fatty streaks on this one, and it will be on the atrial side. Yeah, and it will be like very thin. And when you when you take the annular sutures, you can see that it is actually quite. It's not very firm structure. Film structure.
Dr. Jayakumar? Dr. Jayakumar, are you there? Okay, sure. We'll move on to another talk now. Now, most of us do degenerative mitral valve, and a lot of us don't do active repairs of rheumatic valve. Dr. Amit Chanda is one expert on rheumatic valve, and he's got a large series of repair of rheumatic valve. We welcome Dr. Amit Chanda.
Thank you, Dr. Anbarasu, for your kind comments. And I thank Dr. Jayakumar and the organizers for inviting me to this wonderful meeting. I'll be talking to you about a new technique of rheumatic mitral repair that we have developed at Medanta. So, rheumatic mitral repair has always been Achilles heel of all mitral repairs, and so many of us have tried to repair it and have given it up. So, for that we have developed a new technique at Medanta, what we have come to call as diastolic mitral repair or Medanta correction. So this was a big lecture. I will take the third part only, how I repair rheumatic mitrals, our concepts, practices and techniques, that is Medanta correction. Now, you have been, a 21-year-old female comes to you with this kind of pathology, a severe rheumatic mitral regurgitation. And if I ask the audience, all of you will repair it by either artificial cords or caudal shortening and to take care of the anterior leaflet prolapse. But once you do that, and I also did the same, and once I was finished, this is what I got. An anterior mitral leaflet, no leakage, but an anterior mitral leaflet that was doming. There was partial opening. There was mosaic pattern of flow through the mitral valve. The mean gradient was 5.8 and the valve area was only 1.5 centimeter square. So that bothered us a lot, and we started working on this issue. So the normal mitral leaflet should open like this. That is completely by hinge door mechanism, and anterior mitral leaflet tip should look away from PML. And here, if you notice, the AML tip is looking towards PML. So there were two concerns here. The valve is not opening fully like a normal valve. And number two, you have no control on the post-op gradients. Next time a patient comes to you with a little more fibrosis, more calcification, and then your gradients might be between 7, 8 or even higher, and then you don't know what to do. So you don't have a uniform situation here where you will say, okay, I will repair this valve and I will do a good job with low mean gradients. So classical commissurotomy, as described by Carpentier, is not an adequate operation to open stenotic valves. At Medanta, that is why we divide these patients into 4 categories: pure MR, pure MS, dominant MR plus MS, and dominant MS plus MR. For pure MR, we are doing French correction. For pure MS, we are doing the procedure that we have developed, that is valve opening procedure or Medanta correction. And for mixed pathology, we are doing a mixture of both. So I will go into the philosophy, function, and the technique of diastolic mitral repair or Medanta correction. The word valve is derived from valva, which means door. And to function, a door has to open and close. Accordingly, mitral valve also has a diastolic and a systolic function. For systolic dysfunction, which results in leakage, we have the methodology of French correction based on the concepts of functional classification to open these valves perfectly like normal valves. To correct these valves and close the leakage. And this was the classical paper, the most read paper by Dr. Alain Carpentier, the French correction, published in JTCVS 1983. And here he laid down the foundation of mitral valve repair in form of a functional classification, which was basically a classification of the morphological subsets leading to leakage or regurgitation. Thus, you had type 1 with annular dilatation causing leakage, type 2 causing prolapse causing leakage, type 3A, that is leaflet restriction both during systole and diastole, again causing leakage, and of course some stenosis. and then leaflet restriction during systole like in ischemic, again causing leaking. So Carpenter's functional classification was basically a classification of mitral regurgitation, different anatomical subsets causing mitral regurgitation. For that, he formulated different techniques to correct the leakage. Although he propounded commissurotomy, papillary muscle splitting, and secondary caudal resection for the diastolic dysfunction of mitral valve, but that was insufficient as I just mentioned, insufficient to properly open the valves. Because even after adequate commissurotomy, papillary muscle splitting, secondary caudal resection, these majority of these valves are left with mild to moderate mitral stenosis in form of doming, mosaic pattern of flow through the valve, inadequate separation of leaflets, high mean gradients, and smallish valve areas. Thus, in a study of small study of 97 patients, we had mean gradients of about 6 and mean valve area about 1.63 centimeters square. So up until now, we have known how to close the doors shut nicely by way of French correction, but not how to open them. Not satisfied with these results and with the knowledge that inadequate or incomplete repair is the commonest cause of failure early and in long term, we started working on this issue, and in last few years have developed techniques, concepts, and philosophy to open these valves perfectly like normal valves, what we have come to call as Medanta correction or diastolic mitral repair. So here is diastolic mitral repair for you. In this echo, you see the classical commissurotomy rheumatic mitral valve opened by classical techniques, and this is diastolic mitral repair for you. Look at the wide excursion of antemitral leaflet. The valve is opening fully. The valve area is 2.89 centimeters square. And this too in a patient who preoperatively had a tight calcific mitral stenosis with a pinhole meatus and a valve area of only 0.5 centimeters square. So this is diastolic mitral repair for you. So diastolic mitral repair is a scientific methodology comprising of concepts and techniques for opening the valve fully like a normal valve by hinge door mechanism with low mean gradients and large valve areas. It's based on three basic principles: that rheumatic mitral stenosis is a disease of both anatomical as well as functional obstruction. Even after anatomically adequate commissurotomy, functional obstruction may persist. And both anatomical, that is secondary orifice enlargement, and functional correction, that is restoration of the hinge door movement, are required to achieve a reasonable orifice area, and that is what we call as diastolic mitral repair. So the methodology of diastolic mitral repair is based on basic premise that mitral stenosis is a disease of both anatomical and functional obstruction. Accordingly, we have techniques to remove anatomical obstruction and make them function like hinge door. In this presentation, we will study the concepts of anatomical obstruction and functional obstruction, and accordingly techniques to remove anatomical obstruction, techniques of anatomical repair for anatomical obstruction, and functional repair for functional obstruction. Functional repair is of two types: leaflet repair and subleaflet repair. Leaflet repair is called extended commissurotomy. We will study the concepts of anatomical obstruction, that is concept of free margin contraction, and functional obstruction, that is aortic cusp effect and trap door concept. So we will study the 5 concepts first, then I will tell you why is classical commissurotomy still obstructive, and then we will study the techniques of diastolic mitral repair. So concept number 1, doming means obstruction. Leaflets are not required for diastolic function, that is passage of blood from LA to LV. They are only needed for valve closure, that is systolic function. For diastolic function, the leaflets might not as well have been there. Presence of leaflets is obstructive to mitral flow unless they completely move out of the way of incoming blood by hinge door mechanism. And if they don't, they balloon out like sail in the wind, and that is what we call as doming. As you can see in the figures, in the first figure, since the leaflets are completely moving out of the way, the whole amount of blood can pass. In second figure, only a partial amount of blood is able to pass because the leaflets are doming. So, and by that token, Residual postoperative doming indicates residual obstruction, and restoration of the hinge door movement is the ultimate goal of diastolic mitral repair. Second concept, that obstruction in mitral, as I have already discussed, obstruction in mitral stenosis is both anatomical as well as functional. Merely removing anatomical obstruction will not result in fully opened valve, and now we will see the concepts in anatomical obstruction and concepts in functional obstruction. So, and third, the anatomical obstruction and repair, the three orifices of mitral valve, the primary orifices made by the annulus of the mitral valve, secondary orifice made by the free margin of the mitral valve, and tertiary orifice between the free margin and the aorta. All the three orifices must be opened completely surgically to remove anatomical obstruction at all these three levels. Now, what is the concept of free margin contraction? Normal mitral valve is considered like skirt of a woman. In mitral stenosis, the free margin contracts and the skirt looks like a pencil skirt. In classical commissurotomy, we incise the skirt and the skirt looks like this. In extended commissurotomy, it looks like this. So the purpose of showing these pictures is to show that if you want to enhance the mitral skirt, you need to insert triangular patches into the slits that we create. Now, what is functional obstruction and repair? The first echo is showing pure mitral regurgitation. The valve is opening nicely with a mean gradient of only 3. I repaired this valve by pericardial extension of the posterior mitral leaflet and classical commissurotomy. And you see that now the valve is not opening at all. Both leaflets are doming with a mean gradient of 8. And notice the movement of posterior mitral leaflet. At the height of diastole, when the flow of blood distends it, its free margin or its leading edge further move towards anterior leaflet to obstruct the valve, to further obstruct the valve. So this means that doming causes functional obstruction by aortic cusp effect. The aortic cusp concept goes like this. A leaflet behaves like an aortic cusp if it is attached on 3 sides, just like the cusp of an aorta. The free edge of aortic cusp moves towards the center of orifice when the flow of blood distends it. What is trapdoor concept? For a leaflet to move like a trapdoor, it has to be completely free on 3 sides. As you can see that side 1, 2, and 3, if they are completely free, only then the leaflet will move fully like a trapdoor. Now I will go on to show why is classical commissurotomy still obstructive. In rheumatic mitral stenosis, the fusion of commissures leads to contraction of the secondary orifice and formation of a mitral diaphragm. So that now instead of 2 leaflets, it's now a diaphragm with a hole which blows like a sail in the wind, which is called doming. And at the height of diastole, the leaflet edges just slide away, but only partially, and continue to look towards each other. And this is called the sliding door mechanism. So in rheumatic mitral stenosis, the door opens by a mechanism called sliding door mechanism, and the purpose of diastolic mitral repair or Medanta correction is to make them move like a hinge door or a normal door. So in classical commissurotomy, we incise the commissure up to within 5 millimeters of the annulus. Anatomically, this is an adequate enlargement of the rheumatic mitral orifice as judged by 2-finger test. And because the fingers push it open like this. So this is an adequate anatomical enlargement of secondary restrictive orifice. So this valve is anatomically open. And as I have shown here, I did classical commissurotomy and then inserted into the orifice is a valve sizer of 25, which has an area of 4.9 centimeters square. So anatomically, this should have an opening of 4.9 centimeters square, but that doesn't happen. Usually, we don't get a valve area more than 1.5 or 1.6 with classical commissurotomy. So, but when the flow of blood distends it, the whole valve balloons out and distends, and there is doming. Both leaflets dome with only a partial opening. So this valve is now functionally obstructive because of aortic cusp effect. Now, what are the techniques in diastolic mitral repair? So initially we reasoned that the anterior mitral leaflet is doming because it is still part of mitral diaphragm. So to disconnect the AML from mitral diaphragm, we incised the commissures right up to the annulus, and to prevent leak at the corners, we placed one magic stitch at each corner. But but the leaflets were still doming, and the valve orifice was still restrictive. Then we reasoned it's probably because the part of the anterior mitral leaflet shown in red is still attached on 3 sides, and that part was doming along with the rest of the anterior mitral leaflet. So that's when we decided to develop diastolic mitral repair along the concept of trapdoor concept. We decided to take the incision right up to the trigones to make it move like a trapdoor. But in practice, the commissural fusion doesn't occur like this. The commissures are situated more laterally. You can't incise vertically up to the trigones. So we had to go along the commissures. So in the extended commissurotomy, we extended the incision along the commissures up to the annulus, and then along the annulus up to the trigone. That not only gave us a very large orifice area, but also an anterior mitral leaflet that moved like a hinge door. And to prevent leak at the corners, we placed a triangular patch of pericardium whose 2 sides were attached, one side on the anterior mitral leaflet, other side on the annulus and part of the posterior mitral leaflet. The base remained free, and to prevent prolapse, the base was attached by a CV6 suture to the commissural papillary muscle or its equivalent. That not only made the anterior mitral leaflet move like a hinge door, but also enlarged the secondary orifice along the concept of free margin enhancement by inserting triangular patch here. What is functional repair or subleaflet repair? In order for anterior mitral leaflet to move from closed position at B to open position at B dash, all the joints A, B, and C should be well oiled and free from any restriction due to thickening, fibrosis, fusion, and calcification. So any pathology at all these joints is removed surgically. That also means that in order to make the papillary muscles move along with the anterior mitral leaflet, which are thickened and fixed in rheumatic mitral stenosis or rheumatic mitral disease, we incise the papillary muscles right up to the base and make them thin so that they also move side by side along with the anterior mitral leaflet. This was a small study of 12 patients in July 2016 to 2017. We compared 12 patients with age, sex, and weight matched randomly selected patients with traditional techniques, and look at the bottom line. The mean gradients with traditional techniques 6.8, with diastolic mitral repair 3.14, mean valve area 1.57 with traditional technique 2.95. Of course, these were carefully selected patients. 2.95 with diastolic mitral repair. So here is the technique of diastolic mitral repair. We have deliberately chosen a bad calcific valve to show you the technique. You can see in upper left hand corner, the calcification valve is hardly opening. So this is the incision into the anterolateral commissure. This incision is taken right up to the trigone along the annulus. The thick anterior mitral anterior anterolateral papillary muscle is incised. This is the commissurotomy of posterior medial commissure. A thick secondary cord is excised. Anterior leaflet is thinned. Thinning was done. Now this thick this primary cord was thick and calcific. So we removed it and replaced it with an artificial cord. A triangular piece of pericardium was taken. This is glutalate treated. Sorry? We'll discuss it, yes, yes. Then one side was attached to the incised annulus and the posterior mitral leaflet, cut edge of the posterior mitral leaflet. The other side was attached to the cut edge of anterior mitral leaflet. The base was attached to commissural papillary muscle or its equivalent by means of a CV6 suture. Extra pericardium was incised. The valve was tested for its systolic function. There is no leakage. And now look at the postoperative echo. There is no flow acceleration through the mitral valve. The flow is laminar absolutely. The mean gradient is 1. The valve area is 3.1 centimeters square. That too in a mitral valve which was densely fibrosed, calcific, with lot of thick cords, lot of calcific and cords. So this is what it does to rheumatic mitral valves. Since 2016, this is the procedure for us for every rheumatic mitral repair, and it has really given us good results. So our current strategy to maximize durability in rheumatic mitral repairs, we cut out all the diseased tissue as you saw it. We replace it with autologous tissue pericardium, extended commissurotomy and extended papillary muscle splitting as in Vedanta correction, leaflet thinning, that is peeling. We cut out all the thickened cords, secondary or primary, artificial neocords. We choose patients, AML more than 26, age more than 45 when the rheumatic disease has died down. A burnt out rheumatic disease will not usually progress, and strict secondary rheumatic prophylaxis for those under 45 years. So that is our current strategy. And in conclusion, rheumatic mitral valves remain stenotic with classical Carpentier techniques. Vedanta correction is the technique to open these valves perfectly like normal valves. What French correction is for mitral regurgitation, Vedanta correction is for stenosis. Thank you. So you were asking about the dimensions, how we cut the patch. So we take the cut length of anterior mitral leaflet. So that is one side. We measure the cut length of the cut on the annulus as well as posterior mitral leaflet. That is the other side of that's all. We have lately in last 30-35 cases, we have changed that instead of taking a triangular patch, we are now taking a rhomboid patch, and we are slitting in between so that like a pajama, it has two legs. Each leg is stitched, one to anterior papillary muscle and another to posterior papillary muscle. Because in many cases we did not find a commissural papillary muscle. In many cases it's not there, it's just not there. So now we have changed it. The other advantage of this technique is if the whole triangular patch fibroses with time, that commissure is gone. With a slit in the middle, now there is a very thin sliver of tissue, say 3 millimeter to 5 millimeter, which is holding these two leaflets together. Rest of the pericardium is only acting to prevent leakage and providing a coaptation. So that is the change that we have recently undertaken.
So you do it in both sides?
Usually I try to do it on one side because I still don't have very long-term results of so much of pericardium. So the side which is more involved, I do it there. Other side, I do classical commissurotomy and put a stitch. If both sides are equally long and equally involved, say in a mitral stenosis which is only 0.5 centimeter square, a large valve, both sides are fused, there I have to do no choice but to do both sides. And then I place, initially I was placing a felt ring, Dr. Sampath's ring, but I didn't have very good results. Leakage was a very common phenomenon after. So then I switched to rigid rings. Sorry? Decalcification, you see, lot of calcium can come off when you peel the anterior mitral leaflet. Yes, it is on the rough part only. So it can come out, or it starts coming out. So you begin there. When you reach the rough part, you will find a slit between the two, transition or a gap between the two. There you can start sharply cutting. Yes. 16, yes. That patient is still under follow-up. That patient underwent severe COVID to the extent that, and he survived everything. So he is back now.
And the valve area holding?
No. As I said, if it is pericardium, it will undergo contraction. So the mean gradient to start with were 2 or 3, 1 or 2. Now they have come up to 5 or 6 in 8 years' time.
Dr. Chandra, it is fantastic. If this operation is to be done in active rheumatic phase, active rheumatic arthritis, what are your worries?
You see, active rheumatic carditis will first initially manifest with regurgitation, pure MR. No? So this is basically to open the valve, not, so there you will need French correction, techniques of French correction, because that will be pure MR. There will hardly be any commissure fusion. And if there is any commissure fusion, it can easily be incised and the valve made normal.
But in long term, how it will behave?
See, I had some doubts initially before I switched to the second technique of the contraction of the triangle. If the triangle contracts, the whole commissure is gone. But if you slit it in between, then I have started doing it for last 3 years, and those patients are very stable. I still have to have a very long-term result to say that it works.
Have you tried this for some of these pediatric, like a single hammock kind of valves?
So I presented it in MITRAL Conclave, New York, and that was everybody was excited to see the technique of repairing a commissure with a triangular patch. Yeah. So immediately, Dr. Bacha, Emily Bacha, yes. So he said that I will use it in pediatrics. I have not used it. I am not doing pediatrics. So. Yeah, but probably it can be used. Yes. Because these are the principles of valve opening, you know. So you can use it anywhere. They don't work. You try it and you will be happy to see what you have done. You will be, it will work like a magic.
Used in other scenarios. Do you have any long-term thing from other series, like for example, aortic surgery or autologous pericardium?
Has not worked. That's what I'm saying. It has not beyond 8 or 10 years.
That's why I say Uzaki will be having the same problem.
Uzaki is going to have the same problem. Yes. So that is why I'm saying. That's why I've split the pericardium.
There's a new kind of pericardium from Dr. KMC's place. It's supposed not to calcify. Have you tried that? Syncardia.
D cell. It might work better, yes.
I'm not sure what the long-term results are about recalcification.
Just like core matrix, it came with a big bang.
So whatever said at the end of the day, pericardium is pericardium.
Pericardium is pericardium.
If you don't treat it, it sort of shrinks. If you treat it, it
Gets calcified.
If you get
So
a,
both ways.
If you get a reasonable 10 to 12 year result out of it, it's good enough because the kids grow up.
But the amount of pericardium in the commissure now is very little, 3 to 5 millimeters only. Even if that calcifies, the movement of leaflet will not hamper. So you can use it in pediatric population. I mean, the same principles that incise the subvalvular right up to its base and insert the pericardium in the commissure.
Confidence doesn't change. If you make it 2 slits, the pajama leg, the confidence that commissure remains.
Initially I had my doubts, but it
you don't support it with any cordage.
no, the leg of the pajama gets stitched onto the capillary muscle. That's it.
On both sides. On both sides.
On both sides. It works like a small cord.
So which is better, native or fluted and pericardium or bovine pericardium?
You know, I am using half and half. So I am not using 0.65% for 5 to 10 minutes. I am using it only for 2 minutes. And then I wash it vigorously for at least 10 minutes. So my pericardial preparation itself takes 15 minutes before surgery.
So native pericardium is not better?
No, native, I'm using native pericardium only. That's what I'm saying.
Pericardium without treated?
Untreated, I mean, I have my doubts again. It might shrink, you see.
Untreated shrinks.
Untreated might shrink, yes. So that's why I'm using half and half, little treated. Not fully untreated, not fully treated.
How many cases you have done?
112.
Very good presentation.
Thank you. Because we developed it at Vedanta. And you see, there is another reason. Because you can't use the names, you know, proper names in the international presentations. You can't use institute names or your name. So Vedanta has 2 words. Med means disease, Ant means end. So basically it means end of disease. So you can use that logic for using Vedanta for international presentations.
It's like French, correct?
Yeah, it's like French. Your pulmonary valve. Yes.
That is it. Yeah.
Yeah, I mean, why use that if pericardium is available?
Knife. Knife.
Good afternoon, respected faculties. Our last case for today, 41-year-old female with history of dyspnea and exertion, grade 2 for the past 7 months. She gives history of palpitations, orthopnea, history of on and off pedal edema for the past 6 months. She also gives history of rheumatic fever in the childhood. There is no other medical comorbidities.
Okay, go on.
And on examination, patient is having AF with heart rate, fast ventricular rate, and BP is 110/70. Pansystolic murmur is there. ECG is showing cardiomegaly, LA and LV is enlarged. And chest X-ray and ECG is showing AF with FVR. Echo LVIDD and DS 6.9, 4.3 and EF of 52. Transthoracic echo showed AML flail, probably rheumatic etiology according to the cardiologist. And low moderate TR, mild PH, good LV function, and IS aneurysm dimension. Coronaries are normal. Low moderate TR, unless his size is less than 4.
Manjusha. Next. I think the TE is ready. Manjusha will be showing it now. Hello.
Hello.
We can hear you,
yes,
Dr.
Yes,
Manjusha.
yes, okay, yes. So this is our
Yes.
last case for today, and perfect case after discussion for rheumatic heart disease. So this is the TE image of Minnie. So she has a history of rheumatic fever. So this is now 0-degree view. So the multiplane angle is at 0 degrees. We can see that what strikes you is that the LA is hugely dilated. LA is hugely dilated. You can see the anti-leaflet mobility. Anterior leaflet mobility is okay, but posterior it's not that clear here. She's actually having AF with a fast ventricular heart rate is a little on the higher side, 100. So she had some pericardial effusion, which we drained before we took her inside. Here, this is the although the multiplane angle is 85, it looks more like a bicommissural view. You can see P1, you can see A2, and you can see P3. So that medial commissure also there is a prolapse, and there is some amount of echo density right under the leaflet. So it is probably calcium versus fibrosis. So this is the long axis view. Again, we can see that there is an anterior leaflet prolapse. It's a posteriorly directed jet. There is flow acceleration proximal to the leaflet. And again, PML movement is not that good. AML length is good, 35. The PML length is 12. The thickness of the leaflet is around 5 millimeters. ALPL ratio is 2.9. ALPL ratio is 1.8. The C-sub distance is 3.3. So since in the morning we had a discussion about like patients with pre-op, already in this case if we are anticipating some amount of a stenotic valve, the mean gradients across the valve was 4, peak gradient was 13. So LVT diameters were okay. So this is the valve once again. We can see that subvalvular pathology is also there. There is no AR. Usually it's always important to assess the other valves when you're suspecting a systemic disease. She has moderate TR and RVSP was around 60. So EF is good. EF is around 78. So coming to the 3D, one second. Yes. So this is the 3D end-phase view. Here we can easily see there is a ruptured cord at A3, and there is some excess tissue here also, and some calcium is also there. From the ventricular view, you can see the subvalvular calcium again at the medial commissure. It is there. PML is not coming up into the annular plane, but this is probably not a good view to comment on that. So this is the same thing. I had a 2D shot, subvalvular also I'll be able to show. This is a tricuspid annulus is not dilated. It's 35 millimeters. The circumflex is well away. For this patient, you can see the circumflex flow. This is the distance. So there is some calcium in that portion also a little. It's a little echo dense there, and the distance. The shortest distance I got was around 3.4. Anyway, it's not less than 3. So it's around 3.4 millimeters. That's probably a little underestimated. There is no PFO. The septum is intact. Then so this is a short axis view of the mitral valve. We can easily see sometimes if the heart rate is not good, sometimes the 3D images might not be that great, but 2D definitely is informative. So you can see that speck of calcium which is happening at the medial commissure here. So this is the transgastric view of the subvalvular apparatus. Again, some echo density is here close to the LA appendage on the lateral side also. Another view which again, since the morning we had a discussion on how much TE can help in seeing mitral annular calcium. If you have a 3D reconstruction, you can adjust your short axis plane to see where the calcium is. Like for this case, I was a little worried about whether there was calcium close to the medial commissure and the septal side. So that's corroborating with the short axis view here. You can see that this is the aortic, if the aortic valve is here, this is the lateral commissure, this is the medial commissure. You can see some calcium here. So this is again the calcium which we can see in this portion here. It's in the subvalvular portion also and as well as part of the valve. Any other questions? LV function is okay. This was the effusion actually. With pericardiotomy that had disappeared. So her initial CVP was 24 and since we drained the fluid it has come down to 14. But still her RV pressures are a little high. TR peak velocity is 3.9, RVSP is around 17. So to summarize, it is it's a case of a patient with the history of rheumatic fever, but what we are seeing the lesion is definitely there is a prolapse at A2 and there is a plate segment and also medial commissure is also involved. Plus there is calcium it's there in the subvalvular level and some part of the annulus near the medial part of the valve. Leaflet tissue is there for the AML. Mobility of the tissues are also relatively okay. The posterior leaflet is a little restricted, but AML mobility looks good. Leaflet thickness is also around 5 millimeters, so it's borderline, not too thick. So this is where
table up and away. So I think she is a very sick patient, like the typical mitral who is yeah, just give me that. The camera just the typical one who is having that severe PAS, then some amount of this. Hello, can you hear me?
Yes, sir.
Yeah.
Good.
So little that's sick kind of a patient, who was used to be there routinely earlier, But now we hardly, once in a while only we see such sick patients, because if you look at the Kerala scenario, the literacy rate is high, and probably the healthcare accessibility is good. So when I started my career here in 2000 after my MCA, at that time we used to get a lot of such patients. Now it's not a very common thing to have, say, a patient with huge heart and failure, and then rheumatic patients coming like this, especially rheumatic as such. It has come down very much. So we'll see. But I don't know whether it's purely rheumatic one, because it's not the very typical rheumatics which we used to see, isn't it? Section. Yeah, can you see it now?
Yes, we can see it well.
Yeah. Initially I thought we may have to take care of the tricuspid also, but I think tricuspid is only 35 and there is no significant here. That's what Manjusha is saying. So that way we are comfortable. Section, what's it?
Can we adjust the white balance of the camera, please?
Yeah, just yeah, we'll do that. Just get a gauze. Yeah, first we have to get it. Yeah. Then another, yeah. Where it goes with that? Okay. Okay, right. Is it better? Yeah.
Yeah, a little better. Yes.
Yeah. So this patient also in AF with a dilated atrium. I think we will do some left atrial reduction also. Okay, I retract. But do you think this is something like rheumatic? Yeah. Look.
It doesn't look like it.
Yeah,
from
it
here.
doesn't look like rheumatic. It is something like maybe could be a healed vegetation there somewhere. The PML is looking good. AML, there is prolapse definitely. So the A2, this chord is prolapsing and this is ruptured, okay, and probably what we were seeing as calcium is this tip which was scissors. So where should we fix the etiology? Yeah. Hook. I think yeah, there are some healed vegetation sort of a thing here. Perhaps. Okay, I'll do that. Yeah. And there is right? 1 second. Correct. So that I'll get some space to move. Okay, yeah. So table up and away from me. Organizers, future organizer. Yeah, away from. I think it's little, yeah. Backhand switcher. So again, the same trigonal suture and the annular ring sutures we are taking. So what should be our plan? I think I feel it basically an AML issue where the AML is prolapsed mostly due to some rupture of the chordae, and there's a little extensive area, like both sides, both anterolateral and posterolateral papillary muscle is affected, means from there the chordae are affected. So let's see.
Yeah, I also agree with you. I think it's a myxomatous valve with the ruptured chordae and possibly post-infected endocarditis, isn't it?
Yeah, possibilities there, definitely.
Yeah.
No, I was just listening to the Medanta technique. I think I have heard it earlier once, and then have you ever used that Medanta technique, Praveerji?
No. We hardly see mitral, most of the mitral stenosis. Even if we see, they get balloon mitral valvotomy.
Right. Yeah, that's what we hardly see at that level, and in Kerala the rheumatic incidence has gone down very much. But one case where there was one young boy with infective endocarditis, okay, and the entire, say, A2, A3 and P3 were eaten away fully. So after debridement, he was in acute phase, hemodynamically compromised, in very bad shape. So I took him up during that acute phase itself. So I had to just dissect off the entire A2 and A3 and P3. So if you look at this thing, so if we have 2/3 of the leaflets intact, we can do a repair. So I was remembering what the presentation once I heard from him, and then I took a piece of pericardium, and then put it in that gap and anchored it down. The free edge was anchored down with a Gore-Tex, just like the neocordae, and it worked very well. And the postoperative, if you see the echo, there was nothing. I'll show you the video if the time permits. Actually, it was a very good repair at the end. So I think even though this is a good concept that we can replace the commissural area with a pericardium and anchor it down to anchor the free end down to the LV, so that you will get a competent valve with with minimum gradient.
So I have also used it in infective endocarditis settings.
Right. Yeah.
In commissural areas, and it has worked really well.
Yeah. You use fresh pericardium or glutathione preserved bond?
I actually use half and half.
Okay, right.
Like glutathione treatment for only 2-3 minutes.
Oh.
And then I wash it very feverishly.
Okay, right. I use fresh pericardium, but it is good.
PTFE membrane is another option that can be used
Okay.
But I have no experience with that.
The pediatric cases, tetralogy and all, we use the PTFE membrane for the monocus valve,
For the monogus, yes.
but in the mitral position we never used. But I don't know, with the mitral, especially anterior mitral leaflet area, the 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 pressure load is very high when because it has to withstand the entire systolic pressure. So when you put a membrane and suture it, even that suture lines, no, it will be like small holes. It's not very tough structure. So I'm worried whether if we put it like that, it can.
So when Dr. Shi first came, we asked, like he uses the pericardium for the aortic valve repair. We asked him whether why not use PTFE. So he said he has tried it, but he said within 3 months it forms like a fibrous peel, or that PTFE, and then it fails. So Jagumar, I was telling Dr. Amit Chandra that this technique we may not see rheumatics that much, but some of these pediatric patients like this hammock valve and parachute valve, some of these cases this technique may be useful to open up.
Yeah, definitely. Yeah. It's a beautiful concept. Like now because if you look at the valve forceps, the rheumatic forceps, what we feel is like even this entire area is holding on, and we are trying to just mobilize the remaining thing. That means only this much movement we are getting, no? But the advantage with this technique is the entire thing will move.
Right.
Yeah, that's what I felt like. Forehand.
It was developed as a concept initially.
Okay, yeah.
And then I wanted to see what the results are.
Very good.
So results, acute results, they are like magic, and even long-term results are not bad.
Hook. We'll see once again what exactly is the problem, like, you know. So I don't know whether you can see this, the fanning out chordae. Can you see that?
Yes, we can see that.
Yeah, this is one beauty of it. It is like the pillars supporting the this thing, no? Like it looks so beautiful, like
La Familia Sagrada.
Yeah. Another hook here. Hook. So here, I think this is the commissural area that is holding good, but beyond that, it is prolapsing. It has started prolapsing from here. Okay?
Yes.
Yeah. Then, of course, this area is prolapsing, and then this is okay. That means the chordae, whatever is seen in the last portion, that looks fine. Commissure is okay. Yeah, this is holding good. P3 is good. P2 is good. But there is a cleft here, but we'll see whether it is of any importance. There is no prolapse. So now, how many cords we need? the prolapse is more on this side. This is ಸರಿ ಇದು ತರೋ ಕಾರ್ಡ್ ഉണ്ടാക്കി hook series 4 scale forceps so it is again 2. Okay, same way we measure. Yeah, 2 is good enough. This is top camera.
Are you going to be putting 2 sets of cords?
Yeah, we have 2 because
so three in each? Or
2 or 3 will be, it's not a very big block. Yeah. Good. So top camera please.
Can you show us while you are making the cords?
Yeah, top camera please.
Top camera, yeah.
Projection team, top camera please. They're just getting it. Done? So, are you seeing the top camera
yes,
now?
Yes, we can see.
So this is it. 1, 2, hold. 3, 4, yeah. Need a holder. Budget. So this is it, okay? Maybe hold on. Yeah, attack nicely. Okay. Cardiotomy. Yeah.
Yeah, we can go back to the endo camera now. Yeah, thank you.
Yeah.
Thank you. Yeah.
Can you see it now? Like Dr. Andrews was saying, he was worried about the papillary muscle say necrosis. The same with me also. So I was thinking when we take this thing fully, it can get necrosis. No, so this is how I take it. Like if I'm going down into the papillary muscle body, I will not be taking a full circumference thing. There will be some of this area is left alone without any constriction. So that will maintain the supply. But otherwise, if you are going to the head of the papillary muscle, that's fine. You don't have to worry about it. At the project. Forceps. Yes. Switch it back and switch it. Forceps. Cut. Okay. and a hook. Hook. പുതിയതാണ് കേട്ടോ. Hook and a hook. 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 I think there is a problem. It is slipped inside. I have to just remove it and put a new one. Okay? Knife. Scissors. Scissors. Where on earth? Section. So I can show you that sometimes it can happen like this. So if our knots are not proper, it will slip like this. I don't know whether you can see it. Yeah. Hook. Hook and another. Okay, another scale. Good. Yeah. Back hand. Okay. Okay. Back hand. Okay. ಮತ್ತೆ ಇದು ತರಾಮ ഒരു പ്രോലിനോട് എടുത്ത് വെച്ചേക്ക് 6 അല്ല 4 വെച്ചിട്ടുണ്ട് backhand. അടുത്ത ട്രോളിയിലേക്ക് വേണ്ട പുതിയതെടുത്തോ പുതിയതാണത്
Can you adjust the scope, please?
Yeah, yeah, he's just getting it ready. So hook. So I have done with this area, and see. So that is done. Now this is the place. You can see this much is there. So probably I may need only one cord. And or even this is something more like a cleft, no? This is more like a cleft rather.
Yes,
I think
probably it can be closed.
yeah,
Yes.
I think we'll close the cleft, and if needed, I'll put a single cord, and then that time we'll see. Okay.
Right.
Okay. Saline എടുത്തന്നെ. Saline for checking. Okay. Check. Pressure എടുക്കണ്ട ഇവിടെ വെച്ച് തന്നെ I can show clean and do it. Okay. വേണമെന്നുണ്ട് പറഞ്ഞാൽ മതി. Okay. Okay. ആരും നടത്തി കൊടുക്കണം. Somebody is super. It should be alright, I think. We'll see. Huh? Okay. And the size of that 34 went down. I think 34 will go in easily. 36. I think we'll go for a 36. Okay. 36. കയറി കഴിഞ്ഞല്ലോ. No need to take it out. അവിടെ വെച്ചാൽ പറഞ്ഞാൽ മതി, ക്ലീൻ ചെയ്ത് തരാം കേട്ടോ. There it will be a problem with the camera. Okay. So top camera please. So actually, if that that particular papillary muscle head from which those 4 or 5 chordae were coming, they were all elongated and partially ruptured. But still, if that was a healthy chordae, we can do a papillary muscle sliding plasty and then bring it down. So that is another option in such cases. Sometimes a portion of the AML which is totally supported by the a particular bunch of say chordae coming from a single head. So most of the time we can put it down with a papillary muscle sliding plastic. I was thinking about it in between, that is why I was looking at it, but it's not a healthy cord, that's why I didn't use it. How many? What number?
13 total.
And Parisha and Praveen is there or somebody is there? Because
we are here.
Yeah, all are tired.
No. I think you are more energetic than us. So by the time we will get Deepa to present a bit on the form ring. Just another couple of minutes she's getting the presentation. By the time you implant and test the valve, you'll get it.
That's right, yeah.
Thank you.
Did you have lunch, Jaykumar?
Yeah, I had in between something before the last case.
Okay.
Because if I come, we started quite late, no? So that's why I thought I will stay back here rather than coming over and then getting late. Okay.
Right.
Yeah. How many more?
3 more. Third.
So you were talking about papillary muscle
sliding. Yeah, sliding.
Do you reduce the chordae at the free margin level?
Yeah, sure. Yeah.
Do you do that?
Yeah. Both are done. Like suppose it's only 1 or 2 chordae. That happens basically with the other FED type of diseases where sometimes you have to adjust here and there little bit.
Yeah.
Those cases after putting in the ring, then you see where exactly it is, and sometimes it may be a small prolapse from somewhere and a small jet coming out. So you can easily manage with reducing the length at the leaflet end.
Yeah, okay.
The other is like this case, I don't know whether you have noticed, I was looking at the papillary muscle head and the bunch of chordae.
Yeah.
I was initially thinking like, because the first one I put, the loops get loose in between.
Yeah.
Maybe I was pulling a little too hard with I wanted to save one CV4 for the other side. So I thought, okay, because each CV4 costs something more for the patient. We have limited budget only. But I think probably that must have ended in, yeah, so.
So this, using this projected annuloplasty switches, is this your own modification, or did you learn?
No, I think I don't remember where exactly I saw it, but I saw one US surgeon.
Yeah.
I don't remember his name also, sometime earlier when I started off with the program. So what happening was that time, the annulus, many times I felt, when you take the parallel switches, it came out, then I had to put some additional protein switcher to fix that area and something like that.
Yeah.
So that time only I saw this. Then I thought, okay, it's a good technique. Started using it, then I found it really comfortable. So just all that.
Right.
And for the staff also, there is no confusion because no change, nothing is needed. The same thing it comes,
Yeah.
And actually, I was using the same 26 needle, 26 mm20. But after starting the minimally invasive program, I have changed it to the 17 mm needle. So otherwise, the big needle itself I was using earlier.
Okay.
Because in minimally invasive, you find the 17 is really better. Like, it's good.
Okay.
Yeah.
So you're, after this one, you still, you think the valve is myxomatous valve, isn't it?
Yeah, that's what I feel. No?
Yeah, also, yeah. Because is it common to have a flail AML in a rheumatic valve? Is it?
That is one thing. Like in many cases, if you look at rheumatic, when we had a lot of cases earlier, A3 flail is A3 flail prolapse. That is something along with the PML restriction, other than pseudoprolapse. You may be thinking it is no. Other than pseudoprolapse, sometimes I have seen, and sometimes I used to say, okay, that's a very common lesion in rheumatics. I feel means if there is significant MR. So I see it. I think.
Yeah.
What about you? What do you feel like in many cases? Even though we feel that the pseudoprolapse, on table finally we find that okay, there is something in the.
So in mitral valve repair, which are the valves you will not repair straight away? You say that okay, I'm not going to repair this valve. I'm going to replace.
Maybe heavily calcified rheumatic, one where nothing is going to happen, and I think almost all degenerative cases we can repair. Even I think even mitral annular calcification is also not a contraindication. Because you can really decalcify it, you can mobilize it and do it, no issues. Then infective endocarditis, of course, after the first thing is whether not to repair or to replace, but to debride it fully and then see what we can do. That is my philosophy. Like there is no point in planning something early, go for a limited debridement. No, first extensive debridement and then see what you can do.
So do you, like a minimally invasive, do you select patients for minimally invasive, or you are comfortable in doing all this now through minimally invasive?
If somebody is asking for minimally invasive, I think we will go ahead. Otherwise, just for the teaching purpose, demonstration most of the time, I select patients where I will not be very comfortable.
I'm asking whether, like, are you comfortable in repairing all these valves through minimally invasive?
Maybe other than rheumatic.
Other than rheumatic,
Yeah, rheumatic, I may not prefer to go for that.
Okay. So Ambarish is asking how you are approaching the subvalvular apparatus through minimally invasive.
Yeah, actually we can really nicely see, we have the monostaffed instruments, with that we can go in And then suppose you want to really see inside difficulties, what I do is put a stage switcher into the AML.
Okay.
Yeah, put a stage switcher into the AML and pull it out. Okay, or pull it so that you will be able to see it very well down.
Now, your approach is a submammary approach or a fourth phase approach, or is it a transaxillary approach for minimal invasive?
No, this is submammary, that small thoracotomy, no?
Yeah. Okay. Do you use any of the special instruments for?
Yeah, we have the full special instruments.
The one to expose the subalveolar apparatus.
No, I don't have it. That's why I put a switcher and do it.
Okay.
Yeah. അങ്ങനെ എടുത്തൊന്നാ വരത്തില്ല. You have to. I think. വേറെ സ്റ്റാഫ് ആരും ഇല്ലേ? ഒരാൾ മാത്രം കയറിയത്. ഇറ്റ്സ് ടു ബാഡ്. പുഷ് ചെയ്ത് പുഷ് fill it fast. I think we have to put that one section. Can you see it?
Yeah. That area needs a single cord at least, isn't it?
Yeah, I
that
think
medial
so.
part.
Yeah.
Medial part needs a single cord.
I think so. We need to. ഒരാളുടെ കയറാൻ പറയാം, ചെക്ക് ചെയ്യാനില്ല മെനക്കേടാ. All these things go underneath. Hook and hook. Hook. Section. Another hook. And then there's a small prolapse here. I think this is the area which is prolapsing.
Yeah.
Okay, so I'll bring it down. Yeah. Okay. There. Gotex one more. The Gotex. പുതിയതാണ്. Proline, proline. Just hold it. Forceps. Hook. So that this gives the correct length.
Yeah,
okay. Yeah. Pull it up. Earlier I used to put some clip here and then tie it without pushing. So now 2-3 ties like this and then just tighten it further.
Yeah.
Hook. That looks fine. So first was there any PML restriction? I don't remember exactly. Yeah. Which part of PML? I feel there is some restriction of this portion of the section.
Can we clean the camera a bit?
Yeah. Just give me. I think that area PML has some restriction.
Some restriction, yeah.
Yeah, we'll see. Scissors. A hook. we'll check once again.
Yeah,
on
we'll check
center.
the valve. I think it should be all right.
There. But it has become more restrictive there.
Hello, sir.
Yeah.
One question from my side.
Yeah.
In MICS mitral valve repair, which approach do you prefer, transseptal or supraseptal extended?
I don't know. MICS, it will not be possible to go for a supraseptal, no? You go in the same groove.
Okay.
Yeah.
And it is bicoil cannulation or SVC cannulation by IJV or direct
No.
from the same incision cannulation?
No, in MICS, I go for the femoral cannulation, okay? And that is the just femoral venous only I will be putting single cannula most of the time. Only if there is some issue with the drainage part, then we will think about something else, okay? One more jugular. Otherwise, for an ASD and all, we'll put 2 cannulas, one from the other side also. So I think this is not needed, this is not working well. Nice. Nice. Check in there. One second. ഒരു 6 പ്രോബ്ലം bend down. Pardon? Are they? Forceps. I feel that area, a little bit of prolapse is there where I am holding 6-0. So that chorda is very healthy. I think you can see it, no? This chorda is very healthy. So I am going to just reduce the length of it at that level.
At the what? Valve level?
Yeah. long length. Actually, there is a way to measure to what extent you want to reduce the length at this level. I think Professor Sambat Kumar only has described that. You can put silk around both chordae on either side. That is, suppose this is the one, put it into the A3 and P3, where there is a normal one on either side of the chordae which you are going to shorten, and pull them up. Then see how much redundant chordae you have to bring down. Then take the suture accordingly. Yeah. So this is I'm just doing an eyeballing, but I think there's a way to do that without that. There is another fix there. Okay. Yeah. Everything is, whatever we do, it is increasing.
I think we'll release both the sutures and accept what was there initially, Dr. Ekman.
Yeah, I think so.
Now, what about closure of that commissure, that not commissure, that small cleft between P1 and P2, posterior?
This one, no?
Yeah.
Already that is what I was thinking in between, but then anyway, we'll say once, but the mobility, it is holding down actually, it's not moving freely. Okay, so I was thinking, okay, we'll try once.
Yeah.
Yeah.
Because you seem to have a lot of P2.
Yeah.
So
this one will close like forehand, 4-0. So actually, with that idea only, I was looking at this.
Yeah.
Then I found it was not moving that freely. Yeah. Process. ഒരു ഫോറോപ്രോലിൻ എടുത്തേ. ഇതോ ഫോറല്ല 6. Sorry. Arrow holder, backhand.
So you took a secondary cord and...
Yeah, it is, so I thought I will support that area also and see.
Can you clean the...
Yeah, goes. Okay, fill it. One second. I don't know. It's a huge LV. We need a lot of saline every time. Rotor off ആണല്ലോ not taking rotor on അല്ലല്ലോ. That is not getting filled up. The cord is not getting tensed up, no? ഇത് ഇത്രയും പോയിട്ട് എവിടെ പോകുന്നു? ഒട്ടും ആകത്തില്ല. Okay. This solid logic. Okay, ഞാൻ പറയാം. Okay. Yeah. Okay, whatever we are increasing it only. I think that's increasing it. The TML is not coming up, that's the basic problem.
Yeah.
And the AML is, we can see it, so AML is high. Okay. And on. Okay.
Will you consider closing that
commissure?
Yeah.
Yeah, maybe that's the easiest thing to do.
Yeah, because it's a huge 36 ring, no? So it should
or we can okay, just put a forceps proline. There won't be any problem even if we close the computer.
Yeah, absolutely, absolutely. No problem. There won't be any problem.
Yeah. Eda? Camera.
Camera.
Clean the. The PML is not coming up, and I think whatever. Let's get one more. And that may be enough. Let's just check 1 second.
How is it?
There is a central jet now. Probably there's a little bit of rotation. That's why I think that if I knife and another knife. Knife arrow. Forceps. Okay, not there. Switch there. Forcer. Backhand. hook. Forceps, order, forceps. I think probably we must have put 32 only. The PML mobility was not taken into consideration when we sized the valve, no? I think. So, okay, check. Just put this option. 40. It's exactly at that side we are getting it. By 30 second. Question. Cardiac. Cardiatomy up, bend down. Okay, check once again. No, bend off. Okay. And down. And down. Another fill and down. No fill and down. For zero. Okay. Forehand. And we have closed the entire lateral commissure, medial commissure, I feel. A little bit is there, but mostly this. Anything else should have been done? Anything else should have been done? I don't know. I think PML augmentation must have been one thing, and another thing is we should have done a smaller.
Yeah, 32 ring would have been
better. Yeah.
Better. Yeah.
Forceps. Okay. Sometime I try. I think this is not a very good thing to happen.
How does it look? It's a little fudgy camera.
Yeah, no, it's not very comfortable. There will not be very severe or major problem, but still there will be some amount of jet here and there.
Yeah.
I feel the PML mobility is a major issue. Okay, what's scrum time now? Session. 6 minutes. You keep on play this thing ready. Pericardial augmentation. What about going ahead with the pericardial augmentation of the PML? I think rather than just we know that primary problems knife.
Yeah.
Primary problem is the pericardial issue. Means the PML mobility.
Yeah.
I think I'll do that.
There was some secondary chordae which you were looking at to cut, no? Then you decided not to.
But it is not. I think the LV is too much dilated, so everything is just pulling it out, pulling it down. So even actually it was not the. Doesn't look like.
So it's more of tethering rather than.
Forceps. Forceps. Table corching at rotatio. Okay. Okay. Knife. Knife. 11 blade. spots. You see, this PML is going down like this, no?
Yeah.
It is far away from what? Where is which side? 60? Better, better. Good, good. Went down.
Are you going to use the autologous pericardium or bovine pericardium? What's your
No,
plan?
autologous pericardium.
Okay.
Yeah.
And are you going to treat it or just?
No, just plain.
Just plain,
I usually, because in the pediatric group I found like tetralogy and all whatever pericardium we use, when we later reopen for something like say putting a pulmonary valve or something, it looks so good, like it is like a live tissue.
The untreated one.
Yeah, untreated one. Yeah. So I was using that untreated one from the very beginning. So I think
For the aortic root widening, do you treat the pericardium or just?
No. Again, I use the same.
Same,
Yeah.
untreated. Okay.
Yeah. അതിന് 10 mm നീട്ടി തരണം കേട്ടോ. പഠിച്ചിട്ട് just for it. Forceps എടുത്താണ്. Get me forceps. Silk there, silk, number 2 silk. You can prepare one delineator forceps. It's a rough measurement for the
length of pericardium.
Yeah. So. Get me another resuscitation. Or a switch out of that, stay switch. Six next 6. എടുത്ത് വെച്ചല്ലേ 6 6 10. So probably our in the pre-op TE, the assessment part we must have given more attention to the the PML restriction. Okay, even though we were thinking about rheumatic in the first, and then when I saw the valve, I thought it's a mixed matters with some infective endocarditis and all. So that changed the entire plan. That's why. Otherwise, we should have put a smaller size ring. I think it's a fine forceps zero. Long. 6 of fine. So after putting the ring, this is one problem, like you have to take the suture through the leaflet, it becomes a little difficult. Yeah. So when we are incising, we have to go a little away from the
So this 60?
Yeah, 60, 10 mm. 10 mm. Yeah, because larger needle you will find it really difficult to see the area. Six-sided needle holder as forceps and all.
Hello?
Yes, yes.
Did you consider taking out the ring and putting a new ring?
I think we are entering. I thought of about that. Then I thought Medtronic people to give a free ring so that there is another possibility, definitely.
Yeah.
But still, I was thinking like the basic pathology now we are sure that it is a restriction of the PML mobility, no?
Yeah.
Isn't it? So it may be better to
augment it.
Augment it rather than
undersizing it.
Yeah.
So what was the LV dimension before we started? Manjusha?
Manjusha is there. It was 6.9 in the preoperative echo. That's what I remember vague.
Yeah, 7 centimeter.
Yeah, something like that.
So it must have really tethered the PML.
Yeah. So if it is rheumatic and here and there some restriction, we can cut off the secondary chordae and print. Here it's not possible though. And the moment I cut it, you must have seen how far the PML has gone into the LV cavity.
Yeah.
It is not even coming up. Table കുറച്ച് ഇങ്ങോട്ട് തിരിക്കുക towards me. Table towards me.
Okay.
But it's a good case for demonstration because we have seen artificial chordae.
Yeah.
We have seen caudal transfer.
Right.
Yeah. We had seen caudal what do you call it, shortening.
Yeah.
Then PML augmentation. So
almost everything.
Yeah, the whole spectrum. Yeah, one case.
Yeah. No, what I feel is repair is something like some cases will be really easy and you will be off very fast. Yeah. But in some cases when it is difficult, you have to be really patient. You have to, and if you don't do something proper and then come off and then it is going to be a headache again. Yeah. Some cases we accept and come off because we know that it may be alright, or after coming off, okay, it may be a second one. But I think in this case I felt it's not good. Huh?
Yeah.
What was your feeling like, no?
Yeah.
We had to, otherwise we are going to have a significant jet, eccentric jet. Then finally Manjusha will not allow me to leave the theatre.
Yeah. And you have not corrected the basic pathology.
Yeah.
So you'll have to again go back and correct the basic pathology.
Yeah.
But if you're not able to understand what is the pathology, then sometimes I actually just come off bypass and then ask my anesthesiologist, because they have become very good now to see what is a real problem and then go back.
Yeah, that's a very important option. Like finally, if you feel that okay, we are not reaching anywhere, then there's no point in just playing around that. Yeah. Come off, reassess, then we will be more because we have seen the valve once, so we know okay, this is it, and then it will be good.
So initially, when you did that alpheric stitch, there was more because it was not on the corresponding edge.
Yeah, that's what I must have you must have seen the AML little, bending towards the medial commissure area, isn't it? It was getting tethered to that area.
So that is actually the main problem that the MITRAL clip people face.
Yeah.
Yeah, because it is not in the correct, position area. Then it will become more, and then you'll have to put additional clips, and finally ends up in mitral stenosis.
Yeah.
Yeah, but see, if like A2, P2, if it is not at the middle of A2 and P2, actually the MR will remain the same or become worse. Then they will have to put two on the adjacent side, and then gradient, severe gradient. It's happening. It's just So on an average, how many repairs you do in a year? 100? Close to 100? Or?
Yeah, close to 100, yeah. So for maybe my personal experience has approached almost 1,000 now. Yeah. And others like Vinita and Nidish are also, both of them are also doing right now. So Plagia. Then it's time to give one plagia. Ready? One second. Okay, flush plagia. Flush. Flush. Okay. Okay, give. This is okay. Okay, snagger on the snagger on the cardiotony. We're just giving the plagia, just a few minutes. Okay, going well. Okay. What is it? Oh. Okay, fine. The tractor.
How much you gave second dose?
He said 400. It's a 40 kg patient, so 10 ml per kg.
Second dose.
Yeah. Switch on. Forceps, get me forceps. So when we are doing like that also, this area is not at all coming up, no?
Yeah.
So I think that is cis. 6 or 10 forceps. Then the stay at 3, no? 6. Okay. Okay, switch it. Yeah. Camera.
There was a study on CG future, isn't it, Ambaraju? You were part of it, and our center was also, we did some case. Yeah? All Medtronic. Did it get published? Any idea? Yeah.
That was published?
I think Australia and New Zealand meeting. So surprisingly, in that data, majority of patients were ischemic MR.
Oh.
Rheumatic and degenerative, isn't it? No, I think almost 50% were ischemic mitral regurgitation. Ischemic. I think Vinita published your series, isn't it?
Yeah, I think our 4 or 5 year, like 2000, I don't remember, 11 to 15 or 12 to 15, something like that.
Some 400 cases.
Yeah. It was way back.
Yeah.
It is time to review our data now. Long time. This is one of the problems with the medical college type of work, no? Where you are fully held up with morning till night and then some emergency cases. So academics get sometimes publication business is something. Now since our PGs are there, we do get some publications regularly, but still I think. You have a research assistant with you? Or?
You asked me?
Yeah.
Yeah, we have a research coordinator.
What is the qualification that?
No, she is MHA.
MHA, oh, yeah.
Yeah, and she also knows some basic statistics. Like
okay, yeah.
Oh yeah, absolutely. She collects all the papers, then she does all the basic statistics, and even up to she can do up to Cox proportional hazard and yeah, and survival, all those things she do. All the data, then references, collects all the references, makes the tables.
Okay. I think there was one guy with you who even who was doing that ICMR study on say valves, Chitra valves, and it seems that he was traveling to all the southern states to get the data and all. No?
Yeah.
He's still there with you? Or?
No. He got a job in Ireland.
Oh.
Yeah. Now he's in Ireland.
Okay.
He was an ICMR person.
Okay.
So we had some difficulty in collecting some old patients. So he used to travel to all the districts, and he went to all the post offices. But the people who actually helped, it's a little political thing, but actually helped was the CPM area committee.
Okay.
Oh yeah, they were very, very helpful. Yeah, he went to all the district area committee. This one, so they traced most of the patients. Yeah. 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 I actually sent it as an acknowledgement. Then the editor said that you cannot acknowledge a political party. But they were very helpful. Yeah. Indian Journal. Yeah. So we had 19% lost for follow-up. Initially. Then we brought it down to 3.4%. What is that? Number is it? Are you putting your data in Indian ISCTS website or Jaguma?
Yeah, no. We are collecting the data in that old that same software we are using, but now they are not supporting that software, no? Yeah. So we have the data with us, but since they are not supporting, it is just remaining like that. And the government, since they have the e-health scheme, they are not allowing us to have any other software right now to purchase or. So yeah, there is one major issue with us right now. E-health has not reached anywhere, and actually I went to Faridabad AIMS as a representation from the government to see about. I told you, no.
Yeah.
So, but I think they are all becoming almost paperless, no? More than 70% is they have their own software. I think the same one only you also will be using. No?
Yeah, Amrita has a software, Amrita HIS system.
Yeah.
The problem with the Amrita HIS system is that we can put in lot of data, but there are not many good what is called as queries, so it will not answer. Like if you want to say, okay, how many of your patients pre-op atrial fibrillation you operated, then you'll have to manually check.
Oh.
Yeah. So
that is easy. No, once there is data, they can actually.
Yeah. I mean, but we'll have to manually check. That's
okay.
All. And of course, putting the data is also important. No? Some other that did not have operation notes and then. Which one? Yeah, yeah. Can we clean the camera?
Yeah. Cut. Fill. Okay. Let's see. Fill here. Okay. Fill. Okay.
Send off.
Ah. No, one second. Just get me another forceps. Yeah, this thing has gone away. Yeah, just hold it. Yeah. Just give me a forceps. Okay. Hook on it. Yeah. There. There. Forceps. Nothing. Any suction? Can you keep the suction there? Yeah. Somewhere here. Keep it like this. Okay. There's a filling there. Are we going to have some now?
No. Very.
Yeah.
It was hugely dilated LV. No?
That's right, yeah. Still we may need one suture there. Okay. Knife. There. One suture there, or for cerebral. I think that area will put a suture and then come out, right? One.
Yeah.
Small needle, I think. For cerebral, time and
Jayakumar.
Yeah.
So only 3 of you faculty is there? Only 3?
Yeah, right now only 3 are there.
So you will, I mean, that's a heavy load on, workload on all of you?
Yeah,
isn't it?
Yeah, probably after election we will be getting one more person from, because we have vacancy but the government is not filling up, so one person may get transferred soon and then we will have 4. But there is one advantage for our residents because
they get a lot of
post MCH they are doing CABG left and right. All those, fill 1 second.
Registrars, post MCH registrars.
Yeah. 3 of them are there post MCH right now, and
so is it like a compulsory to work or like a?
Now I think the bond part is not there.
Okay.
But still, for them that's a golden opportunity,
Yeah.
to work for some time and gain a lot of experience. Okay, enough. I think that portion we have to close off.
Yeah.
Went down. Very problem with it.
Now the PML is nicely.
Yeah, it is coming up. Yeah. No, otherwise, no. Actually, as you said, the caudal suture was seen, isn't it? The artificial caudal suture was seen. So I was not very happy with the height of the coaptation also.
Yeah.
So that's what I thought. Okay, I will just. Now sometimes without all these switchers putting here, if we just release all these previous switches which you put on the other side, it may come up.
Yeah.
But now again a lot of time, no, I thought I will put a switcher and come out.
Yeah.
So that will be easier for us. It's a big valve, no issues with.
So what is the choice of inotrope in your settings like?
It is like noradrobutamine. They start off.
Okay. For MRs, mitral.
Yeah, if the patient tolerates, they sometimes they put milrinone also, like milrinone or dobutamine, I think.
Okay.
But as a standard, almost all patients they put norad, and then if needed, and dobutamine or milrinone, one of that. Yeah. But suppose you have a severe LV dysfunction patient, and you are taking up, they load milrinone in the pump, okay, and then especially MR or then take it. Yeah.
One thing we have noticed is that even if it's a very sick LV or LV dilatation, and your cross clamp time is prolonged or this one, repairs, I think post-operatively they behave much better.
Yeah. This has become real prolonged clamp. I think I'll accept and go.
I think we should just come off bypass.
Yeah, we'll come off. Yeah.
Because whatever that jet is there, it is like a central kind of a jet.
Yeah.
And there's no.
Yeah, we'll see what is happening with that. Okay. Because the pericardium is there, so I hope it will come and seal it off.
Yeah.
Yeah, if something is there, we'll have a second run. Okay. Yeah. You can start rebalming.
So Jayakumar,
yes,
it's close to 7:20.
Yeah.
So there is a suggestion that we disperse.
Yeah, sure. Yeah.
And we'll meet you in the hotel.
Sure.
Is that okay with you?
That's fine. Tomorrow we will see the echo. Okay.
I mean,
this patient. Yeah.
I mean, we are little, unhappy to leave you.
No issues.
In the OR while we.
No issues. Please go ahead. Because I was also thinking same. Always long time, no. But till, yeah.
Yeah, so what time tomorrow we should assemble back?
No, whatever is what time you are convenient, no, accordingly we'll do that. Because tomorrow, since we have the techno college thing also, I think we will try to finish by lunch. That means
How many cases you are planning tomorrow?
2 or 3, like how it progresses. Like sometimes just like this, if you are getting held up, 2, otherwise 3.
Are you planning any minimally invasive?
Yeah, I have to see the cases tonight and see whether we can go ahead. The only constraint for me tomorrow is we have to be there in Kumaragam by afternoon. So accordingly we will plan, no? Okay?
Yeah. So, so shall we say 8 o'clock tomorrow?
Yeah, sure, yeah.
Is that a good time?
That's good. Yeah, that's fine, yeah.
So thank you. So to recap today's this one, the first case was fibroelastic deficiency, where he put artificial chordae. The second one was AML prolapse, and where he still did the artificial chordae. Third one was A1 prolapse, where he did that rotation plasty.
Right. Yeah.
For the fourth one is this case.
Yeah.
Okay. Nice mixture of cases. Thank you, Jagumar. Give me a big. Yeah.
Thank you so much. Thank you for the patient waiting.